Good morning, everyone. It's about time, so we will go ahead and start. This is Ahmed Al-Rajih, and we have our first speaker is Dr. Brody Scott. He will give a talk about shaping the future in healthcare, the AI revolution in respiratory care. Dr. Brody Scott, the stage all yours.
Thank you so much. Good morning, everybody. Thanks for being here so early and getting us started. All right, we're going to get settled here. So no real conflicts of interest, just some research funding from the AARC, and eventually I'll get that paper published. We're going to go over some general concepts of wrong one. So, clicking the wrong button here, sorry. I want to tell you that I'm going to start out today with something a little bit fun. I want to get a little bit of fun this morning because it's day 3, it's early, I'm the first talk. Everybody's still in the bed except for us. So I want to tell you that I used ChatGPT for this lecture. I actually went to Chat. Does anybody else use ChatGPT or Claude? Okay, so you've done this too. Okay, this is fun. So here's what I did. So I went to ChatGPT and I wrote this just exactly like this. I have to put together a slide deck to use for the use of artificial intelligence in respiratory care. Please act like me. So I gave it instructions. Act like me, putting together a slide deck for an audience of RTs and educators in Saudi Arabia. Then I put in parentheses, I'm not sure if that matters, the location, and show me what you would include. Here's the title. That's what I said. And here's what it said. It says, great title, it says. So good job on that, Hassan. I think you come up with the title. It says, I'll stay in your voice and mindset. So it's getting to know me, right? It's learning me. It says, measured optimism. Because sometimes when ChatGPT writes for me, it's too optimistic, and I don't like, it's just too much. So it says, measured optimism, clinically grounded. It's learning me, always ground this clinically, educator aware, and not hype driven. Getting to know my personality. It says location does matter a bit, though. It corrected me a little bit. And it says regulatory framing, ethics, workforce readiness, but the core content translates well to Saudi Arabia and the Gulf region. That's what it says. And it says the below is exactly what I would include if I were you. So I said, okay. Then I said, I want to show the audience. I want to show the audience what you showed me as a demonstration of how I can use AI, and here's the key word for today, is as a thought partner. Right? It doesn't replace my thoughts. It's a thought partner. So think about that as we move forward. And then I told it, look what I wrote. This is your moment. I'm giving you an audience. So do your thing. Condense your output into a couple of slides, no more than 5. Watch this. All right. I'm stepping up to the podium. And it actually gave me the smiley face. And he said, here's exactly what I want you to show them. 5 tight slides that demonstrate, not explain how AI works as a thought partner in your voice. It's telling me in my voice. You're not showing AI content, you're showing a process. I said, okay. And then here was literally the copy and paste. If you use ChatGPT, you probably recognize how this looks, right? So he says, perfect, below the slide version, the deck that's ready. I said, okay. And it said, slide 1, using AI as a thought partner of a live. On this slide, you can read this verbatim, and it says, the prompt I gave AI, and it's telling me to say this. It's saying you can say, the prompt I gave AI was to act like me, and the audience are respiratory therapists. And it kept going, like this is slide 3. It says, what I did not ask ChatGPT to do. So then I stopped. I said, no. Can you use your voice? I want you, ChatGPT, to talk to the audience in your voice. I'm giving you the audience. So he says, oh, absolutely. Below are 5 slides that are written in my voice. So I said, okay. So this is what it said. It says, I was given a task, but not instructions. I was asked to think like an RT educator, design a talk on AI and respiratory care, consider an international audience, and so on and so forth. And it says, key line, I wasn't asked for answers. I was asked to help think. So again, think about these words as we go forward with AI, because I think AI is scary because we always think it's going to replace us. But I'm going to ask you to rethink this a little bit and think, how can we make it a thought partner? Who are my educators in the room? All right, educators, I'm going to tell you now, I feel like now I have a colleague in my office. Because sometimes I even ask AI to help me create, I've asked AI to help me create assignments that are AI proof. How can I create an assignment where students can't use AI? They have to demonstrate critical thinking. I've had AI help me create that, right? Then it says, I didn't generate slides first. I clarified the audience and context, which it did. I identified what mattered, organized the topics in clinical education and clinical domains, so forth, so on and so forth. It says, I organized thinking. I didn't replace expertise. Slide 3, that my role has limits. It's telling you, I'm telling you, I have limits as AI. I'm not perfect. I'm not replacing you at this point. It says, I was not asked to make clinical decisions. I did not replace evidence or guidelines. I did not decide what is right for patients, and I did not speak instead of a licensed a professional. I support judgment. I do not own it. I said, okay, I like what you're saying. You're definitely speaking what I like you to say. Because I do argue back. I'm like, no, I don't like that, right? And then it says, why this demonstration matters, the same approach we can support. So AI is telling you, so the lecture is being done by AI about AI. It's telling you what it can do. It can help you with lecture and curriculum design. I will tell you that I've actually used it to help me create rubrics. And I don't know, for the educators in the room, pre-AI, rubrics took me a long time. And what I would do is hopefully somebody would let me borrow one I could use. But now I can create the best rubrics in under 5 minutes. I can do simulation development. We're going to talk about simulation again today. Quality improvement work and policy and guideline framing. This is augmentation, not automation. And then finally, this is what AI is telling us. I am a tool, a thinking accelerator, a structure builder, a second set of eyes. And I will tell you that in my practice as an educator and even sometimes as a clinician thinking about things, I do like a second set of eyes. Somebody I can talk to, I can work through, realizing it's a tool, it's really not a human. And then here's what AI tells us. The future doesn't belong to people who use AI. It belongs to people who know when, why, and how to use it, which is what I'm going to argue for today, is that we need to know when to use it, how to use it, why to use it, and we just have to settle on the reality for those of us that are kind of fighting where we're at in history. We have to acknowledge AI's here. We're going to have to adapt. It's here. It's not going away. It's kind of like calculators. They're here, right? We have to learn how to use them. So I was reading through what AI told me, and I said here, this is exactly what I wrote. You can see I literally copied this from the screen. I did not interpret this. I think this is important. Create a slide in English and Arabic that closes with strong ethics-forward message for the audience. I think ethics, the use of AI and ethics is important, right? I think that's a big thing that we have to consider is the ethical use and how we go about that, integrity. And I put in your voice, not mine. Speak directly to the audience. Check yourself for accuracy as I cannot check for you. Which means when you produce something in Arabic, I have no idea if it's right. I will tell you that when it did do this, I used other AI bots. I used other AI and like Gemini and Claude to verify what I'm about to show you. And I think it's correct. So this does make me nervous a little bit, if I'm going to be honest with you. I did not have an Arabic speaker tell me if it was correct. So I said, I agree with you, this is important. Below is a single slide, ready closing slide, written in my voice, speaking directly to the audience. So this is ChatGPT 5.2, speaking directly to with parallel English and Arabic text. I kept the Arabic formal, modern standard. I have no idea what that means. It sounds good to me. I have no idea. And I've checked carefully for accuracy and tone. You can read this verbatim. So this one's good for me. It says, I need to be clear with you. This is, again, in the voice of artificial intelligence. I can assist, I can organize, I can recognize patterns faster than humans, but I do not carry responsibility. You do. Right? That tells us what, obviously it's just the machine spitting out things it wants to say. Right? But think about that for a minute. It does not carry responsibility. We cannot blame ChatGPT or Claude or Gemini or Grok or all the other ones on their output. We have to be careful with that. You do, it says. Ethics in healthcare do not come from algorithms. They come from professionals who understand patients, context, culture, and consequences. If you ever feel tempted to let technology think for you, pause. Don't let it think for you. Your judgment is not a weakness. It is the most important safeguard we have. Use AI to support care, never to replace accountability. And tell me if that's kind of what that says. This guy's shaking his head yes, so I'm a little less nervous at this point in time. Are we good? Is it the same message? What I love about this is this is a true story, I now text my friend. I work with her. She literally just works down the hallway for me. I text her in Mandarin Chinese. I take it to AI. I write the whole message to her, and I send it to her. She writes it back in Mandarin. I interpret it with AI, and it's almost always right. But just think about the power here that we have now to even to communicate, right? And the fact that it's pretty, I didn't change anything. I wouldn't even know what to change, right? But I think this is interesting. So I wanted to do this thought experiment this morning. I could sit here and rattle off a bunch of data about what we know about AI. But the reality is with artificial intelligence, I think we're just in the beginning. I think that we're just starting to understand its power. I think that we have all probably used AI up to this point as like a super Google. Like a super Google, it kind of tells us what we need to know. But I think we can harness the power to make ourselves more efficient. I think that probably with clinical decision support, we're on the precipice of that. It's already starting to use this clinically. We know that this has created some accuracy. But if you've used AI long enough, you've learned it makes mistakes. It says things that aren't true. One time I was on like a Saturday morning like this using AI. Again, I always say as a thought partner. And it kept spitting out incorrect stuff. I said, this is crazy. I literally talked to it like it's a friend. I said, did you not sleep well last night? You need coffee. What's wrong with you? It said, sorry, I can't get myself going this morning. I'm like, wow, that was a very human answer. But I'm like, I feel you. I understand. Sometimes I don't have good mornings too. But it was kind of interesting how I told it to stop with the hallucinations. Like, you're driving me crazy. So, real quick, what is artificial intelligence? So, first of all, let me tell you, I am currently almost done with a book on the right. I do not make money off this book. I do not know Jeff Woods. But for anybody in leadership or just trying to advance your knowledge of AI, I think this is a good book. Again, you may disagree, but I'm finding this to be very interesting. The AI-driven leader. This is a great book. And so Jeff Woods here says, AI is a technology that enables computers and machines to perform tasks that usually require human intelligence, such as learning from experience, solving complex problems, and making decisions. Think of it as a powerful, again, the word tool. It's a tool that we have that augments human potential by automating intelligent behavior. And so basically what you learn is it learns from large amounts of data. And so this slide gives you some idea. And so according to Meta, the Meta platforms like Facebook, one of their models has what they call 15 trillion tokens. And I had a hard time with this language of what exactly is a token. according to that reference, according to them, that's about 200 million books worth of knowledge. So could you imagine having 200 million books worth of knowledge right there at your fingers, right? And so that's what AI is doing. It's learning from what it's being fed into it. It's not, obviously this information is coming from somewhere. So we have AI, what we think about all this base part. We have things like machine learning. You've heard of deep learning, generative AI. And we are currently here at some of these large language models, LLMs, you see, which is like ChatGPT and some of the others. And where we are probably going here are what's called artificial general intelligence, which as when you read in the text of these things, this mimics human behavior physically, cognitively, creatively, intuitively. That's actually not where we're currently at. That's what is being tested as we speak. I don't know what that's going to look like for us. But I wouldn't be surprised if in the future we have little robots or folks coming around here serving us coffee and waters, and we have a full conversation with them when our coffee's too hot or we didn't have enough sugar, and they can go back and get that for us. And we say, does that sound crazy? It does, right? But can I remind those of us that are old enough to remember that we didn't have supercomputers in our pockets every day? Does anybody here old enough to remember when telephones had cables running from them? And I was talking to my daughter this morning on my phone on a video call halfway around the world in real time. So as crazy as a robot bringing you coffee sounds, and you can tell it that you would prefer 2 sugars rather than 1, I think we have to realize 10 years from now, it wouldn't surprise any of us, really, if there was robots walking around here probably listening to our lectures. Will AI bring value? That's a big question we have to ask ourselves. Will it make us more productive? It could. I actually, when I looked at the resources to come up with the slide, there were no question marks. It was a statement. But you can see the point of AI, we can try to make our operations more efficient. We can stop doing tasks of analysis, maybe mundane tasks. We can have that do it for us. And it could possibly make things more valuable for us in the long run. But I think it's about productivity. Again, as an educator, some days I sit in my office all day rewriting rubrics, trying to rethink schedules, trying to figure out which students I got to send to this clinical site and that clinical site. I can take that same type of model, tell AI what I'm trying to get it to do, and it literally spits it out in seconds. And sometimes accurately and very accurately, right? So I can get much more efficient use of my time. According to Woods, here are our risks. The textbook I'm reading, here are our risks. Job displacement. Woods argues that right now, 6 out of 10 jobs currently today did not exist in 1940. Things will change, right? So job displacement, maybe jobs will just look different at some point in time. There are biases. Remember that AI is only as smart as the information that it's fed. Think about that. It's only as smart as the information that it has. So it may show biases based on how it's been taught. Right? It's not like you. It's not open-minded. It knows what it knows. There are hallucinations. And listen, students, please don't do this. Don't write a paper using AI. You know why? It makes up references that aren't real, and we can see them. If you listen, I know about every paper that Dean Hess has written. And when you write a paper and it says Hess, D, and it has a neonatal paper on it, I know that wasn't Dean Hess because I don't write those papers either. Right? So be careful. It hallucinates, makes it up. It looks real, and it looks really convincing. Not real. There are concerns about privacy. As the associate dean of AI says in my hospital, if you put something into ChatGPT or Claude or any of these public forums, make sure that information that you put in there was something you'd be willing to share on a billboard. Because it's not private. It's a public thing, right? Be careful. relationships with machines instead of humans. The author of that book actually even talked about him hearing his daughter as a practicing with AI, having a full conversation with AI. And it made him concerned because he's like, this AI voice is only going to lead this conversation in the direction that it's trained, or maybe even too affirming, where him as a father would be like, no, that's not a good idea. So we got to be careful with that. Abdicating thought leadership, or perhaps even the end of the world. Who knows? Maybe says, you guys aren't doing any good. We got to stop, right? Let's not go that way. Let's be more positive this morning. So where are we today? There are certainly some scientific papers. So I went to PubMed, I went to Google Scholar, and I went to all kinds of places to look up artificial intelligence in respiratory care. And I kept finding 0, 0, 0. And it's almost hard to find 0 in anything anymore. So then I changed from respiratory care to critical care, close. And I found you can find papers. One I wrote here, I said, as soon as I created this slide, I felt like it was old because things are just evolving all the time, right? But you can see there's actually a scoping review, which means there's several papers out there in artificial intelligence and the management of patient ventilator asynchronous, which we have a poster here at this conference about this. And I won't spend too much time here, but basically they said AI holds potential in managing patient ventilator asynchronous by enabling real-time detection, improved predictions, and personal strategies. I want to focus on that second line. However, significant challenges remain, particularly the need for multi-center validation. And I think that's where we got to put our brains at this point, is we got to think as clinicians, we need to validate these instruments. We need to validate this stuff to make sure that we can trust it. That's where I'm currently uncomfortable. I don't know how much I can trust it at this point. But at the same time, I also have to realize that we are, as humans, aren't great. And we have evidence here at this conference that we are not great also at recognizing patient ventilator asynchronous. So how about let's use some technology to improve our patient care? That paper, by the way, was from 2025. This one was 2024. It's a cool read. It's from an anesthesia journal. Past, present, and future. And the future is AI and machine learning for individualized care. Think about the power one of these days when we can have AI work as a thought partner with us about this patient's mechanical power. Which one of the issues that this patient have is more likely going to increase the likelihood of ventilator-induced lung injury? That's going to be a very powerful model for us soon, once we understand what to do with it. Use of artificial intelligence in critical care. Opportunities. I'll be quick here, but it's clinical decision support. Supporting us at the bedside to make better decisions. Not having it tell us what to do. Perhaps having it as a thought partner to improve the care of the individual patient, rather than trying to make everybody go to the same algorithm all the time. I think that's exciting. I think it's exciting that we don't have to make everybody under the exact same protocol for the individual issues. But this can be, while we can all be lung protective, what is it exactly about this patient's characteristics or phenotypes how we can improve better care, and having clinical decision support to support us in thinking about what to do. Nursing is dealing with this as well. I like the nursing spin on this. They're advocating for the ethical integration of it. Nursing is hitting this from an ethical side too. They say we need nurses to advocate for ethical integration. Autonomy, think we can align with autonomy, benefits, and so on and so forth to make sure we're respecting the patient. And I also believe that's where we need to be as well. And I'll speed up just to wrap up. But some of these, and by the way, I'm happy to email this article to you. My email's at the end of this. I'm happy to send that way you can have the references. But you can see there's all kinds of things out there, and I'll speed up, but they're giving examples. Like, look, using arterial waveforms to predict shock phenotypes, endotracheal tube detection, early ARDS prediction, all kinds of things that we'll be able to use in order to think our way through these complex issues for the individual patient. Not replacing us, thinking alongside of us, right? I think that's the key. I think we got to make sure that it's a thought partner, not thought replacer. Let's not let it replace. Let's let it add to our knowledge, and which means we're still going to have to understand human physiology. Final thoughts. We cannot run from AI. It's here. Sorry. It's here. We can't run from it. Right? The data, we need data literacy and AI fluency, teaching how to question AI outputs. I think we're learning that right now, to be honest with you. All of us have thought AI was awesome until it wasn't, until it gave you something wrong. We need to learn how to question it. We got to, as clinicians, emphasize physiology, not memorization. That way we can work through the problems from a physiologic standpoint. And prepare graduates. I do believe we need to start preparing graduates for AI-enabled environments. We need to teach our young students how to use it, not to circumvent learning, but to use it as a thought partner, to use it alongside their critical thinking. But the reality, educators, we have to learn that too. We can't teach what we don't know. And I'm wrapping up. So, I do believe this is an opportunity for us in terms of partnering together from every country to figure out how to do this. It's an opportunity to shape standards. If RTs don't engage in what AI can do for us, others will define it for us, right? We need to be on the leadership of this. AI is here. We need to adapt. It is a tool, not a threat. Don't look at it as a threat. It's a thought tool. We are a perfect place for it. We're data rich. We're AI ready. Lots of technology. And the future belongs to clinicians who engage early with AI and thoughtfully. And I just wanted to point out there is a great poster out in the audience here. And I asked them to include their photo and their picture here. That I thought this was great. They're using training models of how to detect patient ventilator asynchronies. I ask all of you at some point in the break to walk up there and take a look at that. There's a young student here who's in high school working on this, which I think is an amazing program here in the kingdom. And so I applaud everybody on this team. And with that, feel free to email me. I'm happy to send you these slides. Thank you very much.
Thank you so much, Dr. Brody, for this interesting topic. And because we are running out of the time, so please, the audience, feel free to email Dr. Brody for anything, or you may catch up with him later. So our next speaker is Professor Dean Hess. He is the editor of the Respiratory Care Report and the managing editor for the Respiratory Care as well. Today he will deliver a talk about what is evidence-based respiratory care. Professor Dean, the stage is yours.
Well, thank you for that introduction, and good morning, everyone. It's my pleasure to be here this morning and talk about evidence-based respiratory care and how we can incorporate that into our practice. These are my disclosures. So some of you may be asking, why do I need to have an evidence-based practice? I'm a good clinician. I have lots of experience. Doesn't my experience count for anything? And I would direct you to this quote from many years ago, where the author, Michael Crichton, wrote, "In my clinical experience," is a phrase that usually introduces a statement of rank prejudice or bias. The information that follows it cannot be checked, nor has it been subjected to any analysis other than some vague tally of the speaker's memory. The biases of eminent men, and I would add, and women, are still biases. So think about this the next time that someone asks you a question in the clinical area and you respond by saying, well, it has been my experience. Or think about the time that you ask someone else a question and they preface their response with, in my clinical experience. So think about this quote. And remember that experiences, which are anecdotes, the plural of anecdote or experience is not data. So just because you have more and more and more experience doesn't necessarily mean that you have data to support your practice. So then what is evidence-based respiratory care? So evidence-based respiratory care is the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. So evidence-based practice is individualized patient care. And there are three parts to evidence-based respiratory care. It begins with your clinical expertise. It begins with your expertise as a clinician. It combines that with the best clinical evidence, which is science, which comes from research, and it combines that with the patient's values and expectations. So I want to point out here that evidence-based practice does not devalue you as a clinician, and it does not devalue the patient's values and expectations. And it's important to remember that the best evidence changes over time. So the evidence that I use today in my practice is much different than the evidence that I used 25 or 30 or 40 years ago in my practice. So I said that evidence-based practice begins with your expertise as a clinician, your individual clinical expertise. This is based on your clinical skills and your clinical judgment. This is where evidence-based practice begins. We need to know the right patient, the right time, the right place, the right dose, and the right resources to apply the best evidence. Your clinical expertise is used to determine whether the evidence applies to the unique physiology of an individual patient. So evidence-based practice is individualized patient care. This is a wise use of the best evidence. So evidence-based practice, as I've said I think a few times already, does not devalue clinical expertise, but we need to remember that clinical expertise is not the same as clinical experience. So clinical experience is doing the same thing over and over and over again. And if you do that same thing over and over and over again, and you're doing it absolutely wrong, that is not clinical expertise. So there's a difference then between expertise and experience. The best clinical evidence comes from science, it comes from data, it comes from research studies. This is real clinical research among patients, and this replaces, the best clinical evidence replaces accepted treatments with new ones that are more powerful, more efficacious, and safer. We need to remember the patient's values and expectations as we implement evidence-based respiratory care. So for example, we all know that patients with COPD exacerbation do better if we use non-invasive ventilation. But maybe your patient does not want that mask to be strapped onto their face. So we need to consider the patient's values and expectations. You may believe that a patient with asthma is best served by using pressurized metered dose inhalers with a spacer, but your patient may value their therapy being administered by nebulizer. So we need to consider the patient's values and expectations. And this is particularly important when the certainty of evidence is low. And for many of the things that we do in respiratory care, the certainty of evidence is low, and thus it becomes important for us to consider the patient's values and expectations. We also need to recognize that not all evidence is created equally. There is a hierarchy of evidence. And at the top of that hierarchy are randomized controlled trials and systematic reviews and meta-analyses of randomized controlled trials. Lower on the hierarchy of evidence are observational studies, physiologic studies like bench studies and animal studies, and at the bottom, at the very bottom of the hierarchy are unsystematic clinical observations, which is clinical experience. So there's always evidence I would submit to you. So I don't like to hear somebody say, there is no evidence for this, or there is no evidence for something else. There's always evidence, but sometimes that evidence only exists at a low level. We don't have randomized controlled trials. We don't have observational studies. We don't have physiologic studies. So we have to rely on lower levels of evidence. Experience is evidence, but it is low-level evidence. It is the lowest on the hierarchy. And it's important to recognize that opinion is never evidence. So if when someone tells you that it is their opinion that this should be your practice, that is not evidence. Opinion is not evidence. Experience is evidence. However, it is low-level evidence, and we always have evidence. So we should not say there is no evidence. Maybe the only evidence you have is your experience of the last patient who you cared for. Now, there was a time, not too many years ago, in my field, mechanical ventilation, where we would have said, we really don't have any high-level randomized controlled trials to inform our evidence. But over the last 20 or 25 years, we have been accumulating randomized controlled trials to inform the practice of mechanical ventilation in adults. We have positive randomized controlled trials like low tidal volume ventilation that you've already heard about in this meeting. We have positive trials about the use of non-invasive ventilation for COPD exacerbations. But we also have negative trials like high-frequency oscillatory ventilation for adult ARDS. We've heard about that already. We'll hear more about that, I'm sure, as this day unfolds. We have negative trials related to proportional assist ventilation, to closed-loop ventilation. So I think it's important then that when we have trials that show, that are negative, that do not show that some of these therapies are effective, perhaps we should abandon those therapies. On the other hand, if we have randomized controlled trials that show that low tidal volumes are better than high tidal volumes, we need to adopt that into our practice. So randomized controlled trials, highest level of evidence. But you might say, well, do we always need a randomized controlled trial for everything that we do? And I would suggest to you that we do not. So we don't need a randomized controlled trial to prove that mechanical ventilation is useful for patients with severe ARDS, or that antibiotics are helpful for bacterial pneumonia, or that bronchodilators are helpful for acute asthma. Now we need randomized controlled trials to show whether low tidal volumes are better than high tidal volumes, which antibiotic is the best, which bronchodilator is the best, and so forth. But we don't need a randomized controlled trial to show that bronchodilators help for asthma. Just as we do not need a randomized controlled trial to show that you are more likely to survive jumping out of an airplane if you use a parachute than if you do not. So sometimes we need to use our common sense for some of these things. And we need to remember that just because something is unproven, that doesn't mean it's wrong. But it also doesn't mean that it's right. And absence of proof is not proof of absence. And just because something is new doesn't necessarily mean that it is better. And I'll come back to this in my last lecture of the afternoon and talk a little bit more about how just because something comes out and it's new, that doesn't mean it's better. And the example I'll use this afternoon are ventilator modes. So just because there's a new ventilator mode doesn't necessarily mean that that's better than what we are doing now. But the truth of the matter is, we often need to rely on lower levels of evidence. And the reason why we need to rely on lower levels of evidence is because we don't have a randomized controlled trial to inform everything that we do as respiratory therapists. So sometimes we have to rely on surrogate outcomes, like physiology, like making the blood gases better, making the FEV1 better, surrogate outcomes rather than mortality, because we don't have a randomized controlled trial related to mortality. But I will point out here, and again I'll come back to this afternoon, we need to be careful about using surrogate outcomes, because we have examples in the field of mechanical ventilation about how some approaches to mechanical ventilation make the blood gases better, but it makes it more likely that you will not survive your course of mechanical ventilation. So be careful about surrogate outcomes, because sometimes we can be fooled. We need to remember that observational studies that are not randomized controlled trials, cannot establish causality. So cause and effect can only be studied through randomized controlled trials. We need to be careful about experience, about how we have always done things. And this gets back to the quote that I provided on one of my first slides. So we can have a lot of experience doing things over and over and over again in the same way and doing them absolutely wrong. So that is not expertise. So we need to be careful about experience. I think we need to be particularly careful when the only way that our colleagues can justify what they are teaching is based on their experience. Or you should be suspicious of me if the only way that I can justify something that I am suggesting to you is based on my experience. And then opinion, as I said earlier, is never evidence. So if someone says it's been my personal opinion, well, that is not evidence. And the opinion, even of experts, is often wrong. So we need to acknowledge when we're using low-level evidence. So many times we do not have low-level evidence to inform our practice, but we need to recognize that. We need to recognize that we are basing our practice on lower levels of evidence, maybe because we don't have high level of evidence like randomized controlled trials, but we need to abandon lower levels of evidence when higher level evidence becomes available. So when the randomized controlled trial comes out, like the AARC study that says in patients with ARDS, 6 mLs per kilogram is better than 12 mLs per kilogram of tidal volume with respect to mortality, we should start using lower tidal volume ventilation. And sometimes we are very slow to adopt new evidence into our practice. Again, I'll come back to that this afternoon in my final lecture of the day and show that after years after the AARC study, many times low tidal volume ventilation still has not been adopted. So when a convincing RCT is published, we need to pay attention to that and abandon lower levels of evidence. And I would say that the history of respiratory therapy and respiratory care is littered with therapies that we once thought were useful, but have been proven not effective. So you can look down through this list. I'm not going to read it to you. You can ask yourself the question, how many of these therapies that are no longer supported by evidence am I still incorporating into my practice? So when new evidence becomes available, we need to abandon our previous practice. But again, as I pointed out often, we only have low level of evidence. We do not have randomized controlled trials for everything that we do, and we will never have randomized controlled trials for everything that we do. And you might argue we don't need randomized controlled trials for everything that we do. So what should be some of our considerations when we are faced with low-level evidence? Well, we need to think about what is the rationale for the therapy. Does it make sense? Does it make clinical sense based upon physiology, for example, that we would use this therapy? We need to evaluate the potential for adverse effects of the therapy. So if it's low-level evidence and there is a high risk of adverse effects, we need to think twice about adopting that therapy. We need to think about the cost of therapy. And we should not be driven always by how much it costs or how much we can save. But if there is a high-cost therapy that has little potential for benefit, we need to think twice about that therapy. And then when we have low-level evidence, again, we need to inquire about patients' values. Patients' values and preferences become very important when we are faced with low-level evidence. Now, some of you may say, well, what about the physiology? So if I'm going to practice in an evidence-based way, does that mean that I ignore all that I've learned about physiology? And I would say absolutely not. And in fact, for myself, I am a big believer in evidence-based practice, but I love physiology. I give lectures on respiratory physiology. Physiology does rank low on the hierarchy of evidence. However, it is important to explain mechanisms. So the mechanisms to explain why there is a lower mortality with low tidal volume ventilation, that's all physiology. So we can't forget about the physiology. Physiology is the foundation for evidence. You cannot have an evidence-based practice without appreciating the physiology. We also, though, need to remember that although the evidence changes over time, the physiology does not. It takes thousands of years to change the physiology. It takes only a decade, maybe, to change the evidence. So I think that evidence and physiology actually work hand in hand to be a good clinician practicing in an evidence-based way means that you have to understand the underlying physiology. You can't just skip the physiology and go right to the evidence. So then I think that all of us should practice evidence-based respiratory care, but we do need to remember the physiology when we do that. So with that, I will stop, and I think I got us maybe almost right back on time.
Yes. Thank you so much,
Thank you.
Prof. Dean Hurst.
So now allow me to introduce Carl Hinkson, who's going to talk today about the healer, burnout respiratory care, recognize and response and recover. So the stage is all yours. Thank you so much.
All right. Well, welcome. I do have slides, right? Well, I'm happy to present again. I will be talking about burnout in respiratory therapists. So I'm going to skip a couple of slides. So oh, there it is. Great. So my disclosures are I am the immediate past president of the AARC, and I'm the current chair of the foundation. So the objectives for this presentation is to define burnout, what is compassion fatigue, moral distress. We're going to discuss the rates of burnout in the RT community. And finally, I want to discuss some strategies for respiratory therapist wellness. So why am I talking to you as an expert? Well, at the start of COVID, I was part of a group of other respiratory therapists interested in burnout, and we started doing a series of surveys on the prevalence of burnout, leadership issues, and what made great leaders and stuff. And I can kind of see the list of publications we did over the 5 years, which was pretty prolific. And that kind of gives me the kind of moral authority to talk to you about this topic. So what is burnout? There's a clinical definition that you can use, but I tend to focus on a more what I would consider a more realistic worldview definition. But for the clinical definition, it is described by 3 dimensions: emotional exhaustion, depersonalization, and a diminished sense of personal accomplishment. Now, I kind of pull this into a non-clinical definition. Is burnout is the sensation where you've lost the ability to experience positive emotions. This is where something good happens to you, and the good vibes last for about 5 minutes, and then that dark cloud comes back over you. And this is where you see when you have those coworkers that they're always sort of like, if you've ever watched Winnie the Pooh, there's this character in Winnie the Pooh, Eeyore, who always says things like, "It'll never work, it's the worst day ever." And that's the kind of the colleagues we see that have that burnout. There's always just like, no matter how good the day is, they're kind of a little bit negative about it. So what contributes to burnout? What causes someone to experience burnout? I will say that there are a myriad of factors that will roll into what makes an individual burned out. And it's never just one thing. I want you to start to understand that burnout is not a singular focus or a singular event or issue that happens to an individual. It is a series of factors that they experience repeatedly over time that diminishes their ability to face the day. And we're going to divide what causes burnout into 2 separate buckets. There's going to be the individual factors. One is their ability for self-care. Do they take care of themselves? Do they exercise? Do they follow the rituals that help them recenter themselves? Do they have meaning in their work? When they go to work, are they just going through the motions? Do they get any joy out of it? Is their why in their work experienced? Or are they just showing up, turning knobs, slinging nets? Do they have work-life balance? Now, in leadership, we talk a lot about work-life balance, but I'm going to argue work-life balance just doesn't mean I actually have time off. It means when I have time off, I leave work at work. I don't bring work home with me. A lot of us leaders experience this challenge is that with devices like this, work follows us. Work followed me across the world. I've been messaging my manager of rehab, helping him come up with a compensation package for a supervisor he's going to pitch to. And he needed me to advise him on this, which I was doing this morning when I woke up. So work-life balance means you have found some monicum of this goes in this bucket, this goes in this bucket, and when I'm over here, I don't think about this. And the other part of individuals is, do you have supportive relationships? If you don't have somebody or a group of people in your life that are supportive of you, that you can go to in dark times, then these are indofactuals that will contribute to burnout. And then we have our institutional factors. We have our work environments, our work culture, our work schedule. How does that impact our lives? Do I work in an environment that is very toxic? Or do I work in an environment where I show up and my coworkers are constantly complaining, but never doing anything to make the situation better? They complain about management. They complain about the physicians. They complain about the patients. They complain about the families. Well, if you're in that type of environment, it gets pretty exhausting. You can have challenges with limited growth opportunities. I experienced this at a facility that I worked at where I realized because I was not a nurse, I would have nowhere to go in the organization. So I left the organization. Also, do you have the ability to participate in decision makings? Do other people make policies for respiratory care? I get really frustrated when I'm informed by nursing that they have made a decision that impacts my department, but my people and I had no opportunity to give input on that decision. At times I say, well, you didn't involve me, So you're not making that decision. Let's have a conversation. But if you work in an environment where that's not an option, then that will contribute. And then we have our peer support. Do you have colleagues at work that you can confide in, vent to? And is there opportunities to cultivate well-being? Does your organization support your wellness? These are factors that will contribute to your well-being at work. But I want to reemphasize that your well-being and burnout is not a static thing, it's dynamic. It changes over time. And we represent this with sort of the concept of a fuel tank or a gas tank. There are things that add to your resilience, where you're full of resilience. With support and resources, if you're full, you have the capacity to face demands. Your stress is reduced, your well-being, your physical health, and you have increased motivation when your wellness tank is at full. But with stressors, it can be drugged down to empty. And when it's drugged down to empty, when bad things happen that triggers your fight and flight response, it gives you physiologic stress. We know stress causes inflammation in your body. Inflammation causes bad things to happen chronically. And then you start having physical illnesses, and then the mental toll can kind of drag you down. So you want to work in an environment where you're having gas added to your tank rather than having it completely withdrawn. So what is the impact of burnout? Burnout causes a series of cascade effects to individuals that if left untreated, can be pretty catastrophic in extreme cases. We know that depression and anxiety are early starters, can lead to sleep disturbances. How many have woken up in the middle of the night about something that happened at work? Sometimes I've actually had dreams about missing meetings, and then I wake up and said that I actually one time woke up and looked for the meeting on my calendar. Because I was like, well, I missed a meeting, and there was no meeting. I dreamed it. Will lead to poor health. If left untreated, your stress will spill onto others. You will start to react to your relationships, and that can break some relationships and damage relationships with your family, with your friends, because who wants to be around somebody who's fried all the time? And with your spouse as well. Also can lead to ways to self-medicate. So alcohol is pretty common in the United States because it's pretty available. Drug use is also a continuous problem. And when these people start to self-medicate, they're starting to lose the ability to healthily deal with these issues. It can lead to premature retirement or job loss. As people get pretty burned out and frustrated, at some point they decide, I need a change in environment, and that's what they move on to something else. And in very extreme cases, it can lead to suicide. This was an actual article I pulled out during the pandemic. A respiratory therapist did commit suicide. There were actually more than we'd like to admit, healthcare providers who committed suicide during the pandemic because they were just completely stressed out from it. So what are the consequences of burnout on the healthcare system? We know that there's patient care impact. We know that a burnout harms the culture of safety. People start paying less attention to those details that we need to provide quality care. In the research, it shows that RNs are nearly 3 times as likely to make medications errors if they're burned out because they're not paying attention anymore. The depersonalization, the emotional exhaustion, is taking that toll. They're just not paying attention. It doesn't matter as much to them anymore. We know we have lowered adherence to infection control practices. You begin to care less because nothing good happens to you at work. What happens to the healthcare system? In one study, it was estimated that burnout amongst physicians costs the U.S. healthcare system nearly $4 billion annually. And that's through decreased productivity, so I'm not seeing as many patients, I'm not doing as many procedures, and that cascades out to the nursing staff, to respiratory therapists, to all of the allied health. And it's always associated with higher turnover and the associated costs with high turnover. Because when you hire a new employee, well, you have to train that employee. And it's not just that. When I have an individual leave, my talent acquisition group has to go and post a job description. We have to spend time hiring that person. Then my HR department has to onboard that person, and that takes a certain amount of time. So with higher turnover, that comes with increased costs. And if your staff and your colleagues are burned out, and that turnover turns, that increases the cost to the healthcare system. So this is a graphic from one of our publications, or one of our authors' publications, that kind of looks at this dynamic. And so at the bottom here we have burnout. This is when you're kind of completely fried and done with work and life. And then at the top here we have resilience, which many people believe is kind of the opposite of burnout. If you're resilient, then you can deal with the issues as they come, and it doesn't take an emotional toll. You can still be personally as strong afterwards. And again, we have our personal factors that go into this with cultivating well-being, self-care, nurturing positive emotions, maintaining social connectives, supportive relationships, work-life balance, and meaning at work. And then we have our organizational factors. So this is how I manage my stress, and this is how my work environment manages my stress. So it's got prioritizing well-being amongst employees, approachable and authentic leadership, participation in decision-making. And this is where I say, for the organizational factors, I, as a leader, want to create an environment for my staff where they feel like they make things happen rather than things happen to them. As an employee, I'd like my leaders to make my work experience a place where I make things happen rather than things happen to me. So it doesn't matter what your role is in the organization. You want to have your work environments where I go to work, and I go to work because I get to make things happen. I make patients better. I make my work environment better for my staff. They get to implement a protocol that they developed themselves. They get to present a research poster that they worked on. Some other key terms, if you're not familiar with, I'd like to familiarize you with, is moral distress. Moral distress is knowing what the right thing to do is, but unable to achieve it due to an organizational constraint. Or if you are a healthcare worker and your personal standards are at odds with the organizational standards. So this would be common if you're working in an environment where they set the staffing levels very tight and you don't feel like you have the time to provide the care that you would like to patients. We experienced a lot of this moral distress during the pandemic in the United States, where we had severe staffing shortages, and it was just not possible to get to all the patients. And so moral distress hits every single, as I learned during the pandemic, profession in healthcare. It looks like one thing to us as respiratory therapists, it looks like something else to a CT tech or an echo tech. I had a great conversation with an echo tech where I understood from their report, moral distress to them was not being able to scan all the patients in a single shift, because they always felt that last patient that they didn't get to scan was the one that had the heart defect that needed the diagnosis. And so when they would leave at the day, knowing they didn't get to all the patients, they were worried about, was there an undiagnosed cardiac issue that I didn't get to in time? Moral injury. Moral injury is suffering a relatedly cognitive, is cognitively related to compassion fatigue. It's suffering experience from a traumatic effect. What I say moral injury is when your moral distress leads to actually seeing a bad outcome. A patient extubated themselves because you didn't have the staffing to maintain observation. The classic example we'll use from the United States is we had several experiences, and including me personally, where a patient died in the ER waiting room waiting for care due to constraints. Resilience, again, this is the psychological health, allowing an individual to cope and recover from these psychological insults. So something bad happens to you, you can still carry on with life just as you did before, and you're not sort of detrimentally hit by it. Compassion fatigue. Compassion fatigue is the cost of caring for others through illness, and it kind of mirrors post-traumatic stress disorder. What I will say is if you have compassion fatigue, eventually that can lead to burnout if you don't adjust some of your behaviors. And this is an actual quote I got from a colleague on a text change one day. Just to let everyone know, I'm on my 3rd terminal extubation, killing it. So that is what we describe as dark humor in healthcare. And was he actually having a good day? No. He was having a rough day because a 3rd terminal extubation, withdrawing of compassionate care, is something very challenging for respiratory therapists. We don't often talk about it. I worked at a hospital where we just, out of curiosity, put up a sheet and said, how many terminal extubations, withdrawals as life support, did we do in 1 month? And we did over 100. And it's very difficult for respiratory therapists who experience that all the time for not to experience some compassion fatigue from that. So physical manifestations of compassion fatigue, you can have some symptoms related to the memories, hyperarousal, or you start to get numb to the impact of it. You walk in a very traumatic situation and you kind of just, over there. Or you start to avoid similar situations and the other, like you avoid that type of patient care again, or you just are just exhausted all the time. Okay, so that's burnout, compassion fatigue, those psychological states. Now, what is the rates of burnout in the RT community? In our initial survey that we published in 2021, almost 80% of the RTs reported that people in my work environment are burned out. And 10% of the RTs in this study reported that they were severely burned out. And what we did a lot of analysis on what the burned out RTs were like, and they worked more hours. They were the ones who worked a lot of hours. They were the ones who worked a lot in the ICU. There was some experience of those who were working a lot in the community hospital. So why is a community hospital more at risk than a big hospital? Think fewer resources, fewer RTs to back you up. And we found that they were more likely to work without adequate staffing and unable to complete their work assignments. They weren't able to get to all the patients that they wanted to see. They were unable to provide the care that they wanted to provide. We found no differences in degree, their job role, whether they had a long commute, short commute, whether they worked days or nights, whether they were male or female, or what their race was. When we compared the prevalence of respiratory therapist burnout amongst the other healthcare professions, we found that respiratory therapists are one of the most highest burned out professions, with healthcare interns being a little more burned out, but we were on par with critical care RNs, mid-level providers, and pharmacists. And we know that MD burnout is high, but I think what I would point out for this particular study, when you're comparing the ophthalmologist to the critical care physician, you're going to find different levels of burnout. So we did some qualitative review. We took, we sent out a series of comments and took that back. We found these 5 buckets or themes, if you will, in our qualitative review. Staffing. I'm feeling burned out because I'm always working. Staffing is so poor. Workload. Every time I have a call a supervisor for help because there's more than one thing going on at the same time. So I've got, if I'm working in the NICU, I've got a preemie on a jet over here, and then I just had twins show up over here. I can't be at 2 places at once. I have to call for help all the time. I go home with the weight of work on my heart, and these are all quotes from the survey we did. I have personal responsibility when something goes wrong with our patients, and every time I come in, I feel like we're being asked to do more and more with less. Lack of effective leadership, and this is an important theme that we'll go into a little bit more. Management seems disconnected from the needs or the abilities of staff. Decisions are made that do not favor the bedside staff or retention. And that's a pretty common theme right now if you talk to U.S. healthcare workers, especially with the political turmoil in the United States right now. A lot of decisions are being made to adjust to the big beautiful bill, or H.R. 1, that are challenging us in the healthcare environment. A lack of respect. RTs are not valued by the media covering COVID-19. This was, a challenge for a lot of respiratory therapists in the United States. They felt like there was so much praise being given to physicians and nurses, where we were also on the front line and we were getting some love, but not what we felt like was enough. So this is a graph that I want you to kind of take in. And this is sort of like the dynamics of how burnout impacts you. It's not static, it's dynamic. It can change day to day, it can change, improve slowly over time, it can worsen slowly over time. And you have workload factors, your staffing, your autonomy. Can you make your own decisions, or do people always make decisions for you? Are you required to do low-value tasks? Do you have to go deliver incentives spirometry to post-operative patients, which you know is a waste of time? Protocol use. Are you allowed to use protocols? Emotional stressors. You have a lot of end-of-life care, moral distress? Do you have compassion fatigue? What's your workload culture like? Do you work in a good environment where there's team dynamics? You have strong leadership? And then there's leader support. Do they provide you psychological safety? Is there adequate recognition and appreciation? And do you have a voice in how decisions are made? And one thing is compensation equity is I want to make sure that I'm paid fairly amongst my peers, but not only that, I want to be paid fairly amongst the hospitals that are in my community. And then in the center of that is you, and that's your personal resilience, and that's your self-care and your mindfulness. So what are some positive leadership papers? We published a paper on how the impact of leadership impacted burnout. And what we found is that staff who had a positive view of their leadership had less burnout than the staff that had a negative view of their leadership. And there were several characteristics that went into that. Is that the managers who had positive views, they were more available at predictable times, so the staff knew when they could access them. The leaders provided them feedback. It was positive, useful, and frequent, which means they knew how they were doing in their role. They weren't left to guess, am I doing a good job?
2 minutes.
Doing a bad job. Organizational culture, is there lack of growth, control over schedule? Is burnout contagious? Actually, yes, it appears that it is contagious. Some of the research shows that in others that if you are working in an environment that is burned out, you're likely to be more burned out. So strategies for wellness focus on addressing these issues. So organizational and workload, do you have autonomy? So if you're working in a hospital that doesn't have therapist-driven protocols, steering committees, you need to implement those. You need to make sure that you have evidence-based staffing models so staff feel like that their lives are not controlled by their schedules, that they have some input, some ability to get time off, provide career ladders, and eliminate unnecessary work. Make the work that they're doing valued so that they're feeling like they're making things happen. From a leadership, you want an executive presence, transformational and authentic leadership. You want leaders that care about their staff. And I'm going to skip through this, but I'm going to be short on time, is that leadership qualities that we look for, not all good clinicians make good leaders. Good leaders have integrity, work ethic, they're empathy and compassionate, they're honest with their staff, but their technical skills are not as necessarily important. And for what makes most accomplishment, self-initiated projects, providing interdepartmental education, these are characteristics that leaders decided would make good future leaders. So also to address burnout is you want to have positive emotions. Positive emotions push back on those negative emotions. So this is the thing is you have to think about what are 3 good things that happened to me today. Mindful gratification rituals. And then you need to do preventative self-care, which is exercise. That is very useful. You want to spend time with your friends. And you want to have mindful practices like putting away your cell phone, making sure you have an enjoyable hobby that makes you forget about work so that you decompress. Self-care is very important. I always put this slide in here because I think it's important. If somebody gets to a certain point in burnout, they need treatment. If it's depression or other issues, you need to start SSRIs. You need to start putting them in mental counseling to arrest the further decline. And sometimes they have to go to new environments. Again, I want to remind this, it's dynamic, it's not static. You need to do things that increase your resilience to counteract the things that lead to decrease your resilience and lead to burnout. And so that's my summary slide. think I rolled it in on time?
Yes.
All right. Thank you, everyone.
Okay, thank you so much for this amazing talk. Now, allow me to welcome Dana Evans, the Respiratory Regional Director and the President of American Association for Respiratory Care. Dana is going to talk about the future of respiratory care profession and the role of the AARC. So the stage is all yours. Thank you.
Thank you so much. Good morning, everyone. I'm back. Just wait for my slides. Yes? Okay, wonderful. So I'm going to spend the next 24 minutes talking about some of the activities of the American Association for Respiratory Care and the future of the profession and how we hope we can play a role in really, truly impacting the way our profession will be moving forward. So I have no disclosures to share, except that I am the president of the AARC, so I'll be talking about all the things that directly relate to that. In my paid role, they mentioned I'm the regional director of respiratory care for Advocate Health, so a lot of this impacts me directly at work as well. Some of the objectives we'll cover today, like I said, I'm hoping we'll be able to get to some of the strategic initiatives associated with the AARC, some of the educational initiatives, mentorship support that we have available, as well as some of the academic and research-related things that kind of tee off of what Dean was talking about as well. But maybe I'll just start talking. I think I will. All right. So I want to talk a little bit about the AARC Board of Directors. So just to start with that, for those of you that are not aware, the American Association for Respiratory Care is a worldwide organization. All of you are members now, yes? Hassan? Yes, yes. So welcome to the AARC. We're so excited to have you. You join a family of about 42,000 respiratory therapists around the globe. And it grants you access to lots and lots of educational resources and support. There are several board members in the room with you today, and I'm excited to have them here for this work. Do you need my USB stick? You need it? Brady, it's in my bag. It's in my little black bag. I trust you. You can dig through my purse. There you go. Thank you, sir. So one of the first things you're going to notice as new members of the AARC, and when you log into your account, is you have access to a program called AARC Connect. Has anyone heard of that? Yes. So AARC Connect is our version of social media. It directly connects you with all of the other members of the American Association for Respiratory Care and affords you the opportunity to connect, collaborate, network, share ideas, opinions, talk through issues together to advance your practice and to grow as a respiratory therapist. So we have communities of all sorts, right on down to RTs that ride motorcycles, which is maybe my favorite one. But there are communities for adult critical care, neonatal and pediatric care, leadership, diagnostics, pulmonary function, hospital-based clinical educators. Oh, there I am, hospital-based clinical educators, things of that ilk as well. Let's jump to where I'm at. We'll go back to this. Oh, yes, this. So I took this picture yesterday of AARC Connect, but it's very much available to you. Has anybody accessed AARC Connect ever? A few of you, yes. So it should be very helpful. I use this all the time. This is my personal screen. You can see my name on it. Delighted to share with you that over the last year, we've really worked to continue to expand the types of communities that are available on AARC Connect, really in response to member requests and needs. So we launched one for clinical educators about 1.5 years ago because we have a lot of great resources for formal faculty that work at academic institutions, which is outstanding. But what we heard from our members was that we needed more resources available to people who are educators in the hospital. Is anyone in the room responsible for hospital-based education? A few of you, yeah. So it's hard to do, and you need a community to connect with as well. And so we've created that for you in the clinical educator community. New graduate residency programs are very popular in the U.S., so we've created a community for that as well. We have a community just for students. Where are the students? Yes. There is a community called Next Gen RT, Students to Scrubs. I strongly encourage you to join this group. These are students just like you from all over the world, and it gives you a chance to connect and collaborate with your peers from other countries as well. We have access to a mentor hub. We've talked a lot about finding a mentor and support for that. If you log in to Connect, at the top here, there's the mentor hub. You can pop into the mentor hub, and you can put in all of your information to ask for a mentor, or if you would like to be a mentor, you can put in your information and let folks know what kind of mentor you would be, and then they pair you with someone with similar interests, needs, or career goals so you can help support them on that journey. So strongly encourage you guys to hop into this if you don't have access when you get access into the Mentor Hub. All right, I want to go back just for a moment. So the AARC has been around since 1947, long time. It started as the American Association for Inhalation Therapy, actually, and has changed as the profession has changed. But I want to show you, this is your AARC Board of Directors. We're very excited to have some of these folks here in the room with us. And an army, if you will, of volunteers. So these are all the volunteer-led committees for the AARC working on many projects, a lot of which I'm going to talk about with you here today. But I really just show this to folks so that you understand that there is not any one person that does this work. It really is our community lifting each other up and supporting each other in these efforts. In our executive office, led by Dan Garrett, many of you have met him now, is crucial in advancing this work as well. All righty. Another program that we have that is directly dedicated to emerging leaders, mentorship, education, and support is our Emerging Leaders Program. Very proud of this program. We just graduated our second cohort in Phoenix a couple months ago. This is a 9-month program where individuals from education and leadership are paired with mentors for a very formal, about 9-month mentorship program where they work closely with that mentor to help them achieve a career goal, as well as attend coursework, didactic training, get to connect with these individuals over that period of time. I mention that to you because the applications for this are open right now and close on Monday, if you're interested in this. Skip that. Okay, so I'm going to talk a little bit about the future. I've mentioned this a couple times this week, is the advanced practice respiratory therapist. I hope you have all heard those words before this week, but certainly this week if you hadn't. So what's an APRT? This is right from the AARC website. An APRT is an advanced practice respiratory therapist qualified by academic and clinical education to provide diagnosis, treatment, and care of respiratory diseases, which is a fancy way of saying physician extender, right? Physician extender. Here's a little bit of a snippet from the scope of practice for this care. Right now, there's only one program in the world that offers education for APRT, and that's the Ohio State University. However, there are more coming. We do expect the University of North Carolina, Charlotte to open a program very soon. KU Medical Center in Kansas is also working to open a program. We're expecting things to start popping up quite a bit in the next few years, so folks will have more opportunity to join this new profession. We do have 2 working advanced practice respiratory therapists, so I always introduce people to Mindy and Dan. Mindy and Dan work at the VA, the Veterans Administration Hospital in Maryland in the U.S. Mindy works in she has a couple clinics that she runs. She has a tobacco cessation clinic, a pulmonary clinic, and she works in the sleep lab. She sees patients all the time and is really doing a lot to reduce the wait time for our military veterans to get the care that they need. And Dan was the second APRT that joined her there, and he also runs his own sleep clinic. So we're very proud of them. The AARC is very, very focused on helping to elevate, grow, and advance the advanced practice respiratory therapist. So a couple years ago, our board of directors approved a grant for $250,000 US to support the growth of brand new programs. So as I mentioned, UNC Charlotte and KU Medical Center are taking advantage of those grants so they can have faculty release time to build these programs. And then in the states, we're working on licensure as well. We have a couple of states that have taken advantage of our grants to support legislative efforts so that the respiratory therapists that want to be APRTs can be licensed to do so. So you heard us talk about the world needs more respiratory therapists. There's a respiratory therapy shortage. There's also a shortage of respiratory therapy educators. You need more respiratory therapy educators to be able to launch more programs, to have more respiratory therapists come out. So under the leadership of past President Hinkson, we held an RT Education Summit that really looked at what are the barriers to advancing education, what are the barriers to getting a baccalaureate degree, master's degree, and terminal degree, because you have to have those advanced degrees to qualify to be a faculty member. So we have 4 committees that are actively looking at these barriers and working to address them. And these are the goals that came out of this. Some of this is very U.S. specific, but really the overarching goal here is to create opportunities and pathways for respiratory therapists to advance their education and achieve their own educational goals. Again, so that they're more ready and academically prepared to teach in respiratory therapy programs so that we can have more respiratory therapists. One of the things that is very, very important, and I think you will all agree, is that our physician partners, our nursing colleagues, know who respiratory therapists are, right? We're always seeking to gain their respect, to have a collegial relationship with them, and to collaborate. And first and foremost is for them to understand who we are, what we do, and the value we bring to our patients. So we've worked to advance our relationship with these organizations to do just that. Many of them are physician organizations, including some of them that are actually around, academic counselors, right? You cannot be something you've never heard of. Your high school counselor isn't going to advise you to do something they've never heard of, so we've been working to increase the knowledge base of our American school counselors in this space as well. The U.S. has a program called HOSA. I mention this only to say we've been working very hard at the middle school and high school level to elevate awareness of what respiratory therapy is. I think this is something that can be recreated in the kingdom, but really focusing on getting in there, visiting with students, teaching them about our profession, all the opportunities that are available to them as respiratory therapists. Again, you can't be something you've never heard of, so again, trying to elevate the awareness to close that gap that we've talked about this week because of the national shortage that we're facing of respiratory therapists, and I know you're seeing here in the kingdom as well. Okay, I want to talk about APEX. So respiratory therapy departments that have achieved a high level of distinction, right? These are things that the AARC wants to incentivize, to promote, and to celebrate. And APEX is an award program, a recognition program that we have in place that does just that. Who's heard of APEX? Yeah, I bet you have. Wonderful. Okay, so earning APEX recognition is really intended to do just what it says on this slide, to distinguish your department, your facility, your academic program for achieving excellence in professional development, evidence-based care, patient safety, and quality. And a few years ago, the AARC Board of Directors approved adding a whole host of categories, including international acute care organizations. So I'm delighted to tell you that there are only 3 organizations in the whole world outside of the U.S. that have achieved APEX recognition, and they're all right here in the kingdom. So I just want to pause and congratulate all of you for that. I think that's incredible. Yeah, congratulations. I don't know that any of these folks are in the room. I have seen some of them, but in 25, we recognized the Ministry of the National Guard of Health Affairs, King Abdulaziz Medical City, and King Fahad Medical City. And then this year, King Faisal Specialist Hospital and Research Center received recognition. So kudos to these teams and the work that they're doing to elevate evidence-based practice and professional development for their departments. And I know, just from having conversations, that there are many more departments in the kingdom that could achieve this recognition. So if you want to do that, talk to me later. Okay, so Dean talked a lot about evidence-based care, and we've talked a lot about that overall this week and the importance of having evidence-based medicine, evidence-based research. So I want to talk about the way that the AARC supports that, and generally it's through clinical practice guidelines and the development of those, through our scientific journals, and of course through all the high-quality education that we provide on a regular basis to our members. If you are not aware, the AARC has a lot of clinical practice guidelines. What you see in front of you is a list of the most recent ones, not all of them. There's a QR code that will take you right to the full list. So you can find our clinical practice guidelines. They're all published in the Respiratory Care Journal, but we also publish them right on the AARC website because they are open access. It's important to us that these are available to everyone, everywhere, from the day that they're published. So they're open access for that reason, because we know that the evidence matters and using the evidence matters, so we want you to have access to that. So pop over there and have a peek at that. The most recent ones we've published are associated, the groups have published around patient ventilator assessment, spontaneous breathing trials for the liberation from mechanical ventilation of adult patients, and in partnership with Polisi, we just released a pediatric critical asthma, CPG. And the work isn't done. We have a staff member in Dr. Linda Goodfellow who works on this tirelessly, leading lots and lots of teams, focused on building and creating new clinical practice guidelines. And so what you see in front of you are the list of current teams that are actively working to develop new clinical practice guidelines to be published as soon as they're done. I told you that we just published one on patient ventilator assessment and spontaneous breathing trials. Those teams are continuing to work because they had more questions to be answered. So we're expecting additional CPG publications from them, which is really exciting. As I said, those are the three most recently published ones. So the journal. Who has been in the Respiratory Care Journal? I hope I would see like every hand in the room. Don't make Dean cry. Right? So the Respiratory Care Journal is our flagship journal. It is the pinnacle for publication in the respiratory care profession. We're very proud of it. Recently, we transitioned to a new publisher. So you'll see some changes in the way you access articles to the Respiratory Care Journal, but still remains our flagship journal. The best part about what I'm about to tell you is that the Respiratory Care Journal has become so popular. People like Dean will tell you that we get more submissions than they can publish. So under his leadership, a couple months ago, we published our first edition of our new journal, Respiratory Care Reports. So Respiratory Care Reports is a sister now publication of the journal. This one is completely open access. It is available to you as members, but it is also open access. And the very first articles from Respiratory Care Reports were published in November. There's a QR code right to their website for your awareness. This is going to be a little bit different than what you may see in the journal, as they'll accept case reports and other things that the journal has been unable to publish for a while now. So very excited about this. Again, this is our way to increase access for respiratory therapists who are doing research to be published and to disseminate that really important work so that we can continue to have access to the best available evidence for the care we provide to our patients, as well as the way we lead our teams, the way we educate our students, and things like that. So education. Education really is the heart and the cornerstone of what the AARC does in supporting the professional development of our respiratory therapists and our members across the world. We have 2 big events every single year. These are the dates and locations for our 2026 event. Summer Forum is an educational symposium designed expressly for respiratory care leaders and respiratory care educators. So this is a great space for you to come and learn about all things in those areas of care, but also to connect, collaborate, and network with other educators and leaders from all over the place. And then, of course, our flagship event every single year is AARC Congress. This year it'll be held in New Orleans. So education. Not everyone can fly across the world and get education, so we do have the availability for teaching opportunities and learning opportunities on demand and live virtually through the AARC University. So with your membership, you get access to this full cadre of educational resources and programmatic content. Again, both live events and on-demand events. So lots of things in there, so you can find education on asthma, neopeds, leadership, research, education, really you name it, pulmonary function testing, it's all in there for you on demand when you want to view it, and then also live events as well. And we're in the process of working on the creation and rollout of some micro-credentialing opportunities so that through the taking of several courses in one area of expertise, you can obtain a certificate and a micro-credential in that space to demonstrate that you have done that additional training. So keep your eyes peeled for that. I think we'll see the first ones roll out this year. I also want to just briefly mention leadership grand rounds. A lot of leaders in the room this week. Every single Thursday, or every single month, on the 3rd Thursday of the month, we have a program called Leadership Grand Rounds. This is a non-CRC event, but really is focused on development of leadership skills. You can go on the website and you can register for that. I think it's on the homepage actually right now. This month's event is being brought to us by our AARC President-elect, Joel Brown, and he'll be talking about artificial intelligence. So we're excited about that. Now you're all members, so that's exciting. I love this slide because it kind of really nicely highlights all the amazing opportunities that are available to you as AARC members, including education, discounts to educational events and resources, including our Safe and Effective Staffing Guide, which is around productivity measurement, networking opportunities through Connect, and of course there are educational offerings as well, professional recognition like Apex, access to our journals, and lots of tools and resources. So I encourage you, when your membership comes through, hop on the website and start digging around. I'm confident there are things that will help you on the continuum of your professional journey and support you in the work that you're doing. Okay. Do not expect you to read this. This is the new AARC strategic plan for 2026 through 2028. I put this very busy slide up just so you can see all of the volume of the incredible work that's happening at the national level for the AARC and to support respiratory care globally. I just want to highlight that really what we're focused on are these 4 pillars. These are our guiding principles for the next few years in the work that we'll be doing to engage. Engage really means engaging with you, growing our membership, growing the opportunities and resources available to you, and creating opportunities for you to connect and engage with each other. To elevate, to increase awareness of respiratory therapy in the United States and globally, to elevate the profession of respiratory care as a whole, and to expand the impact and influence of the work that we do. To advocate, so some of this is legislative, but really to advocate through health policy and legislation to support the respiratory therapist, and of course, to continue to provide exceptional, high-quality education that advances and develops our workforce. Really with the goal of increasing membership, increasing output from research and research grants, increasing advocacy, driving policy change that really impacts access to respiratory care, getting more graduates from programs to get more people in our departments, and increasing the number of departments that qualify for APEX designation. So that high quality, evidence-based, very teammate-focused work to qualify for APEX recognition. Whoopsie. And that's all I have. Thank you so much for letting me join you today and this week. It's been a true honor to be here with you, and I'm just so grateful for that opportunity. So thank you.
Thank you, President Evans, for final morning session talk. Thank you all the morning speakers. Now we will go for a break. We need to be back at 10:15, please. When you have time, please stop at the abstracts. There are so many good abstracts up there. See you 10:15. Thank you very much.
Good morning, ladies and gentlemen. We will start our session now. I would like to welcome to the stage Mr. Thomas Pirano. He will be presenting about individualized PEEP versus PEEP table. What does the evidence tell us? Welcome.
Thank you. Okay, this is a very exciting topic for me. As I mentioned yesterday, or actually 2 days ago, mechanical ventilation is my passion, and PEEP, of course, is one of those things that has remained the elusive setting. We still don't know how to set PEEP, even though it's been available for more than 60 years now. These are my disclosures, nothing absolutely related to this presentation. So PEEP FiO2 tables. I'll start with PEEP FiO2 tables and then move into individualized PEEP options. A table basically of PEEP levels recommended for the level of FiO2 that the patient requires. I'm going to assume everyone in the room is familiar with a PEEP FiO2 table. We're not only taught in school about these tables, but they're also the #1 thing utilized in mechanical ventilation protocols, I would say globally. They're also very commonly used in research studies to guide clinicians' choices of PEEP. It's often the standard approach for control groups in studies that are testing alternate ways of setting PEEP. So it's become this gold standard, regardless of whether or not it's the best way to set PEEP. It's become the gold standard at which we compare all other new techniques of setting PEEP. Low PEEP FiO2 tables have been recommended for mild ARDS, and high PEEP FiO2 tables have been recommended for moderate to severe ARDS. However, those recommendations and those guidelines have altered or changed over the years, and I'll talk about that. So here's an example of a clinical application. An adult patient is intubated for hypoxemic respiratory failure and placed on the ventilator with the following settings: tidal volume of 450 mils, and this is 6 mils per kilogram of predicted body weight, a respiratory rate of 20, and an FiO2 of 70. Now, depending on which PEEP FiO2 table you choose, if you choose the low PEEP FiO2 table, you would start them on a PEEP of 10. If you started with a high PEEP FiO2 table, you would have them on a PEEP of 20 centimeters of water. How many people would set their patient on a PEEP of 20 right after intubation? Show of hands. How many would put them on a PEEP of 10, probably? How many would put them on a PEEP of 5? I see some hands. Interestingly, this is actually what the data shows. There was a large epidemiology study done a few years back now called the LungSafe study, led by Giacomo Bellani, and they looked at over 50 countries and over 500 ICUs, and they looked at the practice of setting PEEP. And I just want to point out that these areas here, 50%, 60%, and 70% FiO2 would require PEEPs of 10 and up to 12 in the low PEEP FiO2 table. And I've drawn a line along 10, and you can see that they're not getting an average of people setting a PEEP of 10 until they're on 80% FiO2. So despite it being written in most protocols and most people will follow things like a low PEEP FiO2 table, we are still scared to set PEEPs at 10 centimeters of water or higher. So it's often a reasonable initial level of PEEP. So I'm not against PEEP FiO2 tables, and I'm not here to tell you that you shouldn't use them at all. I'm just saying that they offer a reasonable starting point. It's an easy approach to protocolize PEEP, particularly in mechanical ventilation protocols or medical directives. It provides some form of individualization because it's suggesting that if your patient needs this much FiO2, then you should titrate your PEEP upwards towards this level, or downwards if you're weaning. So it does perform some bit of individualization. However, it does assume that one size fits all. Every patient who needs 60 or 70% FiO2 will not tolerate or require the same level of PEEP. Some may need even more PEEP. So it ignores pathophysiology, so it ignores recruitment potential, shunt, or over-distension potential, and many patients are not maintained on that suggested level, as I demonstrated by looking at the LungSafe data. So we have outcome studies looking at these PEEP FiO2 tables. First off, low versus high PEEP FiO2 tables. We have low FiO2 and PEEP tables against a higher PEEP strategy where they increase PEEP to a maximum plateau of 28 centimeters of water, and I'll talk about that in a moment. We have low PEEP FiO2 tables versus transpulmonary pressure. We have high PEEP FiO2 tables versus transpulmonary pressure. We have low PEEP FiO2 table versus best compliance after a recruitment maneuver, and low PEEP FiO2 tables versus electrical impedance tomography. This one, unfortunately, only used EIT once in their study, so I don't even like including it in this list. However, all of these studies found that there is no difference in mortality when you compare either of these two strategies against each other. However, I will point out that the EXPRESS trial, which was a trial performed in France, the idea of increasing PEEP until your plateau pressure is 28, this one did result in a reduced duration of mechanical ventilation and duration of organ failure. I think it has more to do with how they weaned PEEP than anything. So let's say the PEEP was 12 or 14 on a certain day. Each day they would do a PEEP challenge. So they would decrease the PEEP to 8 and basically wait and see if the patient tolerates it. And this is important because I have clinically seen patients when I've used EIT, where when we optimize PEEP on day 1, the very next day, they may become a very different patient, particularly if they've had significant fluid diuresis in the last 24 hours. The required PEEP becomes very different. So this immediate challenge, it's almost like doing an SBT from whatever setting somebody's on. It's like doing a PEEP SBT. You're just doing a challenge to see whether or not the patient can tolerate lower PEEP. And I think that's why the patients got off the ventilator faster in this study. Now, when it comes to recommendations, we have updated ARDS guidelines from both the ATS and the ESICM guidelines that were published. And I just want to point out that an optimal strategy is unknown, and you should probably select a strategy that is tailored to clinical expertise. And then the ESICM guidelines have mentioned that they basically can no longer make a recommendation for or against PEEP using high versus low. So previous guidelines suggested using a higher PEEP FiO2 strategy, particularly the table, if you have moderate to severe ARDS. As more and more data comes through, they're not strongly recommending this, and now what's happening is that anytime you make a conditional recommendation, as more and more evidence grows, it may weaken the strength of your opinion, or it may strengthen it. And so far, as time goes on, it's sort of weakening this suggestion, so we really still don't know which is the best approach for each patient. But they also are unable to make a recommendation for or against PEEP titration primarily based on respiratory mechanics, so looking at best compliance, for example, when compared to a PEEP FiO2 strategy using a table. So despite the limitations of PEEP FiO2 tables, they do provide a good starting level of PEEP. However, some people have argued that we have already had good recommendations for ways of starting PEEP. This is sometimes coined the Gattinoni method, which is essentially if you have mild ARDS, perhaps starting at a very mild level of PEEP, 5 to 10, moderate ARDS, 10 to 15, and severe ARDS, 15 to 20. And for this method, starting at the lower value is preferred to ensure that you first assess the hemodynamic response of the patient when setting this PEEP level. Now, another thing that has been included in the guidelines for both the ATS and the ESICM guidelines is that they are recognizing that none of the included RCTs, I had that whole list of studies that had compared high versus low PEEP studies or PEEP tables, or high versus low PEEP tables or PEEP tables versus other techniques, none of them have assessed the recruitability potential of the patient prior to randomizing them to a strategy. And this is important because if you compare patients with a low PEEP FiO2 table and a high PEEP FiO2 table, you will get some patients who absolutely thrive on a higher PEEP strategy because they have a significant amount of recruitment potential. Whereas you'll have some patients, if they don't have recruitment potential, that application of higher PEEP will be extremely injurious to the lungs and will worsen lung injury. So, and on the opposite end, you'll have patients who will thrive on a low PEEP FiO2 strategy because they don't have recruitment potential. But for those patients who have significant recruitment potential, keeping them on that lower level of PEEP also could be injurious with alveolar collapse and repetitive opening and closing of the alveoli. So perhaps what we need to do in future studies is first integrate some sort of recruitment test or some sort of recruitment potential test pre-randomization to determine or to stratify patients into which strategies they should receive. And I'll talk about a study that is almost in completion that is doing exactly that. So some common techniques for individualizing PEEP titration. We have the decremental PEEP titration. I remember the first time I learned about decremental PEEP titration was an article in Respiratory Care years ago. It was actually, I would argue, the first mechanical ventilation study that I had read from start to finish. I knew about ARDSNet, but I didn't bother to read the study. I was just taught that this is what we do now. But this was the first study that I read, and it was in Respiratory Care, which is why I have a sort of soft spot for Respiratory Care, because it was the first time I realized that people are publishing this stuff. This is a journal for respiratory therapists, and I didn't even know that this paper or this study existed, it was actually handed to me by a critical care fellow. And I can tell you that within 24 hours, I became an AARC member of reading that paper. Because I wanted access to this journal. And Dean Hess's name was all over this journal, so I was very excited to do that. Now, decremental PEEP titration essentially can use best compliance, or more recently, it utilizes electrical impedance tomography if you have the device, and I'll talk about these two individually in terms of what the evidence says. Transpulmonary pressure using an esophageal pressure probe. Monitoring driving pressure is another option for setting PEEP, and assessing recruitment potential to determine whether you use a higher or lower PEEP strategy has also been recommended for individualization. Now, the decremental PEEP titration usually involves first a recruitment maneuver, which traditionally we would do sustained inflation, and then we learn that it's better tolerated for a patient to use a gradual increase in PEEP using a fixed driving pressure. At least in the preclinical studies, we found that this was very effective and very nice. However, when this protocol here, so after recruitment, coming down in steps, depending on your protocol, 30 seconds up to 2 or 3 minutes at each PEEP step. You decrease PEEP slowly, and then you monitor compliance over time, and then at the end you would typically re-recruit and then put them on the optimal PEEP based on compliance. The largest trial to date, over 1,200 patients, they did utilize an aggressive recruitment strategy. In fact, the maximum pressure they started with in the initial part of the study or the initial phase was up to 60 centimeters of water of pressure to recruit the lung. After 3 patients died of a cardiac arrest, they lowered that pressure down to 50. There was no significant difference in mortality after that in terms of using the 50. But overall, this study showed higher mortality using this strategy. So this decremental PEEP trial and setting PEEP based on optimum compliance was actually, I wrote a protocol in our hospital after the decremental PEEP trial paper. I wrote a protocol on how to do that. And then years later, when the evidence comes out, I'm like, okay, we need to really evaluate that we're doing this safely. And people argue that it was the recruitment strategy prior to doing the PEEP titration that probably impacted the outcomes. Some people argue that post recruitment and management, they were very, very strict on tidal volume, and I've seen screenshots of the trends over time of patients that were being ventilated where there's significant breath stacking. So whether or not they were managed well after the fact is questionable, but regardless, we don't have strong evidence for this. Now, electrical impedance tomography is a very cool technology. Does anyone use this, has used this clinically here? Okay, so there's some parts of the world it's still not taking off, and I'd argue that in many parts of the world it's not taking off mostly because of cost. It is a pricey device, but what it does is it puts a band of electrodes around the chest, and you see in real time ventilation going through the lungs. And what you can do is actually titrate PEEP. So using this strategy of a decremental PEEP trial, what it does is actually map out, starting at this PEEP. Now, there are some assumptions. It assumes at the highest level of PEEP that you have 0 collapse. This is not true, but this becomes the reference point, and it assumes at your lowest PEEP level that you have 0 overdistension. Again, it's an assumption. It's just because your 2 reference points become 0. And what it does is, as you do a decremental PEEP trial, it maps out the improvement in compliance as you drop PEEP. So that's a worsening of compliance that gets better as you lower PEEP. And then as you lower PEEP, there's a worsening of compliance that can also happen in other regions of the lung. So this is collapse. The green is collapse, and the blue is overdistension. And where they recommend setting PEEP is at the crossing point where you compromise overdistension and collapse. I'm going to quote the late Luciano Gattinoni right now. I went to a presentation once, and he said, there is no such thing as optimal PEEP. PEEP is always a compromise. And this is true, because you have areas of the lung that are already open and will remain open, and any increase in end expiratory lung volume in those areas has the potential for overdistension, while you try to open up areas that are collapsed. So this is one method to try to balance the effects of this compromise. Now, one of the things that I utilized prior to doing this decremental PEEP trial, because I just mentioned there was a negative study doing a decremental PEEP trial, so you don't want to keep patients on a high level of PEEP for 1 to 2 minutes, and let's say that this is the safest PEEP for them down here. Think about all of the ventilation you're doing up here is potentially injurious. So what I used to do clinically is I would do a quick recruitment test with EIT where you select their clinical PEEP setting. I increase PEEP by 4 for 1 minute. I increase PEEP by 4 for 1 more minute, and then I go back to clinical settings and I analyze. This is an example of a patient where the blue is the compliance win when you compare the lower PEEP to the higher PEEP. This patient was highly recruitable, very recruitable patient. This one over here, when I compare the lower and higher PEEP tables, the amount of improvement in compliance is only 4% improvement, but I have a 24% loss in compliance. This is a patient who was non-PEEP responsive. That patient we immediately proned. This patient was managed successfully with PEEP, with higher levels of PEEP. Now, there's also some discussion as whether or not we should target the compromise, because the question is, if we're compromising, what if compliance is worse, or what if overdistension is worse? Maybe we don't need to compromise. Maybe if overdistension is worse, we should tolerate a little bit more collapse, or if collapse is worse, maybe we should tolerate a little bit more overdistension. In this porcine model, it's an animal study, they actually found that if you allow a little bit more collapse, the animals did not do very well. In fact, many of the animals died of hemodynamic compromise, basically cardiac failure. So they suggest that in a highly recruitable model, it might be better to target less collapse and a little bit more overdistension, or at least the crossing point, but never lower than that. Now, electrical impedance tomography, there are a number of studies out there. I would argue that the methods of these randomized trials are not sufficient to come up with an opinion on whether or not they can save lives. Many of the studies would use EIT on day 1 and then use a PEEP table after that, which to me doesn't tell me how to utilize EIT to set PEEP, except initial PEEP. But as I told you earlier, within 24 hours, your patient could be a very different patient and require very different levels of PEEP. But this systematic review and meta-analysis did find that after titrating PEEP according to electrical impedance tomography, patients ended up with better compliance, lower mechanical power, and lower driving pressure. Now, esophageal pressure. How many have used esophageal pressure manometry or transpulmonary pressure in their ICU? Few Americans down here. So again, maybe not a very popular technique here. It involves inserting an esophageal balloon catheter that sits in the lower third of the esophagus behind the heart. The typical placement in an adult patient is around 35 to 40 centimeters of distance. And it's used as a surrogate for pleural pressure. And this pleural pressure is used to calculate transpulmonary pressure. You can either have it integrated right on your ventilator where it subtracts esophageal pressure from airway pressure to give you a transpulmonary pressure waveform, and transpulmonary pressure is the true distending pressure of the lung. You could have a standalone device. This is one by a company called FluxMed, or you can have a catheter simply connected to a transducer to your ICU monitor. The one challenge over here is that you need to convert the millimeters of mercury on the ICU monitor to centimeters of water to properly determine what to do with it. Now, to explain this concept of transpulmonary pressure, I made a video about, I want to say 16 years ago now. It was around 2010 that I made this video, and it explains the concept for those who haven't done it. If I have, in this example, I have a test lung being ventilated with PEEP of 6, and I'm just ventilating on top of that. But outside of this, I'm simulating pleural pressure with a CPAP machine. So I have CPAP out here pressurizing the pleural pressure space of 6, and you might think, I thought pleural pressure is negative. Well, when you sedate and or paralyze a patient, lie them flat on a bed, we have positive pleural pressure, particularly more positive in the dorsal lung regions. So let's assume that the CPAP out here represents that elevated pleural pressure of 6 centimeters of water, but I'm ventilating with a PEEP of 6. Notice how my lung is not having any trouble staying inflated, but I'm going to take that pleural pressure and I'm going to increase the pleural pressure to 12. So now the pressure outside of the lung is higher than the PEEP inside of the lung. As soon as I turn it up to 12, this test lung can no longer stay inflated at end exhalation. So how do I counteract that? The idea with esophageal pressure is that if you turn the PEEP to match the pressure outside of the lung should be inflated. Now, I will acknowledge that lungs are not one big floppy alveoli. We obviously have pleural pressure gradients, but this just demonstrates the concept that if we know pleural pressure is elevated, we need to sort of combat that with PEEP in order to keep the lungs inflated. Now, having said that, the largest trial to date using this technique, comparing it to a high PEEP FiO2 table, found no difference in outcomes. They used a pleural pressure table. So the demonstration I just gave you where the pleural pressure was 12 and my PEEP was 12, that would be a transpulmonary pressure at end exhalation of 0. But they had a sort of an FiO2 table that if you were on 80% FiO2, you would target +4 or +5. So you would increase PEEP slightly more than what would be required just to match the pleural pressure. However, they found no difference in any patient outcome compared to the high or low PEEP table. According to the high PEEP table, they did a previous study with less patients comparing the low PEEP table, and they found a trend towards benefit using esophageal pressure, but when they compared it to, but they also found that patients ended up with higher PEEPs. So they said, okay, if they end up with higher PEEPs, maybe we should compare it to a high PEEP table, and they found no difference. But in a post-analysis, which as Dean mentioned, sometimes these interesting findings that they report afterwards, they need to then further test that, because this is interesting. They found that patients that were within ±2 of end expiratory transpulmonary pressure with their PEEP did better than those who were outside of that range. So this had a mortality benefit. But they need to restudy this. So in fact, they are. It's not going to be called EPVENT3, it's called the PREVENT-VILI study, and they are looking at targeting transpulmonary pressure at end exhalation to target this for setting PEEP, and then they're using driving pressure to determine the safety of ventilation on top of this PEEP. Now, I will mention that there are some nice retrospective studies comparing a retrospective cohort to basically a new protocol, this lung rescue team, which I believe is out of your hospital, Dean, but your name's not on here, so maybe you were already retired. But this is led by Lorenzo Berra, and this basically, they integrated a bunch of monitoring with obese patients. So whether it was electrical impedance tomography or transpulmonary pressure using an esophageal catheter, when they compared how patients that met this criteria of obesity prior to implementing this lung rescue group, you can see the mortality level near 40%, which is pretty standard for ARDS when you look at the data. And you can see such a different mortality in these patients, which I used to argue because we used to have many obese patients that we put esophageal balloons in, and I used to call these patients when they would come in with ARDS, I would say this is pseudo or fake ARDS. They just needed the appropriate amount of PEEP. And I think this probably represents the fact that when you optimize PEEP in these patients and give them the appropriate level of PEEP, they're in a different category of patient, really. Now, driving pressure, it's often referred to as the ratio between tidal volume delivered and the compliance of the lung. I won't get through the calculation, but essentially it's plateau pressure minus PEEP. There's a study that was published showing driving pressure more than 15 was associated with poor outcomes. There is currently no randomized trial comparing this, but this is a nice paper, again, published in 2020 by Serena Sahetia in respiratory care, showing a potential protocol for adjusting PEEP based on driving pressure, which I think is a nice, elegant, and simple method. You increase PEEP by 4, you measure driving pressure. Did your driving pressure stay the same? Okay, great. Then it says basically decrease PEEP by 2 and just stop there. If your driving pressure went up, this is probably bad, return to prior PEEP. Does your PEEP equal current? Yes. If that's the case, then you would actually decrease PEEP and see if it improves your driving pressure. So it really just lets you work around adjusting your PEEP to ensure that driving pressure is at a minimal level. Now,
2 minutes.
Okay. We don't have any randomized trials that demonstrate clinical outcome benefits. The question still remains if the lowest driving pressure is the good target. So a low driving pressure of 8 or 9 may imply that you have tidal recruitment and collapse at the end of exhalation. So we don't know if we should target, when we adjust that PEEP, should we target a driving pressure that's 14, 12, 15, or go by the lowest driving pressure? So I have a feeling, based on data we have from EIT, that if you went to the lowest driving pressure, you may actually have patients with significant amount of collapse. And so finally, why is this? I mentioned earlier that PEEP is a compromise. This is the strain equation. Every time you increase PEEP, you add end expiratory lung volume to the numerator, which would increase strain in this equation. Any number higher in the upper equation would increase strain. But if you are recruiting lung units, then the argument is that perhaps the recruited volume is beneficial and it should be added to the numerator, and then all the end expiratory lung volume, again, this is a compromise, it increases strain, but it depends on how much recruitment potential you have. So there's a bedside method called the recruitment to inflation ratio, where you lower the respiratory rate, you have the patient on a higher PEEP. You lower the rate because when you drop the PEEP, you will exhale not only your previously ventilated tidal volume, but also a predicted loss of volume based on your drop in PEEP, and then anything that is recruited. And this can also be done by doing multiple PV curves, but this is a simplified approach, and it was validated against the other approach. What is it? It predicts the change in, it uses the change in end expiratory lung volume. It looks at how much recruited volume there was and calculates compliance based on that. Inflation, it uses the compliance at the low PEEP, so this is your baby lung PEEP compliance, and then it takes the ratio of that. It allows a direct assessment of the potential for recruitment, the RI ratio. Basically, the lower the ratio, the greater amount of end expiratory lung volume is distributed to the baby lung, which is a greater risk of hyperinflation. We are currently wrapping up. We're near the end of a study that is randomizing patients and then stratifying them to a high or low PEEP table, or not high or low PEEP strategy based on the recruitment to inflation ratio compared to a high or low PEEP FiO2 table. Basically, it's based on clinical practice. Whatever your center does, it's comparing that versus the recruitment to inflation ratio stratification. So in summary, the tables have become the main comparator in multiple studies. Methods based on physiology have not been shown to improve patient outcomes. Is best compliance associated with alveolar collapse? Same with lowest driving pressure. We don't know if it's the best. Targeting transpulmonary pressure does assume recruitment potential as well. EIT is not widely available, and it is expensive. Does testing for recruitment potential assist with deciding which method to use? And we still don't know the best method for individualizing PEEP. Thank you.
Thank you, Thomas. Very informative. Now we welcome to the stage Prof. Brady Scott. He will be presenting about high-flow nasal cannula oxygen therapy, physiological mechanism, initiation, and management.
Good morning, everyone, again. Good to see you again. I will say, like I said earlier this morning, if this is too fast or if you want a copy of these slides, no need to take photos. You can if you want. I'm happy to email them. If you'll send me an email, I'll send you a PDF of these slides. So same conflicts as before. So research funding from the AARC. And we are going to go over some mechanisms of action, but I think it's important about learning how to set high flow, which is still up for debate on how we should do that, and we'll go over that in a second, and we'll talk about the initiation and what we know about management. And so for a point of clarification, I want to make sure we're all on the same page. So I'm going to talk about a humidified high-flow nasal cannula that is like heated. Oh, I didn't turn my time on. It's capable of delivering, somewhere between 20 and 60 liters per minute, maybe even higher, up to 70, although some studies are now showing that people are looking at high flow up to 100 liters per minute, but that may not be such a good idea, maybe a little bit too high. And we'll also talk about the adult population. I do believe my colleague Emily is going to talk about high flow in the pediatric population. This, instead of something in our hospital, sometimes in our facility for select patients, we use a wider bore nasal cannula setup that goes from 8 to 15, that's sometimes called high flow. So we're going to be using the device that you're probably more familiar with, that's heated tube. So for, back in 2016 in respiratory care, there was a really nice paper published by Masaji Nishimura that actually still is relevant today because the physiologic mechanisms were kind of discovered pretty early on. And this was followed by a really nice paper that was published in the American Journal of Respiratory Critical Care Medicine in 2017. So there's quite a bit of research that's been done about the physiologic mechanisms. And I think that by understanding these mechanisms, then we can kind of get a better understanding of how one might initiate and then subsequently manage. So that's important. So I'm going to end this lecture with a quote from Dr. Nicholas Hill that I think will make sense to help kind of think this through. I will tell you that I get the privilege to teach high-flow nasal cannula oxygen therapy a lot with, some of you may have heard of the organization called CHEST, which is the American College of Chest Physicians. And a really big question I get from practicing physicians a lot is, how do I start this thing? How do I write the order? How do I know when to turn it down? Do I turn flow down first? Do I turn FiO2 down first? So I think by backing up a little bit, looking at the physiologic mechanisms, then we can start to make a little more sense of the management and what's known. So what is high-flow nasal therapy again? Again, we can use an air oxygen blender to deliver anywhere between 21% oxygen all the way up to 100. And again, some of these devices can give up to 60 liters or more, and we can give 100% relative humidity, 37 degrees, it's humidified at 44 milligrams of water per liter. So we can provide a lot of heat and humidity to patients. For those of you that have been around for a while like me, I actually thought when high flow was first invented, it was nonsense. I thought there's no way a patient is going to allow me to put 40 or 50 or 60 liters of flow in their nose. It's just not going to happen. And the sales rep said, just try it. And I was eye rolling, and I'm like, no way. There's no way. And then I put it on, and I go, feels kind of nice because of the heat and humidity. I think it made it a little more tolerable. So there's your standard device. I actually think this was been presented already once in this conference. So remember that oxygen delivery, this is going to take you back to school for a second. Oxygen delivery to the alveoli depends on the flow rate, the FiO2 being delivered to the device interface, and the patient's demand, right? So we know that on like low flow devices, for example, the nasal cannula. So let me go back just real quick. Let me tell you how to stump your students or stump a resident or a fellow. Ask them this question. How much oxygen does a regular low-flow nasal cannula deliver to the patient? And they all do this. They'll go, 24%, 28%, 32%. And you say, no, it delivers 100% oxygen to the nose. It's pure oxygen, right? So why does it turn into 24%, 28%, 32%? Because you entrain room air around it. Right, so it delivers that. So we know, again, going back, we know the flow rate, the FiO2, but look at the patient demand. The patient demand changes the FiO2 delivery in a low flow device. So that's important to consider here. All right, so remember that on low flow, 100% oxygen, and then the inspiratory flow rate of the patient exceeds the flow rate of the device. That's the key, right? And so the patient entrains room air, and that's why we're okay with giving a patient with emphysema pure oxygen because of the room air around them, all right? So then in walks high-flow nasal cannula. It's in the effects. So what we know is people will say, well, how does high flow work? They'll say, well, it creates PEEP. People will say something like that. Sometimes we say end expiratory lung volume. But, we can say some unquantifiable amount of positive pressure. It adds adequate heat and humidification of inspired gases, which is extremely important. And what I say, when I publish this, I don't know how else to say it, it creates a more stable delivery of FiO2. It stabilizes delivery. And what I mean by that was because of the high flow and how it's affected on the inspiratory flow and the patient's breathing, we can be rest assured that when we are delivering 50% oxygen at 50 liters, that blood gas probably represents 50%, right? Because remember, no matter what, we are still open to the atmosphere. It's not perfect. You're probably still entraining some room air, just not a lot of room air. So that's important to know. And the washout of anatomic dead space, which has been a big issue. All right, so let's talk about positive pressure. This has been measured numerous times. They only have a 25-minute talk here, so I'm not going to go through a lot of the data. So we got to realize that high-flow nasal cannula is indeed an open system, but some studies have shown some positive pressure increase in the pharyngeal areas, pharyngeal pressures, and again, shown some end expiratory lung volume increase. Whether measured by EIT or other methods, I do believe we can be pretty confident that we are at higher flows. We are creating some degree of positive pressure. So this has been shown some here in the Respiratory Care Journal. This was published back in 2018, the effect of high flow nasal cannula on expiratory pressure and ventilation in infant and pediatric and adult models. This kind of was like a laboratory model. And they looked at the effect of flow on pressure and ventilation. So in this model, which again includes the neonatal group, you can see that there's a nonlinear increase in expiratory pressure. So on the y-axis here, you have end expiratory pressure and you have flow. So you can see, like over here in the adult population, as flow increases, so does the end expiratory pressure in both models that they used. And you can see this was also across other models. And it changes with mouth open and mouth closed models. Probably doesn't surprise you that that changes a little bit with mouth open, mouth closed models. And it seems to be consistent across all studies that are looking at the physiologic relationship, or the physiologic, the physiologic influence of high flow on the body here. And then so you got the effect of flow on oxygen, of airway pressure during high flow nasal cannula. This was published by Rachel Park. They actually took 15 patients that were undergoing elective cardiac surgery, and they also measured pressure in the back of the throat, and they did it with the mouth open and mouth closed models at 30, 40, and 50 liters per minute. They also found that mouth closed versus mouth open changed the amount of pressure that was being generated. I think importantly it's to understand what they found with mouth closed, every 10 liter per minute increase in flow, the mean pressure increased by 0.69 centimeters of water, which is not a whole lot. But look at this, how much it dropped with the mouth open. So mouth open, mouth closed is probably affecting some of that positive pressure that's being generated. You know, again, I only have 25 minutes to do this, but if you look at the other studies that are being published, the size of the nasal cannula even affects the amount of positive pressure that's being delivered, even the patient's own individual anatomy. So it's not really something we can say, this is how much is being produced on every patient, because it's flow dependent, it's cannula size dependent, it's position dependent, and it's patient's individual anatomy dependent. So it's not really something we know for sure that we're actually delivering. And this one's kind of short. This is a group of respiratory therapy professionals in here. That what we know that high flow is doing for us now is it provides adequate heat and humidification of inspired gases. This does give us the ability to give up to 37 degrees and 44 milligrams of water per liter. And so we know that warm humidified gases prevent dryness of the airways, and it actually has been shown may reduce bronchial constriction from cold, dry gases that patients are breathing in. So it's much more comfortable. It could be actually better for the airways. It actually has been shown or thought to, at least theoretically, reduce metabolic costs needed to warm and humidify secretions. And we know that secretions that are warm and humidified are generally easy to manage and get rid of. Something that I try to teach a lot here is, again, the stabilization or the creating a more stable FiO2 delivery by high flow nasal cannula. I teach my students all the time. So if you come to my program, you've learned this from me somewhere. If a physician, if Dr. Sullivan, again, here's my friend, Dr. Sullivan, a surgeon, comes up to me and says, Brady, the patient in trauma bay room 4 is on a non-rebreather at 15 liters. How much FiO2 is that? You know what I tell my students to say? I'm not sure. Quite a bit. And then Dr. Sullivan goes, I need a number. I say, I don't know. And then I say, if I turn it up to 40 liters, if I flush it, it's probably closer to 100%. But the reality is on those low flow devices, which a non-rebreather is, a low flow device, it isn't variable FiO2. I don't know what it is because it's affected by the patient's, the way that they're breathing. However, if I have a patient on a high flow nasal cannula system and I have it at 40, 50, or 60 liters, and if I'm increased over top of their inspiratory flow demands, I do feel more comfortable in answering that question. So if Dr. Sullivan said, Brady, the patient in trauma bay 5 is on a high flow nasal cannula at 50 liters a minute at the FiO2 of 70, what FiO2 am I actually seeing this blood gas on? I would feel more comfortable in saying that's close to 70%. It may really be 67% if I could crawl down to the alveoli and see, but I feel much more comfortable that that's what it is, right? That's because you're exceeding their flow demands if the flow is turned up. Right? So again, I just said everything on that slide. So it creates a more stable and more reliable FiO2, And I believe, and this is again my opinion, and Dean's already said that's not worth a nickel, but in my opinion, it at least makes me more confident in understanding if the patient's condition is worsening or getting better, because I can see how everything is changing based on what I'm delivering. But again, that is the opinion of one and has very low evidence or even none. And then finally, probably the most important thing here, to be honest, it's considered by some the key mechanism of high flow is this getting rid of or washing out anatomic dead space. And so this is interesting because this has been studied several times. In some studies, they see a patient that's on a high flow or not. They have the same respiratory rates and they're breathing. They are breathing the same, but CO2 levels are different. And so it's like the minute ventilation is the same, but the CO2 level is different. And so from a physiologic standpoint, that must be dead space or the lack thereof or a change in dead space. So this has been studied, again, a few times. I don't have a whole lot of time to go over this concept. But we know that there's definitely been studied that that high flow does a great job of washing out the exhaled gases in the dead space, which may contribute to a more efficient kind of ventilation. It's a pretty interesting paper, a little heavy to read. I'm going to be honest with you. If you go into the journals of applied physiology, it's a little heavy. You need to take your time with this one. But this was published in 2017, and what they did was they actually thought, high flow nasal cannula in a dose-dependent manner, which means flow-dependent, can reduce dead space and reduce rebreathing of exhaled gases. So they gave healthy volunteers, they gave them some this 81 KR tracer radioisotope gas where they can see these things under a gamma ray or a gamma camera, and they could actually see the rebreathed gas inside of their upper airway and see how high flow washed it out. And they did this at 15, 35, and 45 liters, and they had the patient close their mouth. And so in short, what they found was high flow nasal cannula reduces expired air in the upper airways. Dead space was reduced, making ventilation more efficient, and the dead space clearance is flow and time dependent. So if you turn the flow up, you wash out the dead space more. Probably not a surprise, but this was verified based on the study and actually others. And so you think about areas of carbon dioxide washout in upper airway, so then it becomes more logical, at least from a physiologic standpoint, to understand why CO2 is being affected whenever you have a reduction in anatomical dead space. We know that dead space plays a big role in respiratory care physiology, and so this high flow nasal cannula system can help wash that out. Now, I'm going to go ahead and talk about this idea of initiation and subsequent management. And so I'm going to throw you some papers up here. Again, I could probably give a 2-hour talk just on this alone. So I'm going to give you some references so you can go back and take a look at this. This was a paper published by Oriol Roca, my colleague at Rush, Dr. Jay Lee and others, that was published kind of recently. We actually published a systematic review on the effects of flow settings in high flow nasal cannula. Dr. Lee, myself, and others, we published this in Critical Care. I wrote this piece because I believe this is important in EMJ respiratory, high flow nasal cannula oxygen therapy beyond clinical indications and patient selection. I do believe that high flow nasal cannula, in a certain way, I don't want to say the word suffers, but in a certain way has a lot of evidence. We have a lot of evidence of who we should put high flow nasal cannula on. We don't have a lot of evidence of how we do what we should do with it once it's on. We say who, what patient population, but we don't say, okay, once we put it on, then what? And so this was a paper that tried to address that as best as I could based on the literature. And again, I'm happy to send you this for your own time. And then very recently published in Chest was high flow nasal cannula liberation, who, when, and how. This is hot off the press, published fairly recently. So let me go ahead and say this. When somebody says, how do you initiate high flow nasal cannula oxygen therapy on a patient for name the reason on the adult population, I'm going to go ahead and tell you, I hate it. The data is not strong. So there's a lot of opinions here, and there's a lot of observational stuff, but randomized controlled trials, high levels of evidence doesn't currently exist. What it looks like is it is reasonable. Notice the language I'm using here is reasonable to start at 30 to 40 liters per minute and escalate rapidly as tolerated. I will tell you that from an opinion standpoint, I prefer this. I know that the data it appears that patients do better when flow is high, but I do personally like to start them out to get them a little used to it before I ramp up too quick. I have been argued with, I've been told at conferences, Brady, you shouldn't teach people that. The data says that they do better when the flow is high, and I argue, just give me a minute. I'm just going to start you at 30 or 40, and then I'm going to ramp it up to whatever you can tolerate. Is that the best way? I'm not sure. That seems to be reasonable. FiO2, probably reasonable to once we actually figure out where we are on flow, to begin to titrate down, for example, from 100%, if you will, down to whatever your SpO2 target is. Temperature is also something, so I think intuitively we think that flow is what's the most uncomfortable part of high flow. Not true. It has been demonstrated that people don't like the heat. It has been suggested that we start at 37 degrees, but no, that has been shown in research, I think published in 2017 by Tommaso Mari, that people also complain as much about temperature as they do flow. So, you can always turn that down to 34, 31 if you have to, keeping in mind that we can start at 37. That would be preferred if they can tolerate. So why does flow matter? We know that flow matters because the physiologic effects of the positive pressure, the anatomic dead space washout, and the stabilization of FiO2 is all flow dependent. And so we know that being on the higher flows, definitely the observational trials show a more positive effect. So it looks like we want to be on the higher flows if we can get them there. And we know that the benefits are maximized of high flow when the flow is greater than or equal to the inspiratory demand, which is not easy to measure. How do you even know really what the inspiratory demand is? One's respiratory rate doesn't necessarily say that. You have to have a special device, right? So we know that, but if you can get at or above the inspiratory flow demands of the patient, you probably are maximizing high flow nasal cannula. And we know that higher flows reduce respiratory effort and even reduce CO2 retention in some patient populations. This was published by Oriol Roca, and if you don't know who Oriol Roca is, if you've ever heard of the ROX index, he was the person who described the ROX index. I've had the privilege to meet him. He's the nicest person in the world, so knowledgeable about high flow. I really think he did a good job with this image. And what you see is at the left, you see settings and the physiologic effects. So his recommendation here, not mine, flow rate, set the highest tolerated. So again, I prefer myself in my own practice, if I was at my hospital today, if you came in, I would probably start you at 30, and I would rapidly titrate you up as long as you could tolerate it, even up to 60 liters. Why? I get the increase in end expiratory lung volume. I can increase alveolar FiO2. I'm going to stabilize alveolar oxygen, and I'm going to increase CO2 washout. I'm going to maximize that by the higher flow. The FiO2, again, normalized, temperature to comfort, and then I want adequate humidification. But if you won't wear it, I have to get it to where you can tolerate it. I would rather be at 37, but I'm going to work you down to whatever you can tolerate to 34 if needed. And then the types of nasal prongs, you can see larger sizes are for hypoxemic patients, and then asymmetrical prongs, which are being looked at more for those with higher respiratory drives. So it's not really rocket science, but we do need to let the flow do its thing, right? And so, so there's even other kind of models of how to wean this and liberate this. This, again, was published in Chest, and you can see that this author, recommends that, once we get down, the high flow nasal cannula down to about 50 or so percent, then we can begin, all right, let's get this off. What do we need to do? For example, is the criteria met? SATs are greater than 90, respiratory rates less than 24. There's the absence of accessory muscle use, check, check, check. And then we go, are you less than or equal to 50%? Check. And then it says, is your flow still greater than 20? Yes. All right, let's move down. And then we can start to decrease our flow rate. And there are teams that are beginning to look at methods of weaning and titration of high flow nasal cannula. I do know that's actually underway right now. But at the end of the day, they're trying to figure out just the fastest way to get them off. I know that in my own institution, we promote keeping the flow high, reducing the FiO2 down to about 50% before we really start worrying about decreasing the flow. Again, we kind of have the philosophical belief of let high flow be high flow. We know that the physiologic effects of high flow are more positive when the flow is more elevated, up to 40, 50, or 60 liters, and that's exactly what we try to do. But we don't have that perfected in my own institution. So, to conclude and be on time, high flow nasal cannula has several physiologic mechanisms. I think if you think about it, this is almost 10 years old. We're really sure of how high flow nasal cannula works from a physiologic standpoint. And we have now begun to see a lot of the studies that compare lower flows to higher flows. It shows that the higher flows are more beneficial. So we got that figured out. We know that high flow can improve oxygenation, inspiratory effort, minute ventilation even in some patients. All kinds of things. Dynamic lung compliance, and even lung homogeneity. Now, I will say, I don't have time for this, but there's evidence that high flows up to 100 liters are actually not okay. That may even create a little bit of alveolar overdistension in some regions. So there's probably a threshold where we're getting too high. I'm not clear on that where that's at yet, but it looks like maybe once we get much over 60 or 70, we got to start being a little careful because we don't want to create more issues. We do know that high flows, the benefits are likely more flow set dependent, which more and more stuff will come. But I actually was in New York City, sitting in the audience, and I was up next behind Dr. Nicholas Hill, which I respect, just crazy respect for his work in non-invasive respiratory support. And he ended his slide with this, and I borrowed it a little bit, because this is exactly what I teach in my own hospital. If you're going to use high flow, then let high flow be high flow. Let the flow run, keep it up, titrate your FiO2, watch the patient's condition, and then titrate after that. And again, my email is here. So my first name is actually Jonathan_B_Scott@rush.edu. I'm happy to email anybody my slides after this talk. Thank you.
Thank you, Brady. Perfect timing.
Thank you. Our next topic will be using pulse oximetry wisely, presented by Dr. Dean Hess.
So I'm going to talk about pulse oximetry and how to use pulse oximetry wisely. So as I look out over the audience, and almost all of you are much younger than I am, and you probably cannot imagine your practice without pulse oximetry. But I can tell you for the first 15 years of my career, we did not have pulse oximetry available. And guess what? Our patients' mortality rate was not 100%. I actually was involved in doing some of the first assessments of pulse oximetry when it became available in the 1980s. One of my first studies that I had published in the peer-reviewed literature evaluated the accuracy of pulse oximetry. Essentially, a group of us took turns putting arterial lines in one another and doing desaturation studies to evaluate the accuracy of pulse oximetry. And I can tell you that the accuracy that we reported back in the mid-1980s is not much different than the accuracy of pulse oximetry today. These are my disclosures, exactly the same as what they were a couple of hours ago. So then how might you go about determining the accuracy of a pulse oximeter? How would you do that study? Well, what you would do is you would collect a number of data points where you draw arterial blood, measure the oxygen saturation on a co-oximeter, and compare that to the oxygen saturation that is measured with a pulse oximeter. And ideally, you would have a variety of different subjects that you would include, such as individuals of different ages, of different skin tones and skin pigmentation and races, and you would do that study on patients as well as normal volunteers who you might desaturate. And then you might collect 50 different data points, as I am showing on the slide, comparing the oxygen saturation of the blood to the oxygen saturation of the pulse oximeter. And then you would do some statistical analysis, really pretty straightforward. You can do this on Excel. You don't need to use SAS or SPSS or some other expensive statistical analysis software. And what you do is you compare the differences between the oxygen saturation from the pulse oximeter and the oxygen saturation on the arterial blood. So the mean of those differences from the data on the previous slide is the bias. Then we calculate the standard deviation of those differences. That is called precision. And then we calculate the limits of agreement, which is the bias plus or minus 2 standard deviations. And if you do that kind of a study, whether it's a study that I did back in 1985 or it's a study you do today, you typically find that pulse oximeters have an accuracy of about plus or minus 4%, which means that the bias, the average difference, is around 0, and the precision is about 2%, or 2 standard deviations. So what does that mean? So on the surface, that looks maybe not so bad. Bias of 0, precision of 2%. If we were to look at that graphically, this is what it looks like statistically. This is called a Bland-Altman plot, where we plot the difference between the 2 saturations, the pulse ox saturation, the arterial saturation, against the average of the 2. And this is the 50 data points from the hypothetical study that I showed a few slides ago. And we end up with a bias close to 0, limits of agreement of about plus or minus 4, which is commonly what is seen with these types of studies. So what does that mean? Well, to think about what that means, we have to remember the physiology. We have to remember the relationship between oxygen saturation on the y-axis as a function of the PO2 on the x-axis. This is the oxyhemoglobin dissociation curve that we all know. So let's say that your patient has a pulse ox saturation of 95%. So on the monitor, SpO2, 95%. From what I just told you, the limits of agreement are plus or minus 4%. So for that pulse ox saturation of 95, the true oxygen saturation might be 91, or the true oxygen saturation might be 99. And if we convert that to PO2, we can see that for a pulse ox saturation of 95%, the PO2 might be 60, the PO2 might be 150, just applying the accuracy of pulse oximetry to the oxyhemoglobin dissociation curve. But we also know that the oxyhemoglobin dissociation curve is not always set as a fixed relationship between saturation and PO2. We all learned in school that the curve can shift to the right and the curve can shift to the left dependent upon temperature and acidosis and so forth. So let's examine that. So let's say that you have a patient who has a PO2 of 60. That translates to an oxygen saturation of about 91% normally. But now let's imagine that that patient develops an acidosis, either a respiratory acidosis or a metabolic acidosis. We know that acidosis shifts the oxyhemoglobin dissociation curve to the right. With that same PO2 of 60, with a right shift of the oxyhemoglobin dissociation curve due to acidosis, the oxygen saturation might drop down to 85 or 86%. So what does that mean clinically? Well, you're taking care of a patient in the ICU, you look at the monitor, the oxygen saturation is 91 or 92%, and then the oxygen saturation drops to 85 or 86%, you think that there has been a worsening in lung function. You need to turn up the FiO2, you need to add more PEEP. But maybe it means that the oxyhemoglobin dissociation curve has shifted, and the right response would be to increase the ventilation rather than to increase the FiO2. So use pulse oximetry wisely. Think about what that number means and think about what might affect that number so that you do not apply the wrong therapy to your individual patient. Something that has received a lot of attention just over the last 5 years or so is what has been called in the literature a racial bias in pulse oximetry. And I would point out this is a statistical bias, it's not an ethnic bias. But what this means is that the inaccuracy in pulse oximetry that I have already showed you might be worse in individuals who have deeply pigmented skin. And the limits of agreement of pulse oximetry would suggest that if you're following pulse oximetry, there may be some patients who would have hypoxemia, a low true arterial oxygen saturation, despite an acceptable oxygen saturation by pulse oximetry, and that is worse in individuals who have more deeply pigmented skin. So an important determinant then of the accuracy of pulse oximetry is skin pigmentation. And that was shown maybe first in this paper in the New England Journal of Medicine and other papers subsequent to that. But I think if you think about it, it makes sense. If the accuracy is plus or minus 4%, there are going to be individuals who have a normal pulse oximetry saturation, but might in reality be hypoxemic due to the arterial oxygen saturation. So this has been evaluated now in a number of studies in high-impact journals like the New England Journal of Medicine and JAMA. So here's a paper from JAMA about 5 years ago, looking at a cross-sectional study of a lot of patients, almost 88,000 patients, looking for the incidence of hidden or occult hypoxemia. So when we talk about occult hypoxemia or hidden hypoxemia, what that means is that there's a patient who has an acceptable oxygenation by pulse oximetry, but if we draw an arterial blood gas sample, we find that the patient is hypoxemic. And in this study, they found that the prevalence of occult or hidden hypoxemia was greater in individuals who were Asian, Black, or Hispanic. But what I like to point out from this study was that the incidence was maybe frighteningly high even in white patients. So it was greater in Asians and Black patients and Hispanic patients, but it was not absent in white patients. And in fact, in white patients, it was over 20%. So in other words, an incidence of occult hypoxemia, even in white subjects, when we target an oxygen saturation of 88 to 92%, which is typically where recommendations like from AARC and for COPD patients might fall. Also, this study showed that higher rates of hidden occult hypoxemia are not benign. And in fact, these are associated with a higher mortality, future organ dysfunction, and other abnormal laboratory test results. So this is not a benign issue. So then when you're using pulse oximetry, and if you're using pulse oximetry wisely, you want to ask yourself, what is the likelihood that my patient might be hypoxemic despite that the pulse ox saturation may be okay? This has been evaluated in many different patient populations, and I would say I'm only going to focus primarily on COPD here this morning. But this was a study in the Annals of the American Thoracic Society from a couple of years ago, looking at the accuracy of pulse oximetry for long-term therapy assessment in patients with COPD. And what they found was that using pulse oximetry to screen for hypoxemia, they found that 2/3 of patients they missed the hypoxemia with the use of pulse oximetry. So in other words, using pulse oximetry led to a misdiagnosis of hypoxemia in 2/3 of patients with severe resting hypoxemia. Kind of a frightening number, at least to me. And they found that 10% of those patients who underwent evaluation for long-term oxygen therapy had hypoxemia that was not detected by pulse oximetry. In other words, according to the pulse oximeter, it was determined that the patient did not qualify for long-term oxygen therapy when indeed they did qualify for long-term oxygen therapy. So why should we care? Well, why we should care is we have evidence going back to the 1980s that long-term oxygen therapy in patients with severe hypoxemia leads to a survival benefit. Patients live longer being on oxygen. So pulse oximetry may deprive some patients of long-term oxygen therapy if that is our sole assessment of the patient's hypoxemia. If we are using pulse oximetry to evaluate patients with COPD or to evaluate hypoxemia in patients with COPD, perhaps we need to use a higher target than we have traditionally used. So often it has been recommended that in patients with COPD, we should target an oxygen saturation of 88 to 92%. That's often the range that I have included in my lectures. However, in this study, they found that using pulse oximetry to assess oxygenation in patients with COPD, when the pulse ox saturation was lower than 94%, the patients had a higher mortality, which I am showing with the red or the pink shaded boxes on the side. So this suggests that if we're using pulse oximetry to evaluate hypoxemia in patients with COPD, we need to use a higher target than we have traditionally used. We need to use an oxygen saturation range of 94 to 98 rather than 88 to 92. And if we use the traditional 88 to 92, we may be subjecting many of our patients to hypoxemia, and that may be increasing the risk of mortality for those patients. So we need to use pulse oximetry wisely. This is from an editorial published a couple of years ago in the Annals of the American Thoracic Society, where the author said the use of pulse oximetry to screen and diagnose hypoxemia is the latest example of rationalizing the use of a convenient medical device by applying data out of context without strong evidence to support clinical decisions. So all of us have adopted pulse oximetry routinely into our practice without strong, high-level evidence to suggest that that's improved patient outcomes. Pulse oximetry has become ubiquitous in the acute care setting despite evidence of poor performance of pulse oximeters, which I've tried to make you appreciate over the previous 15 minutes or so. So then if we think about the use of pulse oximetry, maybe it's not as simple as we tend to think it is. Maybe it's not as simple as just putting the probe on the finger and looking at the monitor and taking the number at face value. We might need to think a little bit more about the use of pulse oximetry than perhaps we have in the past. And we talked here about the issue of accuracy. So keep in the back of your head that the accuracy of pulse oximetry is about plus or minus 4%. We talked about the issue of skin pigmentation. The accuracy may be worse in individuals who have deeply pigmented skin, such as black individuals. But what I also show on the slide with the remaining bullets that I'm not going to bore you by talking about this morning is all of the other things that can affect the accuracy of pulse oximetry. So as clinicians at the bedside, we need to appreciate these things so that we can use pulse oximetry wisely. Now it turns out that it even gets more complicated than that. This is a study that was published in Respiratory Care last month comparing two different co-oximeters, devices that measure oxygen saturation on arterial blood. So this was not an assessment of pulse oximeters, this was an assessment of co-oximeters. And they showed that if you take the same arterial blood sample and you measure the oxygen saturation on one co-oximeter of one manufacturer and then another co-oximeter of another manufacturer, there can be differences. That's the bad news. The good news is, though, it's not so bad with oxygen saturations in the 90s. So usually we're looking at oxygen saturations in the 90s, not oxygen saturations in the 70s, and where the differences between the devices become more profound is at lower oxygen saturations. So then my message to you here is not that we should abandon the use of pulse oximetry. I'm not telling you to go home and throw all your pulse oximeters in the trash. We should continue to use pulse oximetry, but we should use it wisely. It's a thought process to use pulse oximetry. So we need to think about what is the accuracy of the pulse oximeter. And then we need to think about what is the range of typical arterial oxygen saturations that might relate to that pulse oximeter saturation. We need to think about the oxyhemoglobin dissociation curve. So if you learned about the oxyhemoglobin dissociation curve in school, and you took the exam and you passed and you said, thank God I never have to think about that again, well, maybe you do have to think about that again. We need to think about the clinical context. And then we need to use that information appropriately to care for our patient, because what good is monitoring pulse oximetry if we don't use it to take care of our patients? So with that, I will stop. And again, my message here is don't stop using pulse oximetry, but make sure that when you use it, you understand what you are doing with the use of that device. Thank you.
Thank you. Last but not least, we have asynchrony, consequences and management, presented by Dr. Thomas Perino.
Thank you. Okay, next, another very passionate subject that I enjoy speaking about, ventilator asynchrony, consequences and management. 25 minutes between me and your lunch, so I'm going to get right into it. Same disclosures as before, nothing related to this presentation. Now, before we can talk about consequences and management, we have to understand how asynchrony is recognized. And of course, if you want to be good at recognizing asynchrony, you need to understand a little bit about how the ventilator mode functions, which we discussed yesterday and in the 2 days ago and in the workshop yesterday. But essentially, if you are using a volume controlled mode of ventilation, then your flow is fixed, whether it's decelerating flow or square. And effort of PMUS, if you see this red line here, the effort by the patient will cause a change or a reduction in the pressure waveform rather than the flow because the flow is fixed. Now, in some ventilators, if the effort is strong enough, the flow pattern will change, but typically this is where you're going to see it, and I'll give you examples of that. In a pressure-targeted mode, pressure is constant, and while you can see some fluctuations in pressure, the largest impact is going to be on flow, where flow becomes more rounded, and I'll show examples of this, and of course, volume can increase with increasing effort. Now, there's also an alteration of the expiratory flow that can occur not only when you make inspiratory efforts, which I'm not showing here, I'll show that in other examples, but forced exhalation will cause the flow that should be a nice exponential decay, it will cause it to flatten out or sort of come downwards and then decline normally. So asynchrony is typically categorized with two different categories. One is over-assistance and the other is under-assistance. Over-assistance can include auto-trigger, so the ventilator is triggering and even though the patient's not demanding it, so this is a form of over-assistance in the terms of over-delivery of ventilated breaths. Delayed cycling, which can be associated with both under-assistance and over-assistance. I'll give two examples of that. Ineffective efforts, which is caused by over-assistance. Reverse triggering, which may include a consequence of breath stacking. And then for under-assistance, we have flow starvation, which is a typical concern when you are using a fixed flow rate, like in volume control. So I mentioned 2 days ago, if the patient is on volume assist control and they begin to actively interact with the ventilator, my first reaction is to switch them to a pressure-targeted mode. Early cycling is under assistance more in the essence of time, and that's same with delayed. Your over assistance is typically related to the time that you are providing the breath. And then double triggering is a form of under assistance where the patient's neurological time typically extends past the ventilator breath and then a second breath is delivered. Now, I'm not going to get into all of these, but to measure over or under assistance, you should get into the practice of measuring respiratory drive. And Dean, I think you can appreciate my reference down here. I promise I will submit my manuscript before I leave Saudi Arabia. This was from the Journal Conference in 2025, where I had to give 2 talks, so I have a reason to be a little bit late, but not this late. But probably the easiest one is P0.1. Measure your respiratory drive. It's available on every ventilator. Now, normal P0.1 is typically reported as 1 to 3.5 or 1 to 4. A recent study that looked at a large database of patients found that 2 to 5 was kind of a sweet spot for P0.1 in terms of patient outcomes. Now, auto-triggering, when you have a leak, I think nobody has difficulty recognizing auto-triggering from a leak where it's constantly delivering the breath. However, this can be a little bit more subtle. We have a respiratory rate of 28, and if you look very closely, you'll see fluctuations in flow and pressure that are because of cardiac oscillations. And these cardiac oscillations are triggering the breath more than the patient wants neurologically. In fact, this breath here was triggered by cardiac oscillations, and then the patient then made an effort, which is why the flow increases again, and then you see this blip here. This is early cycling from where they're breathing. So this is actually a form of reverse triggering, simply that the ventilator beat the patient to it. So by fixing the trigger sensitivity in this patient, making it less sensitive, whether you change to pressure of -1 or increase your flow sensitivity so that it's less sensitive, so increasing it to like 3 or 4 liters per minute of sensitivity. When we did that with this patient, the respiratory rate actually dropped down to 16. Now, delayed cycling, there's 2 different examples I'm going to show here. This one here, again, both are related to time. The ventilator is not cycling off soon enough. In other words, the patient effort is now done, but the ventilator is still delivering the breath. In this example, it's associated with high inspiratory effort. So this delayed cycling, although it was under the category of over-assistance, this is a patient who might be being under-assisted. They have strong inspiratory effort. You can see this is a pressure-targeted mode, and the flow is nice and rounded. This is what it should look like. And what's happening is at the end of the breath, you see a pressure that's higher than the pressure you've set on the ventilator. This is due to the elastic recoil. So again, a passive patient, the ventilator is moving the chest wall and the diaphragm, everything equally. But in high effort, the patient's moving that diaphragm, and then when they're done breathing, that diaphragm has this elastic recoil that can cause an elevated pressure rise. And this is just an example. Again, this red line is PMUS. It represents PMUS. And you can see this was a much stronger effort, and that recoil, again, from here down, the patient's exhaling. And they're exhaling against the ventilator that's trying to maintain pressure, and you see this spike. And then finally, it cycles off. The other example is a patient with a slightly lower respiratory drive. And this is simply delayed cycling that the flow Again, this is pressure support, which we recall that flow cycles off based on a percent in pressure support. And this is just taking too long to cycle off. The patient is actually making an effort here. They get the breath, and where it changes flow direction there, where it's kind of going down and then angles out, that implies that the patient is likely passive. Now, without an esophageal balloon catheter, I can't confirm with 100% certainty that that's what's happening, but after recognizing and looking at many tracings of esophageal pressure, I'm pretty confident that the effort began here and ended here. But also, this is one of the number one causes, this oversupport is the number one cause of ineffective efforts. So the patient is actually breathing here, and then here, and then here. But the ventilator is only picking up the breaths that are actually delivered. So delayed cycling, one of the clinical consequences of delayed cycling is you have less expiratory time, and this is an example of what's happening. Here's your neurological time. The ventilator cycles off. If it cycles off when the patient's done breathing, you have perfect synchrony. Not always so easy. If you are done breathing, but the machine is still waiting to cycle off, you have excess time with flow, and volume is the integral of flow over time, so you have more volume. You end up with less expiratory time, dynamic hyperinflation, and non-triggered breaths, which are ineffective efforts. So there was a nice study published in 2008, and I wish more people were good at recognizing ineffective efforts because they might realize that they're actually quite easy to correct. So here we have an example. You can see the red arrows where there are ineffective efforts, and they tested 3 options for getting the patients to trigger these breaths. One was comparing different PEEP levels, because we often think, oh, if they can't trigger, I have to adjust the PEEP. Well, they found that adjusting PEEP, whether it was no PEEP or PEEP, it made no difference in the patient's ability to trigger the ventilator. When they lowered the pressure support, you can see what happened to the asynchrony. And optimal time, again, that's adjusting the cycle criteria. These were the 2 easiest and best methods for reducing ineffective efforts. Here's a patient example. If you're not familiar with PC-PSV on the dragger, this is the maximum pressure. So this is a pressure support of 24, which should be your first indication that you probably have ineffective efforts, is if you are using high levels of support and you have a patient with a respiratory rate that's lower than mine right now, and I'm not critically ill on a ventilator, chances are your patient has ineffective efforts and you're just not recognizing them. So all day, people have been charting 14 as the respiratory rate for the patient. But if you look, every other breath has a missed effort. Simply by lowering the pressure support, my tidal volumes are now 443, which is actually closer to 6 mils per kilo for this patient. My respiratory rate is 25, but guess what? My patient's respiratory rate was already that high. So when you correct ineffective efforts like this by reducing pressure support, it's extremely important that you talk to the nurse that's on, because if you go in the room, this is what they've been documenting all day, a rate of 14, and you come out, patient's breathing 25, and you say, I just fixed their asynchrony. They're going to say, my patient's tachypnic now, and you're going to say, no, they're not. They were always breathing like that. And they're like, no, they weren't. I've been documenting 14 all day. So it's important to explain to everyone around you that, show them that, look, the patient's breathing here, but they're not getting a breath. So when you fix it, it's not so shocking to them. Again, another way, if you don't reduce pressure, I mentioned that the flow is taking too long to cycle off. If I increase my cycle percent, you can see the ventilator is cycling off sooner, and the patient's now triggering every breath. Now, you might not like the results of this. If their rate when they were missing triggers was 20, and now they're triggering every breath instead of every other, now the respiratory rate's 40. But this tells you that the patient probably wasn't doing well, but they looked well because you were not recognizing the fact that they couldn't trigger the ventilator. Now, reverse triggering is, honestly, I could give an entire lecture on reverse triggering. It's very, very complex. But essentially, the way I like to describe it is that the ventilator delivers a breath that was not triggered by the patient, and it results in a response, or like a stimulus. So the patient can sometimes start entraining with the ventilator. Once the ventilator gives the breath, the patient responds with an effort. Now, there's 2 main types of reverse triggering. Essentially, there's one where if you take the stimulus away, they literally have no drive to breathe, or they have a drive of like 8 breaths per minute. But yet, they might be doing every breath here. You can see there's 2 breaths in a row with reverse triggering. How do I know? In volume control, notice there's a plateau here. I've set it up for an inspiratory pause. Look at the plateau here. It's missing. It's missing. That's because the ventilator gave the breath, the patient made an effort, that effort actually continues on into the expiratory phase here. So the effort starts during plateau and continues. So there's one big effort here. If I were to draw their PMUS, it would be right here. And then same with this breath. And then this one happened to be a regular breath with no PMUS. In pressure, you can see it's a little bit easier to recognize. The patient is not triggering the ventilator breath. The flow goes up. It starts to come down. The patient takes an effort. The flow goes back up. You get this M shape in the flow. And then the ventilator cycles off based on time, inspiratory time. This is pressure control. And you can see there's a blunting or a breaking of the expiratory flow. This is because the effort is lasting this entire breath. And then here again. So what are some ways to assess the type of reverse triggering that you're seeing? Here's reverse triggering. So I see there's a loss of plateau, and you can see the expiratory flow here. You can see that the patient's still inspiring after the ventilator cycles off. This patient, you switch them to pressure support, and here they are. They're on pressure support. Their rate is 13. You can decide whether or not that's fast enough for that patient's underlying condition. But this is simply switching to pressure support. They had a drive, no problem. Here's an example. This was given to me by my friend and colleague, Dr. Felipe Damiani. This is a patient on volume assist control, again, with reverse triggering, which is not specific to volume control, by the way. It can happen in pressure control. They switched the patient to pressure support, and this is their underlying drive. Again, if you recall, they had reverse triggering every single breath, but as soon as you take the stimulus away, they don't have a drive. So when you have reverse triggering, I mentioned that sometimes you start the breath at the inspiratory phase, and it continues on in the expiratory phase. This is also very similar with early cycling. Can anyone identify the difference between, because if you look at the flow, I still have this blunting of the flow because effort continues, and effort's continuing here. Can anybody want to tell me the main difference between these two? Ventilators help you identify this. Trigger. You see it's colored in white, right? The patient is clearly triggering this breath. So early cycling, the patient is taking the breath in, their effort is lasting longer. The ventilator is cycling off here, and then they're still making an effort. If this was pressure support, how should I fix this? You can look at the flow waveform and tell me what's wrong with this scenario. The inspiratory cycle, it's too high, right? So would I turn the inspiratory cycle up or down? Down, very good. All right, sometimes people say up, and then I have to correct them, but very good. So if I decrease the cycle off, guess what? My breath will last longer. And I want it to cycle off down here. So with early cycling, we just described how to fix it, and you did very well on that example, on that question. Now, breath stacking, although it's described as a type of asynchrony, I would argue it's a consequence of two different types of asynchrony. One, in reverse triggering, notice they're not triggering the breath. In fact, this is their esophageal pressure tracing. They're not triggering the breath. The machine delivers a positive pressure breath, which is why pleural pressure goes up because the lungs are expanding. But then they make an effort which causes the esophageal pressure or the pleural pressure to go down. And you can see that they start breathing right near the end of the breath. You can actually see the flow going up right at the end of the breath. It goes up. And then because their effort is strong enough, when it cycles off, it actually causes a second breath to be delivered. This is breath stacking as a consequence of reverse triggering with significant effort, okay? The breath stacking does not have to occur for you to classify reverse triggering. This is actually a misconception that some people feel that, oh, reverse triggering is when the machine gives the breath and then the patient causes a triggered breath. That's not, it's called reverse triggering because the ventilator is causing the patient to make an effort rather than the patient making the ventilator give them a breath. That's why it's called reverse triggering. In this example, this breath stacking, the patient starts the effort here. They trigger the ventilator breath. I have an arrow right at the trigger. And the effort lasts longer than the cycle criteria. They get a second breath. This is breath stacking due to early cycling. So same consequence, two different types of situations. Now, flow starvation, I hope that you never leave a patient like this. This is a patient on volume assist control. The pressure at the onset of this graph is PEEP. How do I know? This is inspiratory flow, breath going in, breath going out. When the patient is inspiring, they are completely outstripping the ventilator. The pressure is dropping significantly below PEEP. This patient, this is suffocation. This is torture to a patient. If you ever see this on a patient graph using volume assist control, immediately switch them to a pressure mode. And you might not like the results in the pressure mode. They may be pulling in 11, 12 mils per kilo of predicted body weight. You need to make a decision whether or not you want that to happen in light of the patient's condition. So if they are still having ARDS, they're still on a decent level of PEEP or high FiO2, you may need to sedate and paralyze these patients. And then here you can see the patient starts to exhale, and notice the flow goes down. Remember what I said causes that? Forced exhalation. So it's cycling off, and they're forcing out, and then they're taking this huge breath. This patient is extremely active. They are flow hungry. So this is the patient who was, the same patient was switched to pressure control, and we were trying to, again, this patient's on 60% FiO2 and PEEP of 12. They had started recovering from ARDS. We woke them up, and they started getting worse and worse and worse. Why? The P0.1 on this last graph, by the way, on this one was 9.6 or something like that. It was extremely high. Even on pressure control, it's 6.2, and you can say, well, why don't you give them more pressure? Clearly, they want more pressure. They are under-assisted, I agree. But when we went up on any of this tidal volume, this is saying 9.7 mils per kilo, it instantly went to 11, 12 mils per kilo. This patient was not breathing in their best interest. So this was likely leading the days prior to that. Again, the volume control, we had switched them, but then the pressure control was clearly not enough. They were on pressure support previous to that, and with a high P0.1, we were documenting it for days, and then finally we're like, this patient is clearly getting worse. But we could not increase the pressure. But this is clearly under support. How do I know? The flow is completely rounded. There is no deceleration. The patient is doing pretty much all of the work. This 6 centimeters of water is really doing nothing for this patient. This patient was ultimately sedated, paralyzed, proned, actually survived ICU, and did well. She was not doing well here. But I did point out that active exhalation. You were good at pointing that out as well. Now, I'm going to talk a little bit about sleep disturbances. I mentioned this in the workshop yesterday, and I mentioned this a couple days ago when I said in adult patients, where SIMV is not utilized for weaning, I often see it used when patients have apnea spells overnight, and it's used as a nuisance mode. Like, I don't want to be called back here for apnea, so I'm going to put a rate, just a backup rate. But because they were on pressure support, they want to leave them on pressure support, but they don't want to get called back, so they put a rate. And they use SIMV for this. Now, when we are awake, everyone here breathing very quickly. This is called the hyperbola, metabolic hyperbola. If we were to hyperventilate right now, following this black line, blowing off CO2, we will just blow it off, but we can do that, and we might get lightheaded, but no one's going to start having a central apnea. Even if you passed out, you'd start breathing. But when we go to sleep, there's something called an apneic threshold, and I want to point out, similar to what Dean was saying with the oxygen dissociation curve in critical illness, it shifts. So does this curve. It shifts under these conditions that are on the screen here. So I can't tell you what CO2 would cause your patient to go apneic, because it depends on how it has shifted. But when they go to sleep, if the CO2 falls below this level, they have a central apnea. And this is why when patients go to sleep on high levels of support, they fall asleep. There are two modes that have shown to be better for sleep, and that's PAV and NAVA. They're proportional modes. When we go to sleep, we downregulate, right? Our tidal volume comes down a bit, our rate comes down a bit, our CO2 actually climbs a bit. But if we're blowing off CO2 below the eucapnic threshold, the minute the patient falls asleep, they have a central apnea. I'm going to share with you an email I got from a friend and colleague, Dr. Laurent Bouchard. He sent me this email. It says, "We have a long-stay patient with myasthenia gravis, very difficult to treat and to wean. She hates staying on pressure support too long. I asked why, trying to explain to her that on pressure control with the same settings, there's no real difference if you're triggering each breath." And then he said, "I'm sure you will appreciate her response." That's all he said. He let me figure it out. And she wrote, "When I fall asleep on pressure support, the alarms automatically come on and disrupt my sleep." So clearly we were supporting her to the level we were blowing off CO2, or she's doing it herself by breathing, but maybe we're giving a bit more support than she needs. She was blowing off her CO2 below the eucapnic threshold, and as soon as she falls asleep, the alarms wake her up. This is why she hated being on pressure support. So in terms of asynchrony and consequences, one of the things that we need to be considerate of is the diaphragm. And there's more and more work that's looking at the the lung and diaphragm relationship, because we feel the diaphragm, although we know it atrophies, we sort of underappreciated what happens if patients are using their diaphragm excessively. We know that atrophy is a problem, but what about using it excessively? So I'll describe the conditions of the diaphragm under normal conditions. When we contract and trigger the ventilator, this is called a concentric contraction. This is normal. We contract, the diaphragm shortens and moves downwards. As it contracts, it increases thoracic volume, facilitating inhalation, and this is typically how we get assisted breaths. Eccentric contraction is contraction when the diaphragm is actually lengthening, so it's relaxing, the lungs are emptying, and you're contracting against this natural exhalation. So this eccentric contraction is what we typically see in ineffective efforts, right? The ventilator is exhaling, lung is leaving, or volume is leaving the lungs, and the patients are contracting against this. Early cycling revolts, and early cycling, whether it's early cycling where the patient triggered it or reverse triggering where the breath cycles off before they're done, this is what they've coined in recent literature, something called post-inspiratory loading, because it's kind of both of those things. It starts with a concentric contraction, but when the ventilator cycles off and they're still going, now it's a bit of eccentric contraction. So now they call this post-inspiratory loading. And concentric, this is an example of excessive concentric contraction. This is making the patient contract naturally, but way too hard and not comfortably. Ineffective efforts, an example of eccentric contraction, and then with reverse triggering and early cycling, we have this post-inspiratory loading where I've put the arrows. So there's actually a study published in 2024, led by Ewan Gallagher and colleagues, that looked at post-inspiratory loading and found that being in a post-inspiratory loading condition, and the longer you are in this post-inspiratory loading condition, over time actually has a negative impact on the ability for the diaphragm to contract. What was interesting about this study is that when they looked at normal inspiratory loading, so patients that are synchronous, that have high effort, they didn't find that it actually impacted the diaphragm in the same way. So they didn't have the same results of worsening diaphragm function over time. But with the post-inspiratory loading, they did see this impact on inspiratory diaphragm function over time. With reverse triggering, again, just getting now into some of the consequences. With reverse triggering, we published this paper in, it was the year 2021, where we had inserted a navicatheter to monitor inspiratory effort in the first 24 hours after initiating mechanical ventilation. And asynchrony with reverse triggering is actually very common, and we think it's very under-recognized. It typically happens at the transition from waking patients from sedation and turning off sedation. You're likely to see reverse triggering. We found that patients with more reverse triggering in the first 24 hours, it's not actually a bad thing. It was telling you the patient is waking up, interacting, and they probably want to get off the ventilator. They were more likely to be on partial support, so pressure support, or extubated the next day. So just because we see reverse triggering doesn't mean we should have a knee-jerk reaction and sedate the patient or paralyze the patient. They might just be telling you, hey, I'm ready. Like, transition me, please, to a spontaneous mode or get me off the ventilator. However...
2 minutes, please.
Thank you. However, work done by Felipe Damiani looking in an animal model found that with reverse triggering, if the effort was mild or moderate, it was actually had a protective effect on the diaphragm. But if the effort was high during reverse triggering, this is in an animal model, it was actually detrimental to the diaphragm. So again, similar to the human studies where we have post-inspiratory loading, which is very common in reverse triggering, resulted in diaphragm dysfunction. Those patients likely had a higher effort, and this is demonstrated quite nicely in this animal model where it can be injurious to the diaphragm. Now, ineffective efforts have been studied for quite a long time. Since 2009, we have this association with an increased duration of mechanical ventilation published by Witt and colleagues in critical care medicine. We have these clusters now, this term clusters of ineffective efforts. There's a few studies that have looked at ineffective efforts in combination with other common asynchronies like double triggering. And they found that what's interesting is that even though having ineffective efforts, interestingly enough, in this paper, it was shown to be associated with better outcomes. Why? Because patients who have asynchronies are interacting with the ventilator. And the bottom line is if you can recognize it or wean them quickly with good protocols of doing SBTs, you'll likely get them off the ventilator before it prolongs mechanical ventilation. But what they found is that the duration and power, so higher asynchrony index, and for longer periods of time, this was associated with poor outcomes. So what we know and don't know. We know sedating our patients leads to poor outcomes and atrophy of the diaphragm and other muscles. Asynchronies are associated with poor outcomes and diaphragm function. We still have not established a true causal effect, right? These are associative studies. They don't prove causation. We don't know if sicker patients have more asynchronies rather than asynchronies causing more sickness, right? So we need to understand that there's a relationship, but we haven't established a causal effect. Many asynchronies can be corrected through ventilator adjustments. So I always encourage you to choose adjusting the ventilator, first recognizing, understanding, and adjusting the ventilator before jumping to sedation and or paralysis. So I'll leave this here if you want to take some pictures. This is just a summary of over-assistance, the condition, description, consequences, and management. I'll leave that there for a moment because I'm not going to read all this. I don't have time, and I wasn't intending on reading it either. And then I'll go to the next one now, under-assistance. Thank you.
Thank you.
Thank you, Tom. Thank you, Chair Ziad, Chair Dr. Ashok. Thank you very much for your time. Okay, thank you all speakers of this morning of taking us back deep to respiratory care. This is our butter and meat of respiratory care, what we have had done today. Thank you. Now, we will go for a break, lunch break, and then we will resume our 7th session of Best of Respiratory Care, starting with advances in asthma and COPD management. Very important lecture. We are all involved in asthma management. And then we will have infant ventilation, and then bronchiectasis and use of high flow, and finally, how to achieve successful career. All of those are very important lectures. Please back on time at 1 o'clock. Thank you.
السلام عليكم ورحمة الله وبركاته. مساكم الله بالخير جميعا. حياكم الله في our session. Good afternoon everyone. معكم this is Raed Zahrani, the program director of respiratory therapy program at College of Applied Medical Science, King Saud bin Abdulaziz University, and the program director of critical care, respiratory critical care, King Abdulaziz Medical City, National Guard, Jeddah.
السلام عليكم جميعا. أنا دكتور رواف العبيدي, Assistant Professor in Respiratory Therapy and Assistant Dean for Clinical Affairs at the College of Applied Medical Sciences. And we welcome you all for this session, inshallah.
It's an honor to have Dr. Majdi Idris with us. Dr. Idris is the head of Pulmonary Vascular Unit, Prince Sultan Military Medical City, Riyadh, and also a professor of respiratory medicine in the University of British Columbia. Please join me to welcome Dr. Idris.
Thank you so much, Mr. Chairman. Assalamu alaikum wa rahmatullah wa barakatuh. Wa salatu wassalam ala Sayyidi Rasulillah. So again, thank you so much for the kind invitation. Now, I'm going to talk about some clinical diseases, asthma and COPD, as requested by Mr. Hassan Al-Uraini, just to have an update about what's new in these fields. Let's start by this. When we talk about asthma these days, we are mostly focusing on severe asthma because there is a lot of changes really in the field. Hence, it becomes very necessary to be careful about what we are talking about. So when we talk about uncontrolled asthma, it simply means nothing. It means that that patient with asthma has uncontrolled asthma symptoms. It does not reflect at all the severity of the chronic asthma that patient may have. He could have very mild genetic asthma, but he's a smoker, he's not using his inhaler, and he can die with acute asthma attack. Now, the word difficult to control asthma is a bit different. It means that that patient is on treatment, but he or she are not well controlled. Now, it could be because they have severe asthma or because there is some other factors that make that asthma uncontrollable. For example, the technique of using the device, the really existence of some other diseases, including allergic rhinitis, GERD, etc. Severe asthma means that somebody on the treatment, after controlling all the variables, and the disease is either not controlled or required multiple medication to control the disease. So we need to keep that in mind when we deal with patients who have uncontrolled asthma symptoms. And hence we start talking about this kind of phenoendotyping in severe asthma. If you look at all asthma comers, they could be different kind of phenotypes. Smoker, women, men, obese, old, elderly, allergic, eosinophilic, etc. So the concept of starting lumping them together, trying to have focused treatment to the focused disease, that really becomes very, very important. And this kind of strategy was first come at least in the field of asthma or COPD by Dr. Alvaro Agusti from Barcelona. That's the way they really like to say it. It's not Barcelona, it is Barcelona, so that's nice. And he was the doctor in charge of Johan Cruyff. You guys are so young, most of you. You don't know Johan Cruyff. Johan Cruyff is the legend in the soccer. In the football, he is one of the world legend, and he died with lung cancer. He was a smoker, very, very bad, but he was really his doctor. And now we started to focus that those patients with severe asthma belongs to different phenotypes. They are not the same. Depends on their type of inflammation they have. Now we start really breaking them down into high T2 inflammation, which is allergic, eosinophilic, versus non-high T2 inflammation. And that's extremely important because we start realizing that those patients who have allergic eosinophilic asthma, when they have some trigger usually allergic, stimulate the epithelium to release main mediators. You don't need to go really for the name, but these mediators called alarmin, TSLP, IL-25, IL-33, that lead to cascade of inflammation by stimulating the Th2 cells. And the three important mediators, interleukins, that now we are targeting with treatment are IL-4, IL-5, IL-13. And we're going to talk a little bit about them later on. But then we have a different type of really inflammation called non-T2, not allergic, not eosinophilic. They're mostly neutrophilic asthma. Or sometimes they have what they call pauci-immune. There is no much inflammation in the lung, but there's a lot of airway hyperresponsiveness. And those people really, hence, using general biological therapy to target inflammation might not be the best things to do for those people. So we need, whenever we diagnose severe asthma, to say which type you are, so we can target treatment. And now the biologics in asthma is kind of becoming everywhere. So now we have the first molecule called omalizumab. This drug has been with us for the last 25 years, and it does not target anything from IL-4, IL-13, or really IL-5, but it goes to the IgE and block their response. So it's purely a drug that works for severe allergic asthma. And now we have a drug called dupilumab that works on IL-4, that work on stimulation of the B cells to produce immunoglobulin, but also work on the IL-13, which is very important for a smooth muscle proliferation and fibrotic activity in the airway epithelium. So we have dupilumab that work there, and then we have two drugs in the Saudi market, the benralizumab and the mepolizumab, that work for IL-5, which is purely anti-eosinophilic, which is the main cell in patients with high T2 asthma. More recently now, we have anti-TSLP. Remember the TSLP is the main alarmin there at the very beginning. So now we are blocking that with a drug called atezolizumab that lead to kind of obliteration of the really distal inflammation in the lung. So now we have multiple molecules with that. And if you look at the GINA guidelines and other guidelines talking about using biologics in the step 5 level of care, those patients who exhausted the really multiple inhaler therapy, ICS, LABA, LAMA, they are not yet well controlled. So now we are using biological therapy to treat them. And the studies, we don't need to go into the details, are very, very, very impressive. Using this medication, we know that really omalizumab, when it's worked in the allergic asthma, did very well. Mepolizumab and benralizumab in really eosinophilic asthma did great in reducing exacerbation by 50, 60, even 70%. Drugs such as dupilumab, because this drug works on IL-13, which prevents smooth muscle contraction, it also showed some bronchodilation effect. Look at the really FEV1 after using dupilumab. It's as good as LABA or really Ventolin, but also reduces exacerbation. And finally, tezepelumab, anti-TSLP, works great in patients with high T2, but also the only biologics that work on non-T2 asthma by working on really the airway hyperresponsiveness. But that's not the end of the story, because we are moving a step forward now from controlling asthma to trying to reach clinical remission. You know that for the last 200 years, we've been working on controlling asthma. And that goes from having asthma symptoms control, less exacerbation, maintain lung function. But now, thanks to our colleague from rheumatology and oncology and others, we are moving forward to the status of clinical remission. We would like those patients to be in remission. And what do we mean by that? We would like to have those patients have the 4 criteria. No symptoms, no exacerbation, no need for oral steroid or systemic steroid, and very stable lung function, and that should be maintained for 1 full year. So you would like them to be disease activity free for 1 full year to say that patient now not only in control, but he or she is in remission. But now remember that this is remission on treatment. And this is one step ahead, or really before the next step of really full remission, which is remission of treatment before we reach the cure. So this is one step forward towards cure, hopefully in asthma, in the coming decade or so. So now this vision of clinical remission becomes a target of most basically asthma doctor. And guess what? With the biological therapy, we are able to reach up to 30% of patients with severe asthma, those whose life were miserable before. We can put them into full remission with biological treatment. So I think that was great success. It's one step towards the cure of asthma. What about COPD? Now, COPD is a bit different. COPD is a chronic killer. If you look at the data, now there's about 400 million patients with the COPD all over the world, thanks to the tobacco smoker, basic smoking company. But what's important to know that now COPD is the third likelihood cause of death worldwide. It comes after ischemic heart disease or vascular diseases and cancer. So it is a real thing. It is really, really bad disease, and it affects the patient in different modalities. And the Goal 26, which was just released a few weeks ago, talk about three main things. This is the concept of cardiopulmonary comorbidity, or the cardiovascular. It's not cardiopulmonary, it's the cardiovascular comorbidities, mortality improvement, and can we start using biologics even in COPD? What we know that after you get a lung attack, I don't like to call it exacerbation. It's very similar to the heart attack. After COPD patients get a lung attack, their mortality became very, very high. And about 20% of those patients die after 1 year, and about 50% of those patients die within 2 to 3 years. So exacerbation or lung attack in COPD patient is a game changer. And we know that after a single exacerbation, you can see that those patients took them about 2 years to go back to their really functional status. Their really 6-minute walk distance does not come back to the baseline. Decline in the lung function loss becomes accelerated, but the mortality of those patients basically jumps. And if you look at it, one hospitalization, which we call it now lung attack, the mortality increased dramatically in those patients. But not only that, what killed those patients is not their lung, it's their heart. And that's extremely important. And we start realizing what's happening between heart and the lung in those patients. Why they die with a heart attack or with a stroke after acute exacerbation or after acute lung attack. We know that among COPD patients, if you control for the smoking, diabetes, hypertension, etc., COPD patient versus non-COPD patient are more likely to have heart condition, and they more likely to have acute myocardial infarction, irrespective to their basically smoking history. And when you look at this kind of correlation between the two, we know that COPD is a disease of systemic inflammation. And when people die with acute myocardial infarction after COPD attack, when they go for autopsy and they look at their coronaries are invaded with a neutrophil, the same cell that is present in the lung. So it seems that COPD spill the inflammation outside the lung to the systemic organs, including the heart, including the pancreas, so you can get more diabetes with COPD compared to a non-COPD patient. Can we decrease mortality in COPD with medical therapy? Now we can say yes. Finally, we have drugs that work on the mortality in COPD. And these drugs, according to the guidelines, are only the triple therapy, triple inhaler therapy in COPD based on two major studies, the IMPACT and the ETHIS study, using ICS LABA-LAMA in patients with advanced COPD or with eosinophilic COPD. And you can see that the number needed to treat to prevent one death is much better than statin in heart failure. It's about 80 to 120. Statin in the range of 120 to 140. So this triple therapy in those patients is extremely important to be used in those patients who are candidate for the treatment. Finally, a few words about biologics. I do have 2 minutes, and I'll finish in 2 minutes. So basically, biologics in COPD, again, following the asthma strategy. Now we're talking about those patients who have type 2 inflammation, eosinophilic COPD, very similar to eosinophilic asthma. We know that they are only 20-30%. Nevertheless, this is 30%, 1 out of 3, that can be improved with biological therapy, because we know that whenever you have eosinophilic COPD, the mortality of those patients is very high. And again, we are targeting the same mediators, IL-4, IL-5, IL-13. And now you can see that these medications are now accumulating, going from anti-IL-33 itepekimab, anti-TSLP tezepelumab, anti-IL-4 dupilumab, mepolizumab, and so on. The two drugs that now are already in the guidelines are the mepolizumab, anti-IL-5, based on multiple trials. The METRIC study, looking at eosinophilic COPD, showed significant improvement in exacerbation, no much effect on the lung function. The METEOR study, again using mepolizumab, was negative, unfortunately, but these two trials did not look at specific eosinophil count. They used eosinophil count of 150. When we go to a different study called the MATINEE study, looking at those with already triple therapy, eosinophilic COPD more than 300, the drug was effective, and there was significant reduction in exacerbation in those patients. So now mepolizumab is recommended for severe COPD on triple therapy, not well controlled. And finally, the other drug is dupilumab that was tested in 2 studies, the BOREAS and NOTUS study. It was very effective in patients with eosinophilic COPD, but chronic bronchitis phenotypes, not really eosinophilia, not emphysema. So my take-home message to you, ladies and gentlemen, I think we are moving forward in asthma and COPD from inhaler therapy that fits all to more like phenotyping those patients, especially when it comes to the inflammation of high T2 or low T2. We look for specific biomarkers, and we have a specific outcome now. We are reaching the status of clinical remission in asthma. What about COPD? COPD, again, I think we are moving forward. We are really recognizing the impact of the lung attack, the exacerbation. We are now recognizing the cardiovascular comorbidities, and we are very aggressive in treating those patients to prevent that from really happening. And I think now we have drug that improves survival, which is the triple therapy. And finally, I think biologics are coming, and hopefully within few years, we're going to talk about clinical remission in COPD as well. Thank you very much for your attention.
Thank you, Dr. Majdi, for your informative presentation. It's our pleasure to introduce our next speaker, Dr. Hawayan Zhang. She is a professor of clinic pediatric and attending neonatologist, director of newborn and infant chronic lung disease program at Children's Hospital, Philadelphia, University, Pennsylvania. And she is the director of Division of Neonatologists, Women at Women and Children's Medical Center in China. It's your floor, Dr. Zhang.
Thank you. I'm so happy to be on the podium again. So Mr. Hassan gave me this topic to talk about modern approaches to infant ventilation, specifically with hypoxic respiratory failure. So I have no conflict of interest to report. I will mention some products, commercial products, but I have no relationships with any of the companies. So today I think I would start with talking a little more about the etiology of neonatal hypoxic respiratory failure and the role of mechanical ventilation in this kind of disease. And then go into discussing the current insights on the best approach to the infant ventilation in hypoxic respiratory failure. And then review some of the advances. You may or may not think this is true advance, but we'll see. When we talk about hypoxic respiratory failure in the neonates, it's a group of diseases that have very different reasons. But then, no matter what reason it is, it comes down to with insufficient ventilation and also deficiency in oxygenation. And when we look at the common causes of neonatal hypoxic respiratory failure, it is actually very different from what you see in adults. Now, I put it in a table to show you different categories of disease. The first big category for us is lung disorders and also transitional problems. Remember, neonates facing a transitional period. They have to come from a fetus living with the mom. The mom actually do most of the job, right? And then coming into the world, now they're facing the world themselves. So some of these babies have a difficulty with transition, and especially the one we commonly say is like when we have persistent pulmonary hypertension of the neonates. It presents as acute hypoxic respiratory failure. But that's a very unique disease in neonates. You won't find it in the pediatric population. You won't find it in adult. What we're talking about is changing from, they're having a hard time switching from a fetal circulation into the childhood circulation. But then we also have a big category of congenital abnormalities. I don't know whether you have taken care of children's newborns with congenital heart, like the CDH, the diaphragm problems, Jandal fallacy, or other issues causing lung hypoplasia. And we also have babies born with structural lung disease. Basically, the structure of their pulmonary venous and bronchi and the arterial, it's not like in line properly. So that's what we call alveolar capillary dysplasia. And then there are other factors causing hypoxic respiratory failure. For example, baby may have experienced perinatal asphyxia, birth asphyxia. Mothers have diabetes. These babies may have different kinds of birth defects, and also they typically have immature lungs. Or prematurity is a big problem for us, Down syndrome or some idiopathic disease. Now, the role of mechanical ventilation in hypoxic respiratory failure in the neonates, we talk about it basically, the way I see it, there's two roles. One is to improve oxygenation. On the other hand is effective ventilation. But these goes hand in hand. You cannot separate them out. So effective ventilation a lot of times would improve oxygenation. And then we also have to think about optimizing ventilation perfusion. And with that, we can help the pulmonary vasculature to relax. And that would, you will improve the hypoxia. And from previous evidence, we know that pulmonary resistance is very sensitive to oxygen. And these are animal studies and human studies looking at under room air or 100% oxygen, how is the pulmonary artery look like? And also the transition time from fetus into newborn life within the 30 minutes, and your pulmonary resistance will change. And the change is different. It's much faster with in a higher oxygen environment. And also, we also know that acidosis potentiate hypoxic pulmonary vascular constriction. So this doesn't truly matter is metabolic acidosis or respiratory acidosis. When the acidotic environment, I draw a red dot line there. If you're looking at the x-axis at PaO2 of 75, but if you have different pH, your pulmonary vascular resistance is several-fold different when your pH is low versus a more normal pH. So hypercarbia and respiratory acidosis increase pulmonary vascular resistance. But at the same time, overventilation and respiratory alkalosis may decrease pulmonary vascular resistance. And this is why years ago, before we have nitric, we kind of do a therapy called overventilation. So people used to drive the baby's CO2 down to teens and 20s. But then what we found out, when you do that, you decrease their blood flow in their head, and they have long-term consequences of neurological damage. So we stopped doing it nowadays. We also know from previous evidence that lung volume and PVR, goes hand in hand. So it's basically a U-shaped curve when you have your at the best pulmonary vascular resistance lowest is actually at PVR. When you have over-distension of the lung or you have under-recruitment of the lung, your pulmonary vascular resistance both go up. So these are some of the biological evidence. You can say these may be low-level evidence, but these are the physiologics that we go by. And when we think about what is the best approach of infant ventilation with hypoxic respiratory failure right now, I would still go by the physiology. Think about what is the pathophysiology and what is the lung mechanics. Then you can choose the correct ventilation strategy. So I would say understand your disease pathophysiology first. Now, is this a baby that has perinatal asphyxia causing difficult transition, relaxation of the pulmonary vasculature, and therefore has high pulmonary vascular resistance, or is this an infection, right? So what is the underlying pathophysiology? And at the same time, figure out the lung mechanics. And you can figure that out at the bedside, looking at your ventilator, how the patient is interacting with ventilator. This morning, some of the talks actually showed beautiful graphs that you can actually figure out what's going on with the patient. And then with those, determine your mechanoventilation strategies. I gave you an example. One of the most common hypoxic respiratory failure that we would see in neonates is meconium aspiration with persistent pulmonary hypertension of the neonates. And when you look at the pathophysiology, we know meconium is thick. It can cause mechanical obstruction, but it also can cause chemical pneumonitis. And with that, these patients actually are at risk for atelectasis in some area if that area of lung is completely blocked by the thick meconium. Or they can be at risk for air leak. And with this, when you have meconium aspiration, you have inflammation in your lung, you have high PVR, you have surfactant inactivation and dysfunction, right? So when we look at it, let's look at one case. This is a baby that born at term, C-section for fetal distress, and has meconium-stained fluid, and then had some acidosis from the cord blood, but the baby had progressive respiratory distress, initially needing CPAP, not getting better, and got intubated. And you can see, once the baby got intubated, the CO2 got slightly improved, but the PaO2 progressively got down, right? And the saturation wasn't that ideal. Now, this unit, this is actually a baby I received in Guangzhou. I have to put on ECMO, because this unit only thought about, okay, this is a baby MAS PPHN, but this has neonatal ARDS and has inactive rate of surfactant. So they diagnosed an ARDS, put the baby on high-frequency ventilation, and gave 3 doses of surfactant. Guess what happened? This kid ended up with big pneumo, and they did not have a good ability to drain the pneumo, and we had to emergently transfer this baby and ended up having to put this baby on ECMO. So with that, when you're trying to treat disease like this, you have to think about the pulmonary mechanics alongside with your pathophysiology. And in meconium aspiration, these kids, like it can form a valve effect, and there are areas that airway resistance dramatically go up, the lung compliance come down, and the time constant is high. So when you ventilate these kind of kids, you have to think about this lung physiology and pulmonary mechanics. And you have to understand these babies are very prone for air leak. And let's look at another case. This is another term baby with meconium aspiration with PPHN, 3.6 kilo term baby, and this is the vent setting that initially was put on. Well, the blood gas wasn't that nice. PCO2 72, PaO2 was low at 39. So the team increased the PIP to 30 and respiratory rate to 50. But guess what? This is the X-ray. The lung is not open at all. So when you do this, you look at the tidal volume that it's achieving. 3.6 kilo baby, you're giving not even 4 per kilo of tidal volume. This lung is not open. And essentially, what's the problem with this kind of vent setting and the vent adjustment is that they choose, I had a typo here, they choose a mode of PCS-MV, but without pressure support. So the spontaneous breathing was only supported by a PEEP. And with the pressure control, the target, like the reached tidal volume is very variable. And then when the gas is not good, they went up on the PIP, but they didn't touch the PEEP. So you end up with something like this. This is a rabbit lung we simulated, that you can see that in high pressure it opens, and when you don't give enough PEEP, it kind of collapsed down. So now you ended up with a repeated open and collapse and end up with shear stress. And these kind of babies will be much more prone to air leak. So this is an article we have published in 2024 looking at these kind of babies, what we do based on physiology and lung mechanics. And these are only suggestive initial settings, and then you have to look at your baby. The second thing we need to pay attention is heart-lung interaction. What we want to do is to maximize the VQ match. And if you have lung completely not open, you end up with right or left shunting intrapulmonarily. Or if you have over-distension of the alveoli, you ended up having not enough blood flow in those areas, you have increased dead space. So for these kind of babies, when that happens, they are hypoxic. You're simply pushing up on vasodilators will not work. And sometimes it will even get the baby worse. So there are a bunch of hemodynamic changes in PPHN or other hypoxic respiratory failure situations in the neonates, and we have to think about not only treating the lung, but also how the heart would react. And this is the algorithm that was published last year, and you can see on the left side is all how you optimize lung recruitment, how you achieve respiratory support. And then with that, you have to think about how do I do in the middle is the cardiovascular support. And then towards the end is whether I give vasodilator. So vasodilator is never the first line treatment for hypoxic respiratory failure. You have to take care of have the lung recruited, have the heart supported, and then think about vasodilation. All right, let's move into some approaches, like some new advances in this area. One of the things I would not call it a new advance, but however, because I've seen studies published about 10 years ago, but there was really not a whole lot of study until recently. I saw some newer article talking about using OSI versus OI to monitor oxygenation. So we all know, a lot of us use OI to judge how the baby is oxygenating and use that to judge whether I need to put the baby on ECMO or not. But you not necessarily have an arterial gas to determine the OI. So what can you do? This is 2 studies looking at using OSI, means mean airway pressure with the inhaled oxygen concentration, and divided up by the SpO2, your saturation. And you can see these studies are, one is 123 babies, one is 77 babies. They do have different cutoff line to predict OI over 15 or over 25. But they do have a pretty good correlation between OSI and OI. So if you really cannot get arterial gas, you probably can do this. And how do we monitor the ventilation? Typically, we get blood gas too, but that requires blood draw. Nowadays, we do transcutaneous PCO2 monitoring. So this is a term baby that also has hypoxia, and PCO2 wasn't good. And that's the X-ray the baby has. So the baby wasn't able to maintain his saturation on the conventional ventilation, had to go on to high-frequency oscillation. And the team started a setting like this, and they started monitor the transcutaneous PCO2 and transcutaneous O2. And then afterwards, they adjusted the vent setting, and now you see the CO2 is coming down. The PaO2 the O2 is actually coming up. So this helps to adjust vent support without the need to draw blood, and it's a kind of a real-time monitor. We also use that to combine the use of transcutaneous PCO2 monitor and also exhaled CO2. We really use exhaled CO2, untitled CO2 in the NICU because of the dead space. However, for some of the bigger babies, this is one of the baby at top with severe hypoxic respiratory failure after a trach. This is a baby with bad BPD. Trached, we could not ventilate, 100% oxygen, just not doing well. And we talked about whether we need to take that lung out. So the left upper lobe is so hyperinflated, it basically squashed down all the rest of the lung. So we thought about maybe we should take this part of hyperinflated lung out. But BPD babies don't have enough lung to begin with, and I don't want to just cut off a lung, right? So what we did is actually under my bronchoscopy, we put in balloon catheters into the right upper lobe bronchi, blocked it, and then monitor how the baby does. And turns out, before we started, the PCO2 is higher, like over 70, but the transcutaneous CO2 and untitled CO2 is similar. As soon as we block that left upper lobe, transcutaneous CO2 went up to over 100, ET CO2 went down to less than 10. We basically figure out this baby, that part of the lung is the main ventilation part for that lung. So we decided we could not cut that lung off. Okay, this baby actually already decannulated and doing well nowadays. All right, the other thing that's really hot worldwide is point-of-care ultrasound. And this is an example that how it can guide treatment in babies like this. So this is a 23-weeker, now 7 months old with severe BPD, has severe pulmonary hypertension and persistent hypoxemia. 100% oxygen, nitric, being paralyzed. And what happened is when we did the point-of-care ultrasound, we found out in the front, the lung is open, very collapsed on the back. So this baby was ordered to prone over 12 hours a day. And this is, you can see, the percent time of the saturation over 90 over the days that, the longer the baby has the prone position, actually improved gradually. Okay, so that's an ultrasound-guided treatment. And I think the talk in the morning mentioned the EIT, and I do see some role of EIT in neonatal hypoxic respiratory treatment. This is a study in adult, basically showing you PEEP titration, looking at overextension and atelectasis area. But traditionally, we have difficulty using EIT in the neonates, simply because we don't have small enough belt. Now we do. So I do see potential that this EIT monitoring can help individualize ventilator settings, even do PEEP titration for us, can do a lot of things. The other thing that the Chinese folks has been using a lot is this non-invasive cardiac function monitor. There are actually two types, one by ultrasound. This one is it's a simple one. It actually can spell out a bunch of cardiac function parameters, helping you to understand the hemodynamics. And you can use this in conjunction with your ventilation to try to determine what's the best way to ventilate. Next generation sequencing is something big in precision medicine nowadays. Now, there are two roles of this. I think most of you guys will hear whole genome sequencing or whole exome sequencing for genetic disorder. But something else is also very popular in China now, that using NGS for infectious disease diagnosis. Both of these are super helpful. So I had two babies on ECMO at different times. One, the course didn't go along what I thought should do. We sent out the whole exome sequencing early on, at the time the baby went on ECMO. We expedited the result. It turns out that baby has ABCA3 deficiency. Talked to the family about it, came down from ECMO withdrawal care. Okay. A second baby went on ECMO with no reason. Hypoxic respiratory failure, really bad PPHN, no reason. We couldn't find out the reason. NGS showed this kid actually has herpes infection. We sent herpes testing initially, but it was negative. Okay. And we also send these kind of testing early on. If it's negative, it actually helps us to stop antibiotics. Okay. Nitric treatment in hypoxic respiratory failure has a big role, right? I'm sure you guys have already heard about it. But now there's new generation of tankless nitric delivery systems. And I show you in this slide two kinds of system. On the top, Vero is in the United States. The other one is from China. So those are cascade-based from chemical reaction and create nitric. In the bottom, this beyond area is in America, and the other one is in China. So those are got by high voltage cleavage of air into nitric, okay? So these kind of systems enabled us to move beyond this big tanks into the small handheld system. You don't need any tanks. And this is a picture that we were transporting a severe BPD kid on high-speed train. And the kid needed ECMO, needed nitric. So you can see that dog holding the handheld device of inhaled nitric. Very convenient. All right, in terms of changes in treatment, now we're starting to explore high frequency with volume guarantee. In the state, we only have Sensormatics, so you don't have the ability to add volume guarantee. In China and in European countries, those ventilators are dual-mode ventilators, but also there are a bunch of monitoring and you can add volume guarantee. This is a study showing that this is like for babies after PDA ligation fall apart with acute hypoxic respiratory failure. And using high frequency VG compared just high frequency, you can see decreased episodes of hypocarbia or hypercarbia. So basically, your CO2 is a lot more stable. All right, the last resort of hypoxic respiratory failure is ECMO. We do that both in CHOP, and I do that in my Chinese unit too. The problem now is you can see on the right side of the curve, these blue areas are the neonates with pulmonary disease needing ECMO. And the x-axis is years, so you can see it came down so dramatically. On the left side chart is also data that you can see the newborn went on ECMO because of pulmonary disease. The survival rate for 24 hours survival after ECMO was 84%. Survival to discharge is about 73%, okay? Now, a lot of babies, because of our advancing neonatal care, we don't easily put these babies on ECMO anymore. However, the ones do need ECMO, it's so much sicker, so much harder to manage. So you really have to think a lot more, and also have to think about rare disease too, and that's why we send out the infection workup, we send out the genetic workup for a lot of these babies. All right, in summary, hypoxic respiratory failure to me is a consequence of different disease process that when we treat this hypoxic respiratory failure, we need to target the underlying pathophysiology and also lung mechanics. When we understand the pathophysiology and lung mechanics, we will be able to really provide the best mechanical ventilation strategies in these babies. Now, the newer advances I talked to you about, they are very exciting, but there's a problem that some of the units just go ahead and do it without being well trained and do not have good quality control protocols. Then it actually may bring harm, right? So those are good aids, but I don't think it can substitute good bedside practice. So I would still go back to the bedside. I would think about these tools, use these tools as aids, but not completely rely on it. That's all I want to talk to you about today. Thank you.
Thank you, Dr. Zhang, for this insightful presentation, and it was really enjoyable. Now, let us introduce our next speaker, Dr. Emily Lamorina. She's the Director of Respiratory and Pulmonary Asthma Program at Children's Hospital of Orange County. She's also the AARC Chair of Neonatal and Pediatric Section. Dr. Emily, the floor is yours.
Thank you. Good morning. So we're going to talk about bronchiolitis and high-flow nasal cannula. Here are my disclosures. At the top, that's all voluntary work. I am a paid consultant by F&P and Vero. I do not believe I have any conflicts of interest pertaining to this topic. And our objectives for today is we're going to review the evidence for the use of high flow when we're treating infants with bronchiolitis. But what I really want to focus on is the development and the importance of RT-driven protocols to actually reduce what has now become high flow overuse and overutilization in this patient population. So let me set the stage for you. It's 2022. America is just trying to recover and rebuild post-pandemic, and many departments were working with critically low staff, with high rates of turnover. We're barely starting to rebuild, and by September, these headlines started to fill our screens. And I'll tell you why that's bad. In pediatric hospitals, at least in the US, our viral season usually peaks. It starts end of November, December, and peaks in February. But what we saw was that by September, our pediatric ERs were already getting inundated with pediatric patients. And across the country, we were operating in crisis mode. We were putting back our incident commands. We were engaging with the National Guard, setting up mobile hospitals. It felt very 2020 again, and we all said, can't we just get a break? And by October, the pediatric bed capacity was already filled 71%, which is the highest it had ever been in October for at least 2 years. So to already be filled to 71% only in October, and we had no idea when the peak would actually hit, put us all in a lot of fear of what was to come. And by November 14th, the American Academy of Pediatrics and the Children's Hospital Association wrote a letter to the White House begging them to declare a national health emergency, to initiate a national response to help us with this alarming surge of pediatric viral illnesses. And just to orient you and show you visually what this looked like, what you see here on the bottom, it starts with October, goes all the way to September. You can see we normally peak around the January, February. The green is obviously the year I'm talking about right now, that by October, that is astronomically high for any amount, past any peak we'd ever had in history, and earlier than we'd ever been anticipating it. So this was a huge issue, and this is what famously became called our triple-demic, because this was also the year that pediatric flu hospitalizations was the highest it had been in a decade. And while COVID did not really affect us in the pediatric population, what it meant for us was that while we were surging, we couldn't really count on our adult counterpart hospitals for extra bed spaces because they were yet going through another surge. I don't know about you, I think I've been through enough demics in my lifetime, but I think it's always important that when we are put through stress like this, that we continue to learn and be prepared and do better in the future. So before we get into how to treat bronchiolitis, I want to do a very quick review over the disease. So it is the most common diagnosis of children, and it's in less than 2 years old. 90% of children will be infected in the first 2 years of their life. Now, this was a big question of what actually happened. Did the disease get worse, or was it more severe? And the truth is, it wasn't. It was still a very mild disease, and it's still a very small percentage that would get escalated to going to the PICU. It was just the sheer number of them showing up at the same time in the hospital. And I think what happened was, from 2020 to 2022, when we were in remote schooling and masking, those kids who have normally gotten infected for the first time, turns out when you're not in close quarters, licking toys and playing with each other, they stayed pretty healthy. So now we were seeing all those kids who did not get infected, so they were 3, 4, and 5 years old, in addition to the 0 to 2-year-olds, and they were all coming at the exact same time, overwhelming our system. It is a leading cause of hospital admissions for infants, accounting for 100,000 inpatient admissions, 18% of overall and 10% of our PICU, 2.1 million outpatients, and accounts for about 100 to 300 deaths in children younger than 5 years old. That could scare you, but just realize that in the 1980s, that number was as high as 4,500. So we've actually learned so much in the last decade about how to appropriately manage this, that it is now a very mild disease with very low morbidity and mortality. I also want to remind everyone that while they're sometimes used interchangeably, RSV is not synonymous with bronchiolitis. Bronchiolitis is a disease, and RSV happens to be one of the viruses that causes it. It is the main one, about 80% of our cases, but it could also be due to adenovirus, human metapneumovirus, or the flu. Knowing the specific culprit does not really change your management. We still very much manage the patient based on their clinical symptoms. So what is bronchiolitis? It's exactly as it sounds, itis of your bronchioles. It is a result of the inflammation of the epithelial cells that are lining your small airways. So it's going to cause inflammation, increased mucus production, necrotic cells. Now what happens when the necrosis of those cells, they're going to come off and slough off into your airways. So now you have what we learned yesterday was already small airways that are now inflamed with slough filling it that's going to greatly reduce the diameter of your airways. When you have greatly reduced diameter of your airways, what do you think you hear when air is going in and out? A wheeze. Is that wheeze due to bronchoconstriction? Will albuterol help? Okay, my talk is done. I hope I can see you guys later. No. Yeah, just remember that. As a mainstay, we will go over that. But also, all of this together also increased respiratory, resistance, both inspiratory and expiratory. So you're going to have air that has a hard time getting in, as well as air that has a hard time coming out. So it's going to cause that ball valve effect. So you're going to have some areas of your lung that have hyperinflation, some that are atelectatic. This is going to cause a lot of VQ mismatch, which becomes the hypoxemia that we see. And the virus itself can destroy our ciliary cells, which is an additional insult. So in the face of increased mucus production, the baby's normal response to clear their airways is impaired. So that's really what we have to help these infants through, is helping clear their airways so that they could breathe better. The treatment. I always walked around the hospital saying, stop touching the baby, stop doing so much, you don't need to do it. We tend to overtreat it. I understand it's hard to see a baby who's breathing in the 80s and retracting and struggling, but I want to remind everyone the care is mostly supportive. The number one thing is to support their hydration, because babies are obligate nose breathers. Now, when their nose gets stuffy and they can't breathe in and out of it, they start becoming mouth breathers. What happens when the baby is dependent on mouth breathing and you put a bottle in their mouth? They can't, right? So usually my recommendation to parents, if they're concerned about whether or not they need to bring them into the hospital, I normally ask if they're still having wet diapers. If they're still interested in feeding, you should be okay, but any concerns of dehydration, they should bring them in. Shallow suctioning of the upper airway. I repeat, shallow suctioning of just the upper airway. Deep suctioning is no longer recommended. Many studies have shown that actually just increase the adverse events with no change in outcome. And of course, you want to treat the fever. That's all. For a majority of cases, this is a very mild disease. You just have to support the baby through the course of the virus. You only want to use oxygen if they're satting less than 90. There are some pretty high-quality studies that show that try to target higher sats only prolong their stay with no change in outcomes. In fact, on our units, even on the floors, we don't really do continuous pulse ox monitoring. The more you monitor it, the more scared you get, then you add more treatments to them. So you only want to target, you are not concerned unless they're satting less than 90. And of course, while this is not within the scope of this talk, there are a number of risk factors that could predispose a baby to having escalation of care and needing ICU care. So with anyone that's coming in, we're going to monitor closely if they fall into that risk category to ensure that they don't get any worse. As far as treatment, we're lucky to have a lot of international guidelines that give us our evidence for our care. What I'm showing you here is our gold standard in America. This comes from the American Academy of Pediatrics. I'm not going to go through the entire document, but I will highlight the treatments that will affect us most as the RTs. You ready? For the routine treatment of bronchiolitis, bronchodilators, not recommended. Racemic epi, not recommended. Corticosteroids, not recommended. CPT, not recommended. Hypertonic saline, maybe. The evidence is not as clear. However, I will tell you, it is not recommended for frontline therapy for your standard care. And in my practice, we usually only consider adding it in if there's at least 24 to 48 hours of zero resolution, and you want to try something to try to help the baby improve better. But again, for the most part, we just need to support the baby through the course of this virus. So now I want to talk about high flow. And thankfully, Brady talked a whole lot about it, so he helped cut out a lot of time for me to describe it. But I do want to mention it actually was first created for neonates to treat apnea of prematurity. As they have some immature, the breathing center would cause them to have these periods of apnea. That little whiff and blow would stimulate them and help them continue to remind them to breathe. Now, as a reminder, it provides flow. The actual definition is meeting or exceeding your patient's inspiratory flow or their minute volume. Just for range, I'm not sure how many peds people I have in here. The normal minute ventilation for neonates and infants is around 240, 360 mLs per kilo. For easy math, let's take a 10-kilo baby. So that's about 3.6 liters. So in the literature, you'll often see it as described as 4 liters or more. However, I'll remind you, that's for a normal, healthy baby. If an infant comes in and they're breathing in the 80s and they have a really high drive, that number's a lot higher. So we have to keep that in mind if we're actually going to use high flow to meet or exceed their demand. And just like Brady mentioned, for the adults, we started using this without really any clear evidence about what to do. We were really scared of flow. But in the last decade, there's a lot of strong evidence for weight-based dosing. What was first brought out about 10 years ago was the 2 per kilo. That terrified us. We were always scared and thought we were being dangerous by going up on 6 liters, 8 liters, and then all of a sudden guidelines were telling us to put 25 liters on a baby. I remember being there and we were all watching very scared. We thought they would fly off the bed. But what actually happened is you had a baby who was breathing and struggling, and then all of a sudden you put that flow up, and then they calmed down. Parents were able to hold and console. We could feed. And we are much more experienced now that no one is scared about the 2 per kilo, but that was a huge shift in how we managed it. I will talk about dosing. It is 2 per kilo up to 12 kilos, and then we have evidence-based doses at larger sizes, which I will show you. So up until this point, we didn't have any way to treat bronchiolitis other than a nasal cannula. So babies would come in, we would put them on nasal cannula. If they failed, we would intubate. So the high flow kind of gave us this really cool intermediary way of trying to help. So it was, again, introduced in the early 2000s. By 2010, the institutions that adopted it started sharing their experiences and publishing these. So around 2010, and this was out of Australia, and you can see here, between 2005 and 2009, after the implementation of high flow in their units, they actually increased the use of it from 13 to 66% of patients, and they reduced their rates of intubation from 37%. That is just wild to me. If you guys, the thought of intubating 37% of the bronchiolitic infants that come in is just wild, because we never intubate patients who are on bronchiolitis unless they are very, very severe. It's very rare. But the fact that we brought that down from 37% of infants to just 7% just with the implementation of high flow. And then later that year, this came out of Tufts. And similarly, after implementation of high flow, the rates of intubation dropped from 23% down to just 9%. And the length of stay cut almost in half, from 7 days in the hospital to just 4. Clearly, this is a cause for celebration. We finally figured out how to save the babies. And while we didn't really quite understand what we were doing with it, we knew that high flow played a really important role, particularly in infants with bronchiolitis. And in the following years, this followed many other similar studies that were showing that were supporting that if you implement high flow, early initiation, prophylactic initiation of high flow would dramatically reduce your rates of intubation, improve your clinical symptoms, and improve your outcomes for your patients, which was super exciting. And then this became the sign. Now everyone gets high flow. And it was, if you hear bronchiolitis at the door, I remember as an RT, I felt like a super RT. I was running around the hospital with poles, and anytime I heard that bronchiolitic cough, I would run to the ED, just place it. It was like Oprah. It was all your favorite things. You get a high flow, and you get a high flow. We didn't even assess the patient. All we knew was if an infant comes in with bronchiolitis, put high flow on them. That's what we do. The thing is, we didn't really know what we were doing. We had no evidence to really guide how to put it on, really no evidence about how to take it off. And it's funny because our MO in peds is low and slow because you don't want to break the baby. So, and I'm guilty of this, I will very vulnerably admit. Without really any knowledge, I wrote a weaning protocol in 2017. And it was wean by 2 every 2 hours. Then when flow is less than 10, wean by 4. It was so arbitrary, I had no idea. And then what would happen is, that's really hard to do, like RTs to assess and come around every 2 hours to go down by 2 liters. And then once the baby did not tolerate it, what would we do? Go back to 25 liters because everyone got scared. So it was a terrible weaning protocol, but we just knew we had to go low and slow to guide the baby off. However, I will just say all of those studies that led to that practice were all retrospective in design, and it clearly filled a gap of knowledge and a gap of support that we had for a very vulnerable population. However, in the last few years, we've actually had several large multi-center randomized control trials tell us a completely different story about high flow and bronchiolitis. So this was published in 2018. It is the largest randomized control trial looking at infants with bronchiolitis, and it's dubbed the Paris trial, and included almost 1,500 patients in 17 different EDs, and they were looking at, they had two groups, high flow versus standard oxygen therapy, or nasal cannula. However, when I was reading it, what happened was if they failed nasal cannula, they would get put on high flow. And in my mind, as I'm thinking critically, if both groups at some point could possibly get high flow, it's not high flow versus nasal cannula, it's whether it's immediate and prophylactic or rescue. So the results are unsurprisingly, in the nasal cannula group, they had significantly higher rates of failure. That makes sense. However, even those that failed, 40% of them were saved on high flow and didn't escalate past that. And whether you started on high flow immediately or got put on by rescue because you failed nasal cannula, you had no difference in the rate of PICU admission. So between the two groups, whether immediate prophylactic high flow or rescue high flow, there were no significant differences between PICU admission, intubation rates, any adverse events. So the results showed us that there's actually no difference in clinical outcome between immediate high flow or rescue, which blew our minds. What do you mean I don't need high flow on every patient? That's how I grew up as an RT. I know every baby needs high flow. That's also what every pediatrician heard. And so this was really even hard for all of our teams to say, wait, we don't need to put them on right away? And if you ask me, and putting on my leader hat, if two therapies have the exact same outcomes, I would always choose the least invasive and the cheaper one first. And then this followed several other large randomized controls that said the exact same thing. In the treatment of bronchiolitis, high flow is most appropriately applied as a rescue therapy and not as a prophylactic immediate therapy. And this followed, what happened, especially during the triple-demic, is that the cost of care for bronchiolitis became astronomically high. And because of the amount of admissions and how much we were using and how much money we were using to spend for these patients. And so this was published in JAMA in 2021, and it was actually kind of looking into that. And they were saying, we were just using so much more money, $700 million annually to spend on care for bronchiolitis, and they were just getting more NIV, high flow, but there's actually no difference in outcomes and no change in the disease, but we were just doing so much more for those patients. And this followed several other review articles that were criticizing this, is why are we overutilizing it for a disease that does not change, but we are just adding more and having longer lengths of stay, more ICU stays because we're putting in more therapies. And they ultimately said that high flow use in the management of acute bronchiolitis has been increasing in frequency over the last decade, with associated increases in ICU utilization and total costs without any convincing benefit to support why we're doing this. So then the focus changed. It wasn't put every patient on high flow. It was, okay, it clearly has a role, but now we need to figure out who actually needs it. And if they do, we do want to get everyone still on that optimal weight-based dose. But then this was also a big thing that came out in those earlier trials. They actually did high-flow holidays. Now that was crazy. They didn't go down by 2 every 2 hours by 25, 23, 21. They just said, support the baby through the disease, don't touch it. Once their FiO2 is less than 40%, take it off. That, I think I had a lot of mean stares when I was staring at a group of physicians that was going to become our weaning protocol. Again, because that was so against our beliefs of how you wean a patient off high flow. We were so scared, but all of those randomized control trials also implemented an aggressive holiday. So this has all changed in the last few years of how we manage it, with the ultimate goals to reduce costs, the length of stay, and the length of treatment for the largest number of pediatric patients that we see every single year. I'll also tell you, in America, it's the least reimbursed disease because There's like nothing indicated for it. So no insurance company is going to pay us to keep them in the hospital for weeks, giving them all of these medications and therapies because it's just not indicated. And there's good research to show that. So we needed to focus on this. And so these were some of the protocols used in those randomized control trials that can help build a protocol that you need. So again, for dosing, we're looking at less than 12 kilos, 2 per kilo, but as they get larger, you can increase the dose as you see there. For weaning, there were 2 different weaning protocols that were introduced. One was just what I mentioned, is keep them at their optimal dose, and as long as they get over the hump of the disease, once they reach whatever criteria, you just take it off. Other protocols were a little more conservative, and they said, okay, we'll go to half and off. The main point was just take it off. It's like CPAP, right? If someone comes in and they're in an acute, if they are in an acute state of a disease, we don't go from +8, 7, 6, 5, 4, 3, 2, 1. We support them through the course of the illness, and then we take it off when they don't need it. So I was asked to look into this because they said, hey, we spent like $1 million last year. Can you really see, are we doing the best thing for bronchiolitis? My C-suite asked, can you take a look at our care? So I let everyone get through that terrible triple-demic crisis, let everyone breathe, and then they pulled together a group of stakeholders. From the ED, the floors, our PICU, I had nurses, physicians, pharmacy, everyone that we have to touch this protocol. We did a literature review. I benchmarked with other top children's hospitals, and we met, and I built a protocol, and we went back and forth about what they wanted this protocol to look like. My secret to you is there's no perfect protocol. It's whatever everyone can decide to do. So I said, here's what I'm suggesting. If your team, I just need your team to follow this 95% of the time with a few exceptions. And so we went back and forth, and we finally, in preparation before the next year, got approval. We went through evidence-based committee, and we were about to go live with our new protocol. So to figure out who actually needed it, I went through a whole number of different scoring tools because we just wanted to be able to decide if we were going to actually pause and say, I don't think you need it, you can start on nasal cannula. And so I wanted to look at what would be easiest and help the RTs make a very quick decision. And I think, with scoring tools, I will say there's no validated scoring tools in the literature. However, I will always say, if you build it with the best, you just want to ensure that there's consistency of care. And so you have to ensure your own internal validity within your own clinicians. When we built this, I do want to give credit to UC Davis, Brian Smith. This was guided off of a scoring tool that he shared with us. And it's really simple. It's just what are they breathing, what's their work of, how fast are they breathing, what is their work of breathing, and what's their mental status. And because we knew that people were really scared about this, they didn't believe that we could just not give high flow to a baby, we made it very conservative so that we would always err on the side of placing a patient on high flow to get through this pilot. So the way we made it was if you score red in any of the categories, that is your score. The highest you score. So if you come in breathing super tachypnic, it doesn't matter what you score in the other categories. It's red, you go on high flow. If it's green, you're probably fine. If it's yellow, we just say, can we pause and optimize care? Can we suction, treat the fever, console the baby, get them comfortable? Nothing revolutionary, but we're really saying, is there other ways we can optimize our care before jumping? And can we start them on nasal cannula with a short rope too? If they don't look good, we'll put them on high flow. Now, I'll tell you, most of our initiation that occurs in the ED, of course, and they were not happy about this. And I understand. They're seeing 400 patients a day. It's really easy to say, hey, put them on high flow, let's go up to the units. And so I will tell you, for the initial pilot, they did not participate. And I totally understand. It was really hard time to roll it out. They said, go do the thing on the floors and show us the data after. And I said, completely fine. And I know this is a busy slide, but I'll show you, in addition to the scoring tool of should they go on or not, we had a holiday weaning, a holiday process. So again, our thing is put them on their weight-based dose, keep it there, just wean your FiO2. Once they reach 30% or lower and they're scoring green, do a holiday trial. And what did we learn? Holidays from full support were completely safe. Patients weren't falling out of their bed because they need that support. We actually found, this was interesting, because the ED did not participate, but the floors were. Once they went up to the floor and we assessed them, Patients were being discharged after 10 hours. So that got my C-suite's attention, because they said if they were here for less than 10 hours, did they need to be admitted at all? So that helped in my argument of this needs to start earlier in the ED, and perhaps we can prevent admissions, especially when we're surging and going and having tough throughput. And then what happened, and as what we saw after implementation, the time spent on high flow reduced by 33%. And even though we didn't have our scoring tool in the ED, just by empowering the RTs to speak up and say, hey, I don't think this patient needs high flow, we reduced the use of high flow and potentially sending them home from the ED by 10%. And then, because they wanted the data magically came. Oof. Just perfect timing, because I said we need to do this. And then the American Academy of Pediatrics published this multi-center quality improvement that was over several years and included 71 children's hospitals that did exactly what we did of implementing either a weaning holiday protocol or a pause protocol, which can be paused and implement care, and they found very similar results. That was the data I needed to push the hand of saying we need to do this and fully adopt it. So now this is an example of our pause protocol, which is just if you're in the yellow, do all the things on the top before we try to jump to high flow. And what I will share is these are our goals, is identify who actually needs it when they do initiate care at the optimal weight-based doses, and then you need an aggressive standardized weaning process, all in the goal of reducing overuse. I'll also tell you, this is our value as RTs. We have to move away from task-based value. We are not valuable to our hospital because we complete tasks or do orders. We are valuable because we have critical thinking, because of our unique expertise that we can evaluate a patient, and we can critically evaluate the necessity and frequency of a therapy and implement care, but most importantly, de-implement non-indicated care to improve the outcomes, and what's important to our C-suite, the cost of care to improve outcomes for all. That is something no nurse, no physician can do on their own without the RTs. This is how we quantify our value. Don't do things because they're ordered. Do things because we are using evidence-based care. So at this point, like I mentioned, we haven't gone through all of these demics to not be prepared for the future. Ensure you have updated your clinical care guidelines, you have RT-driven protocols, be proactive with your staff education, pull out your playbooks. We should all know how to open care in non-standard areas of care, how to get agency staffing, how to triage. And my key takeaway, and I know I'm out of time, I'll just go to that large point in pink. We need RT-driven high-flow protocols to reduce high-flow overuse, ICU utilization, length of stay, and hospital costs of bronchiolitis care. And this is how we show the value of the RT and why we are needed in our hospitals. And with that.
Thank you so much, Emily, for this wonderful presentation and important topic. So let's move on to the next speaker. Again, Dr. Majdi Idris with an important topic on how to achieve a successful career. Hopefully we will get that, inshallah, by the end, inshallah. The floor is yours, Doctor.
Okay, so thank you so much. So we're gonna shift gear from medication, devices, high-flow nasal cannulas, etc., to a strategy of really building our career. And we need to think about it that this is probably fits everyone. It fits definitely RTs, physician, banker, lawyers, it doesn't matter. So these are standards that are accepted universally. And there is a roadmap for successfulness that people should understand. Those specialists, those who are expert, they should really understand these roadmaps. And if you look at them, they are kind of standards. We need to look for those who got suitable conditions, the role of 10,000, system-based strategy, and then having the golden habits. Kind of educate yourself to really follow these habits. People who kind of learn these 4 pillars are more likely to be successful compared to those who do not. So let's look for the first one, the suitable conditions. And that's what we call when the world works for you. احنا هنا نسميها basically توفيق الله سبحانه وتعالى. So basically, the conditions work for you. And let's talk about this guy. You know this guy, right? Mr. Bill Gates. Would anyone challenge that he is successful? He's very smart. His IQ level is very, very high. So there is no doubt. I don't think anyone will really argue on this. So he is the role model for successfulness. However, the world worked for Mr. Gates. If you know that he was born in the right time, he was born in 1955, and that's the time where computer science was becoming extremely important and really kind of evolving. If he was born 10 years before or 10 years after, he would miss this. With all of his smartness, etc., he will not be Mr. Gates that we know him now. He was born in America. Of course, there's a lot of opportunity there, right? He was white. We have to accept that. He belongs to a rich family. His father and mother were so influential. His basically father was a banker, his mother was a lawyer, and both kind of loved academia. So they pushed him towards really science. By chance that his school at that time, when he was on the secondary school, opened the computer lessons, courses, that most schools in US at that time did not have this. So it was by chance. Again, by chance, he lived in neighborhood of Washington University. That's again by chance that university has good computer science department. And the computer lab was available for people to come to work on it from 4 to 6 a.m. every day. So Mr. Gates and a couple of his friends used to basically wake up in the morning, early morning, to go to the computer lab and work. So differently, they were hard worker, but you can tell that all of these conditions were needed for Bill Gates to be a Bill Gates without him doing much basically to start. So this takes us to this Matthew effect. You know what's Matthew effect, right? Matthew effects mean that it depends where you start. If you start with really advantage compared to others, you are more likely to be successful compared to others, even if you have the same basically resources. So الأغنياء يزدادون غنى والفقراء يزدادون فقرا. So basically, that's the Matthew effect, which is true for the majority of time. So let's go to the role of 10,000. What do we mean by that? Now, if we ask everyone, do you agree that success equal to innate talent? And probably yes. If you are talented, you are more likely to be successful as a person. But that's not enough. You need to add to it preparation. You need to work hard on your talent before you can be successful. And if you look at those people, Einstein, Sir Magdi Yaqub, Stephen Jobs, Lionel Messi, Barcelona. Okay, basically you can tell that I'm a fan of Barcelona, right? I keep mentioning them. And then Beethoven, right? So those people are the greatest of the greatest, right? But they did not only stop on this innate talent. They worked too hard. And based on many observational studies, it showed clearly that in order to be outlier, you need to work at least 5 hours a day for 2,000 days to get this 10,000th hour of preparation. Are you willing to do that? To work or to study or to really work on your talent for about 5 hours a day for about 5-6 years? As a fellow, as a trainee, you should do that. Even as a junior really staff, probably all over you would, but really if you want to be an outlier, if you want to be very similar to those 5 huge names, this is what they did. So no weekend, nothing. You have to work 5 hours a day. If you want to be kind of exceptional, you need to work for about 3.5 hours on your knowledge, on your really talent, in order to be exceptional. If you work for about an hour a day, you'll be good. But that's it. So it's your choice where to focus in your talent to be successful. Remember that these are not random numbers. These been looked at in many observational studies all over the world, and they proved to be correct. System-based strategy is extremely important. And what that tells you is this: it's good to have a goal for success, but the journey to that goal is extremely important. No shortcut work in this situation. Don't try a shortcut. It's not going to work. It will probably work. It's gonna help you for a while, but eventually you will be spotted. It's going to be clear that your success was not based on the journey. You did not work to get that goals or that success. And let me give you an example. Losing weight, everybody trying to lose weight. Everybody trying to lose weight, right? Well, not everybody, but most people, right? And most people did what? They go for diet. Low protein diet, low sugar diet, low fat diet, interrupted fasting, you name it, right? And they focus on this, and indeed they lose weight, of course. But do you think they're going to be successful? Probably no. If you see them about a year or 2 years later, they're going to go back to the baseline because they focused on the goal, not on the journey. Other successful people will really flip it. They're going to work on changing life habits, eating with really moderation, sleep well at night, no smoking, balanced meals, go to the gym, do that, and make that as your lifestyle. I can assure you, if you do that, you're going to lose weight, and you're going to maintain it. So both parties will lose weight eventually, but those guys will not maintain it. They're going to fail eventually, while the other successful, I'll say, those who have a successful way of thinking, they are more likely to maintain weight loss. Very similar, passing the exam. I know that really our fellow in pulmonary medicine, from day one, they keep asking question, would this really question come in the exam? Do I need to know this to pass the exam? So they focus towards passing the exam more than achieving knowledge. Probably they're going to pass the exam if they know the technique, how to answer the MCQ questions, and to know about the common exam questions. So you can practice, and you're going to pass the exam eventually. But the other way around, the successful people will not think about the exam until the exam comes. They're going to build their knowledge. They're going to build their experience. And for sure, they're going to pass the exam. But whom you think that's going to be more likely to be successful? Both are going to have that kind of certificate really on the wall behind them. But who will be more successful is clearly the one who has a strategy towards the goal, rather than taking shortcut to reach the goal. And then we're going to go to the golden habit. But before that, I work as a fellow with this guy, Peter Paré. I'm not sure if you know Peter Paré. Peter Paré is one of the most famous Canadian pulmonologists. And he is one of those doctors who wrote a textbook, a fascinating textbook when it comes to the pulmonary medicine. And I was working with him in the physiology session. And he told me something very, very important. He said, Majdi, don't treat the disease. Understand it first. Try to understand what you are treating. Now, when we have severe acute asthma, I know that my thinking, everybody gonna give Ventolin. I am giving Ventolin to decrease the autopeep because I know that the intrinsic peep that's been really developed in the chest is the problem. It's really decreasing the venous return, It can increase intracranial pressure. So my goal, and I'm going to judge my treatment based on this. When I treat pulmonary hypertension, that probably you know that I'm interested in this, I'm not treating patients to decrease the pressure. I'm treating patients to improve lung compliance and decrease the pulmonary vascular resistance. Because I know that once those people die, their cardiac output goes down and the pressure goes down. And as a matter of fact, at the time of death, the pressure is zero. So that's not good things to do. So we need to understand what are we doing. And this is very, very important when you become really specialist dealing with patient, whether you are an RT, whether you are a physician, whether you are an intensive care basically person, try to understand the disease physiology before you start treating it. Don't go with these kind of tables and arrows and this leads to that and this leads to that. That does not work. So let's go to the golden habit that successful people should learn it very well, which at the first golden habit is time management. And if you look at the time management, there is those important and urgent that you need to do, non-urgent but important, urgent but not important, not urgent and not important. And let me ask you a question. Where do you think successful person will spend most of their time in? Who believe that it will be D? Let's go for D, such as really watching Netflix. It's not important, not urgent, right? Do you think successful people will spend most of their time there? Probably not. It's still important to watch Netflix, right? But not all the time. What about C? What about urgent but not important? For example, answering a phone call. That's very urgent, right? But sometimes it's not important if you're doing something more important. Now we come to A and B. Who will vote for A and who will vote for B? Let's say A. So we have few hands there. B, more hands there. Right. And really the answer is B. You don't want to spend most of your time in A because that's going to burn you. For example, when Mr. Hassan asked me to do this talk, if I started preparing for this talk last night, it will be urgent and important, but I will be under a lot of stress. If I start doing it last week, it's still important, but it's no longer urgent. If you are really sitting the exam and you start reading one night before the exam, it is urgent and important, you're going to be very stressful. While if you prepare for it, when it's not urgent, that's the way to go. So most people, successful people, will spend most of their time in very important issues, but not urgent. So build that strategy. Let's go about proactive or reactive. So if you look at it, it's extremely important. Reactive people wait until the problem happens to act. Proactive people work beforehand. They don't want. And when things happen, they pause, they think, and then they take action. So the proactive people do not take action reactively. So what do I mean by that? So let me give you an example. If you are sitting in your office, you have a lot of papers, important papers on your desk, and someone came and opened the window, and with the air current, the papers went all over the place. Reactive people will jump and start to pick up the paper, right? Proactive person will close the window before it starts, because that's what you should do, right? When you are driving your car and you have a driver behind you just like, and he wants to really pass you and he's irritating you. Now, reactive people will start shouting, open the window and say, hey, what's wrong with you, buddy? A proactive person will probably say, you know what, let him go. I do have more important business. And that can sometimes save your life, because sometimes if you're becoming reactive and you stop your car and you came out of the car to fight and the other guy came back and he's a bodybuilder, you are in trouble, right? So anyhow, so basically be careful. So really what I'm saying, try to be really proactive in everything you think. And this is where the famous diagram for those people who are reactive versus proactive, where really reactive people will start working when the total failure happens. The proactive people sense that there is something, I'm still doing great, but I sense there is something wrong, so I start working to improve that before that happens. And I'm going to take you to this book. I'm sure most of you read this book. This is a famous book by a famous author who died a few years ago. And he said very clearly, Mr. Stephen Covey, I'm not a product of my circumstances, I am a product of my decision. And that's true. Don't blame others for your failure. I know that sometimes it's difficult. Sometimes there is multiple reasons for you to fail. But do not focus on them. Focus on you and what you can do. But you can really go to a different habits, which is extremely important. That's dependent versus independent. Now, all of us we start as dependent people. When we are kids, we are dependent on our parents. When we get older, we are dependent on really our brother and sister, then our teachers, etc. During this journey, we have to build the independency. When we became good and we became independent. And that's extremely important. So this is why I keep really telling the fellows and residents, you need to show that you are in the journey for independency. Don't feel shy that you don't know the answer to really some question. Nobody does. But if you are a shy, really resident or fellow, and you always stay at the back, because you don't want people to test you, to test that journey of independency, you will never become independent. And when you become consultant or in charge or something, it's going to show clearly how dependent you are. So please take your journey and don't be afraid of it. But more important is after you learn that independency, to learn to be interdependent, to work with others, towards the success. Don't ever be a single man show. Please overcome your ego, overcome your everything, work within the team. And that is the most important advice towards the successfulness. So my take-home message to you, ladies and gentlemen, I think building your exceptional future depends on decision you make. It's not on others, nothing. It's you who decide if you want to be successful or you want to be general person. If you want to be basically outlier, if you want to be exceptional, just good, or average. Always you need to incorporate the surrounding condition that in a great time, most of the time you do not have control over it, but try to deal with it as much as you can. Build on your talent, prepare, and follow the golden habits. Remember the time management, system approach, be proactive, and be independent and interdependent. So you need to do this before you become a successful person. So always aim high, raise the bar. Don't accept anything that is okay. Challenge yourself, be an outlier. And you know this poem, right, from a very famous, really Arabic poem, Abu Tayyib al-Mutanabbi. You know this? Anyone would like to say what was the first part of it? إذا غامرت في شرف مرومي فلا تقنع بما دون النجوم. It means that the sky is the limit, right? So really aim high for that and don't accept anything but in nujum. Thank you very much for your attention.
Thank you so much, Dr. Majd Idris, and thank you to all of you attending the session. And finally, we conclude the session, and we would like to thank Mr. Hassan Al-Araini for inviting us to be part of this session as a moderator. Thank you.
Thank you very much. Thank you very much for sharing this session. Okay, we will go for a break, and we should be back 3:10. And then we have a very nice, beautiful session. Please don't miss it. And then we conclude for the day. Thank you.
Assalamu alaikum. Welcome back. Now we will go to session 8, and the theme of the session is respiratory care education, challenges and breakthroughs. And we will start with Dr. J. Brady Scott from United States. He is the Director of Respiratory Therapy Program, Department of Cardiopulmonary Science, Division of Respiratory Care at Rush University, Chicago, Illinois. Please, Dr. Brady, the floor is yours.
All right, thanks everybody. So I'm not as good as Dana Evans as talking without my slides, so I'm going to dance. Never mind. So the slides come up. I was going to dance otherwise. Just kidding. You don't want to see that. So this is my last talk at the conference. I just want to say to everybody, thank you for just being so welcoming to us. This has been an amazing trip. I wish I could stay longer. I'm just now getting rested. Like finally the jet lag is over. We have to leave in the morning, but I just want to really give a sincere thank you for how kind you've been and how welcome you've been to our team. I'm going to spend the next 25 minutes talking about simulation, and actually know some folks in the audience that have PhDs in simulation and are doing research, and we had a really robust conversation out there. So I'm hoping that that conversation is going to lead to some collaboration. Same conflicts as I had about an hour ago. So let's do a quick overview. So for folks who are a little less familiar with simulation, I'm going to start from the beginning. So simulation, clinical education using simulation is not new. So I'm not going to be giving you something state-of-the-art, hey, here's a new way of teaching. It's been going on for a long time. Anesthesia in healthcare was some of the very earliest pioneers of simulation. And as a matter of fact, if you go to simulation in clinical education, you still find a lot of anesthesia papers along with nursing and the nursing profession. There are numerous papers, I'm only referencing 7 here, but I have the reference list at the end, that simulation is really effective in clinical skills, as you would expect, but also it improves teamwork, right? It helps people work across teams, and of course procedures that we have to make sure that we're getting a little better as we go. It is a Latin term, which means to imitate or to copy. And actually, the first documented uses of simulation was in warfare, war games, simulating, back in the medieval times, simulating different types of battles to prepare for how to fight those type of wars. So simulation's been used for a long time, and also in aviation. As we know, aviation disasters, there's not a lot of room for mistakes there, so a lot of simulation in that environment. So it's the major concept is it's an educational tool. Like I've talked about earlier this morning, artificial intelligence is also a tool that we have. Simulation is a tool that allows participants to learn and practice as an individual or as a group in a safe environment, which is what we try to create, without harm to the patient. And actually, we try to create it without harm to the learner, right? Because we are evolving over time to teach our students in such a way that they know they can make mistakes. We can stop and reset and create more of a positive learning environment. There's a wide spectrum of simulation. I think this is probably misunderstood a bit. I think sometimes when we think of simulation, we think of the ABG arm that has a pulse. That's a simulator. But simulation is actually verbal simulation. The what-if discussions. What if this, then what, right? That's actually a version of simulation. It's very inexpensive, sometimes hard to design, but that's an inexpensive version. Then we have standardized patients. Those are, in reality, they're actors. I live in a city with a large theater district, and my hospital literally hires actors and actresses to come in and pretend to be scared mothers of a sick child or scared fathers of a sick child, or they are scared patients, or they act, they are told what to do, they act it all out. The problem with that type of simulation In my model, is it's expensive. We have to pay them to be there, but very effective. And then there are tasks trainers. So for those of you that have intubated using a mannequin head, or you've drawn a blood gas off an arm, that's called a tasks trainer, right? It trains a certain task for you to be able to get some of the skills and the knowledge to perform certain types of procedures. And then we also think about simulators being mannequins. Mannequins can just simply be a piece of plastic that does nothing, all the way up to a high-fidelity mannequin that has sensors, pulse, it can blink, it responds to what you do. Those are low fidelity, are the ones that do very little, all the way up to these high-fidelity simulators that actually, again, have sensors, and you can tell it to be hypoxemic. I actually, in my lab, have a simulator. And for the Rush graduates that are in the room in the back, we still have Mr. Jones. He's been part of our department for almost 15 years now, and he's our simulator. He lays there. And for every year we give him ARDS, or every year we give him pneumonia, and you have to fix him. And I stand there and I go, fix him. What are you going to do? His saturations are 83. What are you going to do? And the student goes, I don't know. And I go, you got to do something, make a decision. And they get all stressed out. We still do that. I haven't changed a bit. I do it every single year. And then now, though, we have virtual reality and augmented reality. So now we can be virtual in simulations and even be in the same room with other folks across the world. Another thing about simulation I'd like for you to think about, for those that would like to use simulation more, either in your clinical environment or in your academic environment or your clinical education environment, is what can you achieve with simulation? Well, you think, well, I can get better at intubating. I can learn how to extubate better using simulation, or I can do ABGs again using that model. But those are psychomotor skills sometimes, right? So sometimes we think, well, you learn how to do something more. That's a cognitive skill, falls under the knowledge domain. Well, but you can also, again, learn how to do something, as you know. That's psychomotor. But I'm also going to remind you that we can work on attitudes, communication skills, teamwork skills, situational awareness, and those things can be actually measured and graded as part of simulation. And I will tell you that in my hospital, or in our clinical department that I'm affiliated with, we actually use simulation, and we actually grade people on how they're reporting off to physician and how they're having some discussions. We literally have all the domains based on our simulations, and we actually put a grade to it because we're trying to improve professional communication. We're trying to make sure that is an aspect that our RTs are as good at the bedside as they are at doing the task or the procedures. So keep in mind that simulation gives us the opportunity to work on that as well. So the old model that I was taught, this is funny because I learned this in respiratory school. Here's what we do: see one, do one, teach one. Is that what we do in the kingdom? Is that, you've heard that too? Well, in the U.S., see one, do one, teach one. Well, guess what? That's out of date. We got to let it go. It's not how we do it anymore. There's issues with that. Like, we could actually do a lot of training before we get into the do one and mess up a couple times, and then teach somebody how we messed up a couple times. We don't have to do that anymore. We have the abilities to do it. So simulation allows us more practice before real patient contact. So it closes the gap between theoretical knowledge and clinical practice, and just simply allows us to do it over and over and over again until we get better at it. And helps us refine these skills, and we can use it. So again, let me point out, we can improve our knowledge. Think about the 3 domains here. So the cognitive domain, the psychomotor domain, and the affective domain. Equally, those 3 can be dealt with inside of simulation. And one of the points I wanted to bring out, we had a really nice discussion about this at the break, was kind of these translational tiers that we can be in with simulation. Like, you think about simulation, what are you trying to achieve? What's the goal? And you can design your simulation based on the goal that you're trying to achieve. So if you're just simply trying to improve performance, you can do that. You can translate, can I get students to figure out which hand to put the laryngoscope in before they intubate? Sure, right? We can do that type of training. We can work on that level. And then we can try to see if we can get this to move into patient care practices. And the discussion we were having earlier at the break, where it was prone positioning. We can teach prone positioning. We can work on how to do it, the why to do it, how to not extubate and pull all the lines out of your patient. And then what we hope that does is that translates over to the bedside where we actually start to change our practice. And we can measure that outcome. If we do something in the sim lab, does it translate over into clinical practice? And if it does translate over to clinical practice, what does it do to improve outcomes? The idea behind learning how to prone position somebody is what? To improve mortality, to decrease the likelihood of mortality. But we have to think about this across the line. Does our simulation improve it only here? If it doesn't translate to the bedside, what good is it? It needs to translate from the sim lab. It needs to translate to the bedside. And then we're going to measure, okay, are we doing it more often? Is it making a difference in our actual patient outcomes? And when you start to use simulation, you can begin to measure it at each one of these levels to try to figure out, as part of your process improvement, where are we making the mistake? And then hopefully you can say, okay, well, if we improve patient outcomes by by using the PROCEVA study and doing the things we know that are better for mortality and ARDS, maybe we find out that the way that we're doing some things, we're saving costs and all the other collateral stuff that goes with it. Simulation can be effective in all of these levels. And it really all depends on what you're trying to do, right? It all depends on what you're trying to do. It also depends on where your learners are. You can use simulation to teach something to novice clinicians. That's fine. I do that all the time. I use simulation all the time to first-year RT students. I do not expect that to translate directly to patient outcomes right now in terms of like changing behaviors. But I also have responsibility over a clinical department. We do use it. We want it to translate all the way through. I want to teach you how to do something. We want to see how that improves our practices, and we want to see how that might improve our outcomes. And simulation can do that and drive across all those transitional levels. So one of the things I wanted to, that surprised me about simulation when I took interest in it, and I wanted to put this on this slide, was how real should simulation be? Right? It seems logical that the more realistic it is, the better the outcomes are. And that's not necessarily true. Sometimes you can actually get the same benefit from a fake-looking arm that's not attached to a human being. If it's just an ABG, you can probably get away with that. And I will tell you, somebody who has a budget where I have to buy simulators, I would rather pay $500 for an intubation head than $80,000 for a high-fidelity simulator thinking it's going to be better. And there's a pretty good body of data that says that for certain tasks, more expensive, more real, doesn't necessarily matter so much. That's an important consideration for those of you that may want to start implementing simulation more into your practice. And I also want to say that before answering the question, to what extent should one strive for realism in simulation, it should be emphasized that, as this author stated, simulators themselves are not true to nature. You know, no matter how many times you intubate that simulator that got a little bit better, it's still not like the first time you really do it. For those of you that intubate, you know what I mean. The first time you intubate a real person, after you've intubated that mannequin head 1,000 times, that is not the same. You're like, whoa, that doesn't feel the same. You have to learn that too, but you still have some of those skills. And as we teach our students, we actually lead this conversation in our own sim lab in our university. I'll say this to you. All right, everybody. We're in this sim lab. We're all ready to go. Guess what? Those are mannequins. They're not real. We get it. You don't have to tell me. We get it. You got to pretend here a little bit. They're not real. We can't expect them to be real, but we're going to work through this the best way that we can. That's what you got to set that up for the learner a little bit. So simulation today in respiratory care, so one of the leaders in this area in our profession, her name is Samantha Davis. She's actually got quite a few publications here, and she's been looking at this in simulation use and entry to practice respiratory care program. And kind of like the way I set this up the last time, I'm also happy to send you my slides at the end of this. And I wrote a little bit recently about the role of simulation in clinical education. One of the things that probably gets underreported or under-discussed in respiratory care is clinical education. We talk about academic classroom education, but we don't talk enough about how to use simulation to improve your clinical department. So I have some stuff there I can share with you. And then a really nice paper that was published recently here in Advances in Medical Education covers a narrative view of all the simulation teaching and learning in respiratory care education. I'm going to cover some of that now. So we know that respiratory care in general is a competency-based profession, so simulation really plays well for us, right? It's really nice for us because we have these competencies, which include competencies to communicate, right? So simulation really leans into what kind of training that we do. But we also realize that clinical access constraints persist, and more schools are utilizing simulation to at least keep their students bedside or train their bedside skills when they don't have direct access to clinical situations. So a lot of professions are looking, the medical profession, the nursing profession, even the respiratory care profession are looking at ways that simulation can be effectively utilized in lieu of clinical time. And we're not saying fully replace it, that can't happen, but at least using simulation to close gaps when we can, because clinical, I can tell you that in the United States it's getting more and more difficult to find clinical sites and places that can take students. In the U.S. model, I can tell you, and sounds like this came up yesterday too, we're really short-staffed in a lot of hospitals. A lot of hospitals in the United States need more respiratory therapists. We have websites called that. MoreRTs.com and BNRT and those things. And so, as such, it's hard for hospitals to take students. Hey, will you train some of our students? They're like, we don't even have enough people to take care of our patients. We can't help you train your students. So we're trying to evaluate whether or not simulation can help us there. So when Samantha Davis did some of her work, she figured out that 75% of the programs in the U.S. are using simulation, and 100% of the master's programs are reporting simulation use. My program is a master's degree program, Entry to Practice, and we use simulation for all three of those domains: psychomotor, cognitive, and I'm heavy on the affective side. In my opinion, this professional side, behavior side is extremely important and something that we have to give a lot of feedback on. And actually, 2/3 of the programs in the States are reporting that simulation is a mandatory part of their curriculum. So what works? We know that in respiratory care that there's improved confidence and competence. So let me point out the two things on that first bullet point. Simulation has been demonstrated to improve competence, knowledge, but also confidence. Confidence. Here's the word for simulation. You can actually make somebody more confident to do a procedure by using simulation. In my hospital's model, I'm going to show you this real quickly. We did that with prone positioning. When the PROSEVA study was published in 2013, we all agreed we need to start doing prone positioning. And then we would go there, and the docs, the RTs, and the nurses are like, we're going to pull out all the tubes. So we knew, we even watched the videos that were even published in the New England Journal. We weren't comfortable. So we had to create the simulated training to create the confidence to change the practice. That was the point of how we use simulation. So remember here that high fidelity is not always better learning. This has actually been published. It's been compared. Sometimes you can get the same learning outcome with a lower fidelity model that might be more cost effective. So just because you used mannequins in the airway workshop doesn't mean that wasn't effective. As a matter of fact, it might be just as effective as a cadaver lab, right? So it's not always better to spend more money. It all depends on the design and the feedback and what you're trying to do. I don't have a time to go into this, but one of the most important things I've learned about simulation, I know there's some simulation experts here, we need to talk more about this later, is the concept of teaching how to properly debrief people. Debriefing is probably where the learning really happens after a simulation. And debriefing means we have a model, we have a situation, a cardiac arrest or whatever. We come back in and we debrief. We do it in a safe way where we have the people tell us how they felt during that. How did you feel during that cardiac arrest? Did you feel prepared? Why did you think we had to do this? And we let people tell us what they found. We use structured formats in order to encourage teaching after the simulation occurred. That's a very important time in simulation, is debriefing afterwards. And what's nice about this, a lot of researchers have helped us figure out ways, the plus delta way, advocacy inquiry way, or the PEARLS way, to structure debriefing in such a way that it becomes part of the learning process. So in other words, it's not just doing it, it's after in the discussion that helps support it.
5 minutes.
Okay. So I'm going to speed up just a little bit because I want to get to this. I want to say this, faculty development. So those of you that are in charge of your faculty or in charge of this or just yourself, simulation teaching is an art or is a skill. You got to learn it. You need to go learn how to do it. It involves how you set up the curriculum, how you set up your scoring tools, how to debrief. I took a whole day's course on debriefing. I didn't even know there was that much to know about it. And then when I got done with 8 hours, I felt like I needed another 8-hour course over debriefing. And we know that probably half of the faculty in the U.S. feel like they're adequately trained on how to actually deliver simulation. So my challenge here is how do we get us to that point? And so the future directions here are we probably are going to start taking a more significant role. Simulation is going to be more and more significant to us. It's not going to go less. It's going to go more, especially with the difficult nature of placing students in the clinical at the bedside. But real quick, I want to talk about research, and I'm going to use an example from my own institution. Again, in 2013, the ProSiva study was published. At my hospital, I have incredible critical care physicians that I work with, and we all said, we need to start doing that. We got to stop using the oscillator, because that was the same year that the Oscillate trial, the Oscar and Oscillate trial were published. We said, we need to start proning. So guess what? We didn't. We didn't do it at all. As a matter of fact, this paper, I don't know where my slides went. This went out. So as a matter of fact, this paper on prone positioning wasn't published in 2018. So let me tell you, there was a long time before we got good at this. But we said we have got to get our team up and running on prone positioning. So what we did is we designed a study. We actually brought people in and we said, what's your knowledge now? Pre-knowledge. We ran an intervention where we did we had a discussion, we had a moment, like we looked at the literature behind proning, we watched video demonstrations, and then we proned. And we did that, and then after it, we tested everybody. But I want to show you what we did. We created we worked with our physicians, nurses, RTs, we created all the checklists and all the things we're going to do. These were the tools that we used. These are published in the Education Annual Respiratory Care, so you do not have to reinvent them if you want to use them. And look, check out that fidelity. Anybody know him? That's Tyler. Tyler, that's my director of clinical education. And no, he is not intubated. He wouldn't let us. But what we did is we cut that endotracheal tube off right there. He wouldn't let us do any of the lines or anything. So we taped all the lines in. We put lines here. We put them all around. And guess what we did? We had the physicians come in. The physicians did the head of the bed. The physicians did all the jobs. The RTs did all the jobs. The nurses did all the jobs. And we did it on real people, on real ventilators. The only thing, he wasn't a real patient. But we did full body weight. Tyler's about 5'8". The other person we have is about 6'5", with 2 models. Huge model, small model. We did this back and forth until everybody achieved competence. And then we had them perform it. So look at this. This is one of our critical care doctors. She's got the head of the bed. This is another critical care doctor. This is two of our students learning how to work all the pieces, right? What we found was knowledge, pre-post-test knowledge went up, but what we really found was confidence went up. Confidence went up in prone position. I'm going to wrap up right now. So we said, if you got the ability, we think this is a good way to do it. Why research? I'm going to tell you this. Y'all remember COVID? Y'all remember when that happened? Well, when COVID-19 came around, so we published that paper in 2018. When COVID-19 came around, we said, we got to teach a lot of people how to prone. How are we going to teach our whole hospital how to prone? We went right back to this motto again. We did the whole thing over. All the physicians, all the nurses, all the RTs. And in fact, we watched that video, and then we published our own video using this same simulated model that we used, and we taught people how to do it. You can go find it. It's on YouTube. Prone positioning for ARDS, right there at my employer. Here's what I'm proud to show you. 1,359,000 views of that video. The point of that is we found a way internally that seemed to have worked for us. And during the pandemic, we just let people have it. And many people have contacted us and said, we've changed your protocol a little bit. It didn't work for us. But using a simulated model of training was how we feel this was done, so we've done safely. We didn't like your protocol. It didn't work. You know, they're like, well, you should have done this, you should have done that. But putting a person in the bed and using simulation to train it translated to a whole lot of institutions using that as well. So my point is you can really make a big difference by using simulation. And there's so many different ways to do it. Again, in this model where we use Tyler, that's called a standardized patient. He was pretending to be a patient. We use that model to improve our outcomes. And I'll just conclude. I realize I'm at time. Simulation works really well when it's done well. I challenge anybody in the room who's on faculty. We need to train all of our faculty how to be simulationists. It's not as easy as just us knowing how to teach. There's a big process to learn simulation. And I'm going to tell you that I'm going to ask that we all get more involved in more simulation research, because if I'm being honest, every time I look up a model of how to do certain kinds of simulation, it's from the nursing literature, it's from physician literature, like anesthesia a lot, and then sometimes it's from pre-hospital literature. I think we need to help create our own literature base to help understand the unique things for respiratory therapists. And with that, again, I want to point out there's a really cool poster that's been up there. The really cool poster with a bunch of awesome future researchers here. They are working on virtual reality to use simulation in the VR world to improve inhaler techniques. I shared with them that I've been an RT for 25 years, and my generation has not figured that out. So I hope that VR is the way to improve inhaler technique on those patients, so I congratulate them. And with that, I want to say thank you again for welcoming me to your country. It's been such an honor to be here. Thank you so much.
Thank you, Dr. Scott, for this informative presentation. Our next speaker is Dr. Douglas Gardenhire. He is a clinical professor, respiratory care department, Georgia State University. Please start, Dr. Douglas.
Thank you so much. Absolute pleasure to be here. Very honored to spend the week with you. We've really been talking here these last few lectures about how we're kind of transitioning and getting these careers, how we're learning, how we're teaching. So here, for my talk, we're going to look at clinical training and how we can strengthen this preceptor or clinical instructor partnerships with students. To me, this is very vital in what it is that we do. Interesting enough, talking to so many people over the last week, this continues to be the topic that continues to speak the loudest to me, is that we need students to learn, we need clinical instructors, faculty to be able to teach. So where in the audience, I know that there's our students here, where are those individuals here, if you raise your hand, that are teaching students? Great. So we need you to be the ones that are assisting those to, again, model those individuals to be able to have those successful careers that we heard in a previous talk this afternoon. My disclosures, of course, are Georgia State University, Elsevier, Wellstar Health Systems in Atlanta, Georgia, and the American Cancer Society. What we're going to look at today is look at some different effective characteristics or positive characteristics, looking at some of the roles that you play as a preceptor or clinical instructor. And that doesn't necessarily mean that you are or are not a faculty member, depending on how that might play out. And we'll look at some different examples of some strategies or behaviors. And we're going to look at understanding feedback and why that's so important to students, because that continues to be the biggest piece of a characteristic in terms of what they're looking for from you as an instructor to be able to learn and be able to change. So if we look here at some characteristics of effective preceptors, this is again from a study that we had done a number of years ago with Ali Al-Shamari. And what we're looking at is how respiratory therapists value this preceptor-student model. And what we look to find is one of the biggest things is that we looked for this enjoyment from the profession. That's something that we seem to struggle with in the States, is that individuals don't seem to always enjoy their profession. So we need to make sure that we look for positive individuals who are instructing our students and making sure that they enjoy what it is they're doing and modeling this behavior. So what we're able to, again, find is that students here in respiratory therapy wanted to find things such as respect. They wanted to be able to be supported in their role as a student. They wanted to be evaluated, but they wanted to be effectively evaluated. So using some type of a rubric to be able to evaluate them effectively each time. They were looking for instructors who were going to be engaging but patient with them as they were doing their learning within the clinical world. So if we look at some of these other positive pieces that came out of this, this was a study that we had done, and this was specific to our Saudi respiratory therapy students. And they were looking at some things that were pretty similar, but what they were looking for is professionalism. They wanted these instructors to be able to discuss with them how their learning was moving. They wanted to have encouragement, and they wanted to be demonstrated. They wanted you, as the instructor, to be able to show them what it was for the individuals, which really goes back to having the feedback and being respectful so that we were always looking to challenge the student, but again, at a respectable pace. So if we look at characteristic students that were unfavorable in this same study, what we found is that students didn't want to feel uncomfortable. They wanted to make sure that they were introduced. They wanted to make sure that they were part of the team. They wanted to make sure that they had positive feedback, but that they did not want to be felt like they were not engaged, that they were not approved of, and they wanted to make sure that everything in which they were doing seemed to be very organized. So this disorganization of an individual that they may be with, or in terms of their perception, seemed to again be a big turnoff. So they wanted to make sure that they understood what was, again, important for them that they were doing. Now, as characteristics of students, usually we look at you as an adult learner. And so in this adult learning model, we understand as students have modernized over the years, but we still, again, see that students want practical, problem-based learning to occur. And the way that we're able to do that is we just heard that before we're going to clinical with Dr. Scott, is that we want hands-on learning. We want to be able to do those simulations. We want to be able to integrate these ideas that we already have and be able to practice them so that we are competent. And that is able to allow that individual to capitalize on the experience in which they are growing in. So with that, we can now choose in how we are directing our learning, as long as we have those individuals that have those characteristics that are effective and or positive to us, so that we can continue to learn and to grow. In terms of styles, one of the big ones that we see, of course, is visual. Students want to be able to see, and students see more than what you may think. So body language, facial expression, those are important. If you want to know how you're teaching as an instructor, look in a mirror. And not, again, actually look in a mirror as you, again, give that talk. See what it is that you're looking at and how you might be expressing yourself. Many learners, again, in terms of visual, will do better with written instructions. This is important, and we'll talk about this a little bit later as the pyramid of learning, is, again, writing, seeing and writing these things down are very desirable as we look to retain. And, of course, having information that, again, we can take from that chart, which is, again, very common for us as a respiratory therapist, or at least that I hope, that we're looking at that information through the chart of that patient. Auditory learners, so now we, again, are seeing. We might be, again, writing some things, but, again, we're hearing. So having this, again, tone of voice as the pitch changes with the speaking could turn on or turn off individuals. So understanding how those instructions may occur is very vital to the learning process of the student. And, of course, kinesthetic learners. This is that hands-on approach. This is the practical approach. What we may do as we're learning in the laboratory and as we're taking that forward to the clinical side. So these relationships continue to be important. And as I mentioned before, students report this lack of relationship impacts their learning at the clinical side. So as we look back at some of these positive or effective learning pieces, we need to make sure that we understand how relationships grow. We heard earlier in a talk this morning about having a mentor. So again, mentoring. So as you guys had raised your hands about, yes, I'm the one teaching them, students want you to be able to have that relationship. That relationship will allow them to grow. So their dependence, sometimes clinically, for you is tough to overcome. So we need to have that and build that relationship. We find from our students, at least in the States, at least at Georgia State, that our students seem to learn more and openly a lot better if they consistently have the same instructor every single time at clinical. If we can do that and we can continue that continuity, they seem to learn more. Students are, again, reporting that attitudes hamper their clinical learning. So we have to be respectful of all. If we look at some barriers to learning, we talk about poor communication. I mentioned this before, not being organized. Organization, to me, is one of the best things we can do as a faculty member, as a clinical instructor, as a preceptor. If we're organized and we know exactly what it is that we're going to do for the day, for the week, for the semester, students appreciate that relationship in terms of being organized and what they're going to be able to do. They know what's going to be coming. If you cannot manage your time along with the skills, that's going to be a turnoff, and it's going to be hard to learn. The experience, so this lack of experience that we have in terms of applying theory to practice. A lot of times, I think as clinical instructors or preceptors, we have this notion that maybe we've been doing this for a little bit of a time, and that we forget that we have to take into account that these students are learning the theory, and they're coming to clinical to make that application of that theory. But what we try to do is say, no, well, this is really the clinical way, or this is the way we do it at this institution. And some may see that as a shortcut. But what we need to do is we need to make sure as instructors, in terms of to the student, we need to understand what it is that they're learning at their school so that we can make sure that we're better prepared to implement that theory. We've experienced the same thing where we have issues in our community in Atlanta where we find better improvement in the learning when we have preceptors, instructors who are graduates of our program that are now teaching clinically at whichever hospital that may be. Those students are learning more. It again prepares that student to know that they're receiving that clinical instructor that has been through what they've already been through. Because I'm going to ask everybody here, raise your hand if you've ever been a student or are a student. We're all students. We continue to learn. And so we have to understand that we at one time, at least once, were a student, at least a student in respiratory therapy. So other experience that we have found in terms of barriers is those, again, working with illness. We've heard a lot about COVID. That's been a big barrier to learning. We've had students, again, drop out during that time. They were scared to be at clinic. Funny enough, all of our students, no one ever contracted COVID during the time that they were in a hospital because they were following all precautions. So we have to overcome some of those pieces. Working with, again, professional colleagues or employees. So we might, again, have this barrier because we, again, think, oh, this person is better than me. This person is very intimidating. So we have to, again, go through that and kind of make sure that we're open. And that's that part of encouragement that we, again, saw with those effective characteristics. Of course, cultural and generational barriers. And, again, don't fear about making a mistake. I would rather students overcome making a mistake as a student than making a mistake as a professional. We want you to make those mistakes so that you don't make those mistakes as the professional. So for that role of you as the preceptor, remember, you're the superstar, you're the rock star, you're the one that's going to have this organized plan, you're going to be the role model of the best respiratory therapist, being able to facilitate the learning and give those things to the students. Ultimately, you need to make sure that you are probably the first person, not necessarily the faculty member who is just teaching the theory. You're the first person that you're going to identify these gaps in knowledge. So you need to be able to provide that feedback. So students are going to remember more from one single experience than any extended time sitting in a room with a faculty member. So that makes you more important at times than the faculty member. If you're looking at style, so there's lots of different style pieces there. I think in terms of timing, again, kind of go through these, but looking at the different approaches that you may need. We heard just again from Dr. Scott about debriefing in this simulation. That's what needs to occur every day after clinic. You need to have a debriefing session with other students and with those preceptors or clinical instructors. Expectations to me are at the top. We send a sheet with all students to all of our preceptors that they, on the very first day, the expectations of that instructor and of that hospital is gone over, written and signed by the instructor and by the student. We need to make sure that we understand what those expectations are. Evaluation. We heard that already as an effective piece that students are looking for from you as a preceptor or an instructor. They want to be evaluated. They want to be evaluated effectively. They want the feedback as often as you're willing to be able to give it, but they want it to be constructive. So you have to be engaging enough, but again, kind enough to be able to give that feedback and not making sure that it sounds harsh. Of course, sharing the feedback. Students, again, as I mentioned, like that. They like that maybe in more conversational form. That's why I think the debriefing piece is exceptional, because now we can just use this as an open air topic of going over all the different pieces that we've learned for the day and or for the week. That regular feedback increases performance. So the goal of that feedback is to, again, produce the highest level competent individual that we can so that they can continue to move on through that program. So you cannot move to critical care unless you have all of the basics first. You can't advance. So you need to be able to have that and be able to learn in terms of being mentored in that time. Sharing that, of course, in the timely fashion that we had said. Ultimately, in terms of that feedback, you are the one who's with the student the most, and if you're recruiting, which is often done in the States, recruiting that student to be an employee at that institution. So that feedback can be very informational, it can be very culturally driven, so you understand the culture of the department, so that it is found that you may want to come and work there. Here's what I'm going to finish up on is why all of these things really matter. And this is from Dale, this is the learning pyramid, and this is something I try to go through with all of my students multiple times in making sure that they understand, and I think it's important too for our preceptors to make sure that we're really doing some of the same things. But as learners, because we're all learners, we need to understand how this is in retention. One of the things I tell all of our students is that you cannot memorize material. Memorization and then regurgitation for an exam gets you nowhere. It actually will set you back. And what we find is students in the U.S. are, again, taught that, I think, at a very early age, that they just need to memorize these history dates and be able to take this test and regurgitate these dates in history. But for healthcare, that doesn't work. We need to make sure that we connect the dots. So in doing so, we may listen to lecture, and if we only listen only, the pyramid tells us that we're only going to retain or put into our hard drive 20% of that information. Now, if we look at that material and we hear that, so for instance, we go to class, we listen to a faculty member, we see the information on the screen or on the page, we can retain approximately half. Now, if we get into groups and we discuss, or what I like to tell my students, reread your notes. So when you reread your notes, you're discussing, you're saying, that's at 70. Now, as we try to get to the highest level, we're now going to do it, and we're going to do it as we're speaking. Have you ever seen someone do something that sounds like maybe looks like they're trying to talk to themselves? Because they understand that retention part. This is where you get to the point in your career as a respiratory therapist, you don't think anymore, you just do. You know exactly what you have to do. When that patient comes through the doors of the emergency room, you know exactly where you need to be and what you need to do because you've retained 90% of that information because you have heard it, seen it, discussed it, and you're doing it. And if we can continue to do that as students, that makes us better preceptors, that makes us better faculty, that just makes us better healthcare practitioners. So I think it was yesterday, there was some discussion of asking, like, what does the AARC do? What's available for us? And we heard that earlier this morning as well. But I do want to point out, if you need assistance with clinical preception, so there is things available to you on the AARC website. So if you go here to the AARC website, it's there, you see at the top, aarc.org, Preceptor Training Courses. You can actually get this course. We use this course for our preceptors. So it's a great tool to be able to utilize and is available to you as members of the AARC. So with that, remember, communicate, give lots of feedback so that we can make that connection. Be enthusiastic. Love what you do. I love being a respiratory therapist. Love what you do. Make sure that you embody that respiratory therapy professionalism. And again, always think and be positive. Thank you all so much.
Thank you, Dr. Douglas Gardenhire, for a very important topic and informative speech. Now we go under the same theme, respiratory care education challenges and breakthroughs, with Emily Lamorina. She is going to speak about a topic, why teams fail, the leadership imperative in transforming the culture of your team. Ms. Emily Lamorina, the floor is yours. Go ahead.
Thank you. So I'll go ahead and start. My disclosures are the same. And I want to start, what is culture? And I often think that when we talk about workplace culture, the conversation often starts and ends with one thing. It's your perks. Is it pizza parties, blue jean Fridays, how much fun and celebrations that you have? And I will say those things aren't bad, and if you know me, you know I love all of those things and adding glitter and sparkle, but it's not culture. And if you're a leader who tries to use those things to build your culture instead of actually fixing the underlying problems of your department, this is what your staff is going to experience. To them, it's going to feel like being handed pizza when you ask them for support. It's going to feel like you're invisible and you're dismissed when all they want to do is to share their concerns and feedback with you. Because fixing your culture isn't about increasing the fun and celebrations, it's about addressing the actual real unresolved issues of toxicity that can lie in your department, which often for many of us might look like this. Sometimes these are egregious, really bad behaviors, but the dangerous part is most often these are so insidious and little tiny things that bleed into your everyday that you don't even recognize it, but it's severely affecting the culture of your department. It's when bad behavior or performance is tolerated or not addressed, and we just say, oh, that's just how they are, or you as a leader are too scared to actually address it. It's when coworkers are talking badly about each other, maybe even bullying the new grad or the new person and making fun of a mistake that they made. It's those people in the break room who are just complaining about all the things and everything is terrible and bringing down the group. And it can feel like when you try to bring up solutions and new ideas to your leader and they just say, no, we're not talking about that. This is the way we've always done it. Culture isn't what we say and do. It's what we tolerate it. And I learned my biggest lesson about culture actually from one of my favorite TV shows. I don't know if you've watched it. Raise of hands, has anyone seen? Oh, I see. We'll talk after this. But Love Island is a popular reality show in the US. It's actually pretty terrible. It's just a bunch of young people who are looking for love on this island, and it's so toxic. They're all yelling at each other. They're talking badly about each other. They're gossiping. They're actually just fighting and screaming at each other. Almost everything that I just showed in the previous slide. And I was sitting there wondering, like, why is this so bad? They're all there for a common cause. They're all there to find love. And then it made sense to me, because in episode 4, our dear Maya Papaya is sitting on the couch with her love interest, Austin. And she says, you know, I'm ready for the real thing. I'm 25. It's a great age. You know, your frontal lobe is fully developed, and Austin, who's not the smartest tool in the shed, says, so, I think mine is kind of still developing. And I said, oh my God, this makes complete sense. If I now view the show through the lens of a bunch of people who do not have fully formed prefrontal cortexes, all the toxicity I see makes absolutely more sense, because I think Amaya was onto something. As leaders, we need to know what this means when we're dealing with our team. So what actually does go on in our brain when we are facing our own emotional triggers and conflict? So as a little review, our brain is actually divided in 2 main parts. You have your higher and lower brain, or what we call and by older, I just mean it's older from an evolutionary perspective. It is purely meant for your survival. It asks one question and one question only: is there a threat? It's instinctual, it's reactive, and if it does perceive a threat, it's going to release some chemicals and hormones. Your eyes are going to dilate so you can see more clearly. Your heart rate's going to increase to get blood flow to your extremities so you get adrenaline and run to safety. This is our fight, flight, or freeze response. The primary purpose of the amygdala is to control and regulate your emotions. So this is responsible for your fear, your anger, and happiness. It works really well together with your hippocampus, which is what creates your memories. And together, they create your episodic memories. And remember, our brain just wants to protect us. So if you think of all of your memories, even from 30, 40 years ago, they are probably really emotionally charged. They are likely times where you felt extreme joy and happiness, or times where you're really sad and traumatic. And that's because your brain wants to create these paths so that you can easily identify this is good or this is bad. One part, the lower part of your brain, actually controls 95% of what we do. And it is largely unconscious. These are your autonomic functions, like your heart rate, your respiratory rate, your bodily functions, but it's also your habits. Have you ever driven to work, got to the parking lot, and looked around and said, how did I get here? I don't remember driving here. Or when you're walking, your neurons are firing to your muscles or contracting, you're picking up your leg, your brain is trying to balance you and you step. Every single time you make a movement, thank God you're not consciously doing it. Your brain would be overwhelmed, but it's largely unconscious. What that means, though, is the way that we interact with each other and with situations is driven by processes that we are largely unaware of. And this is your prefrontal cortex. I like to call it the CEO of our brain. This is where we have cognition, problem solving, analytical skills, organization, planning, prioritizing. This is what helps us maintain focus when we're stressed, be rational when we're emotionally triggered, and understand other people's point of view. This gives us empathy, compassion, collaboration, and yes, it's not fully formed until around the age of 25. I think that's really important because if you're having challenges with maybe some coworkers or associates that are of that age and they just cannot seem to take accountability, cannot work well with others, just keep this in mind. It's not them. It doesn't mean we don't hold them accountable, but they may need to be coached a little bit stronger. Now, your higher brain and lower brain are constantly at war, and your higher brain is just trying to say, chill, 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 let's think through this, and it's trying to inhibit it. But the problem is that your higher brain is really fragile and gets really, really tired. And under stress, it completely starts to deplete. And at some point, your higher brain's gonna go completely offline, and this is when you're gonna lose control and you're acting completely out of fear and stress. That's okay, I wanna normalize it, but as leaders, we have to be aware of when that's happening. And just as a piece of advice, don't send that email. Don't send that text. Make sure that you can get to a place where you can get back into your executive functioning to deal with any problems that you may have. Now, our brain is biased because it wants to create powerful associations between the things that hurt us and whatever happened to be happening to us when we got hurt. So our brain can sometimes make up stories about our experiences that are aimed to protect us and ensure our survival, but it's our job to recognize this and challenge our inner narratives to tell a different story in our brain to set us up to engage our executive function and our prefrontal cortex when we are dealing with conflict. Our brains are wired to avoid and protect us from conflict, so if you're sitting here and thinking, I really don't like that difficult conversation, if I'm angry, it's really hard for me to go and address this with the person who made me angry, all of us feel that. It's because our brains have wired to tell us that conflict is bad. There's a really great book of two psychologists wrote, and they made this diagram that said all of us sitting here have carry our own basic human and dignity needs. These are all things that we need to feel safe and belong in a space. And what they say is conflict occurs when our basic human and dignity needs are not being met, or we hold that perception. And I'm going to tell you, 99.99999%, it's the latter. I deal with people who are, usually it's one person who's so hot and bothered and angered and triggered and, oh my God, I hate this person, they did it. And some person who's just like, la-da-da-da-da, just walking about my day, has absolutely no idea that something they did or said made them that angry. And that's because no one comes to work to do a bad thing or intentionally hurt someone. The problem is that sitting in this room alone, we all have 300 different perceptions about what each of these elements mean to us. The way I receive love is different from the way Dana receives love. The way I want to feel security and belonging is not what Brady's going to want to feel security and belonging. So unintentional, we all may be triggering these responses in people, and this is the challenge of leadership, is that you are leading a large, diverse group of people who want to be felt that their dignity and safety is being protected, and it's our job to manage a department where that may not always happen unintentionally. So when it goes to what makes teams fail, I would argue that the teams that fail are the ones that cannot manage conflict appropriately and haven't yet learned how to embrace it. So I'm not talking about tension, anger, sarcastic comments. I'm talking about an environment where we all feel like we feel safe to share our true feelings, disagree with decisions, and give honest feedback. We all work in large, diverse departments in rapidly changing environments. There's literally no one way that any one decision or announcement will have 100% consensus. I used to think it would be raises, but then I got a huge amount of raises for all my staff, and they were still angry and had so much more feedback from me, and that's when I learned there's literally nothing I can do that all 160 of my RTs are going to agree with, and that's okay. Because I need to create a safe space for people to engage in open, constructive, and ideological conflict. Pretending or even preventing it won't happen is just going to set you up for failure. The most resilient departments are the ones who know how to storm together, and the ones that make it okay to not be okay. There's actually a lot of research that's looking across industries that say the best teams are the ones on teams where feel free to share their ideas and even constructively argue, and they have found that they have better decision-making, better innovation, and even better relationships with people. And this requires one big thing: psychological safety. I really recommend this book. This was a landmark book that was published by Harvard business professor that really provided a framework for managers to promote psychological safety on their teams and their workplaces. And the definition of psychological safety: it is the shared belief that it is okay to take risks, express your ideas and concerns, speak up with questions, admit your mistakes, give each other constructive feedback, all without fear of negative consequences. In fact, this was so important that in 2012, Google set out to try to find out what made the most high-performing team. They looked at 180 of their teams to see what were the patterns and behaviors in the teams that had high performance. Going into it, they thought, oh, it's going to be the number of high performers, a really experienced manager, and they were really shocked because it was not. The only thing separating high-performing teams from everyone else was the level of psychological safety on those teams. So there's Patrick Lencioni is also a great author. I would recommend if you're going on your leadership journey. And he first described and helped us understand the role that conflict can play on teams. So what he says is that there's two actual ends to this spectrum: artificial harmony, and the other end, which is just mean-spirited personal attacks. And what artificial harmony is everything seems okay, it's all roses, except there's really some underlying ugly things happening because no one's going to talk about it. How we can show up in our departments: this is when you have a quiet public staff meeting, and then no one says anything, but then in the break room later, they're all huddled and talking about what actually happened. I'll tell you, nothing scares me more than a quiet staff meeting. If you've ever met my team, they are not quiet. They have a whole lot to say to me. And when they do, I say, something's happening. Let me go have some one-on-ones and figure out what's going on. The anonymous suggestion box. This may be an unpopular opinion. I always say that is where culture goes to die. For two reasons. A, it means you've set up an environment where people only feel safe to share feedback if their name's not attached to it, so you should address that first. And two, it's just not effective. When I'm getting feedback, I actually really want to know and work towards a solution to what the problem is, but if I don't know who said it, I can't ask questions. I often have to ask why 6 times to actually truly understand the root cause and what they're asking me to do and work with them to find a solution. So when I get if you get a random sentence and it's either misguided or not true or you don't understand, you can't actually solve the problem that they were looking for. This is where your RTs may report behaviors to your managers, but not actually tell the coworker that they did. So this actually happened. I was, as we always do, we were debriefing our engagement surveys, and there's those questions about your culture of safety. Now, I'm really proud of my managers. We really embrace just culture. It's psychologically safe. When we are debriefing safety events, it's not about the person or blame or shame. We're looking at the system, and this was rated pretty low one year, and that was surprising because we're not a disciplinary or punitive department. So I was debriefing it, and I said to my team, at a staff meeting, I really want to understand this. How can we do better? Because you guys know we are not punitive, and we're really trying to create a safe space. And one person raised their hand, and they said, you know what, no, you're great, the managers, we know we're safe with you, but I was working with Dana for 12 hours on Sunday, but then on Monday I got called into Dean's office, and he told me that Dana told her that I was suctioning the wrong way, but I was with Dana 12 hours before. Why didn't you just tell me? Why did you have to call me in my manager's office? And I stopped, and I said, oh my gosh, I get it. It's your culture of safety with each other. And trust me, I agree with them. I don't think 95% of the conversations that happen in my office or my manager's office need to be there because they're all there to do that work together. Peer-to-peer feedback is actually much more productive. But then I did challenge this RT, and I said, that's a great point. What happened the last time they gave you feedback? It was bad. And she said, well, you know, I said, but you bring up a great point. I do believe you guys should be able to coach each other. We also need to learn how to accept feedback well. And so that was actually a really profound moment that our staff was asking for, but was too afraid to take that step. So we've been on a long journey of feedback, training, how to receive feedback, how to give it well, peer-to-peer accountability, really trying to shift that focus from having to tell on someone and just coach your coworker because, again, no one comes to work to do a bad thing. They probably don't realize, and we could all use the reminders because we all make mistakes every day. The other end of this is a lot more egregious. Thankfully, this is not really common in either in our organizations or in other industries. That being said, I think it's the easier one to deal with because it's obvious, it's egregious. We have clear policies. You coach them up, coach them out. The other side, this side, is really hard to recognize if you're not paying attention and really hard to fix. And what Patrick says is both ends of these are toxic. And there is an ideal point in the middle where we balance that if you can get your team there, it's a healthy balance. So how do we get there? You can take little tiny steps. Now, when anyone comes, and this is what I instruct my leadership team to do, when someone comes in and starts to complain to me, oh my gosh, I hate Brady, he was so mean to me, he was so condescending, we shouldn't let him precept. Even in my mind, I'm like, gosh darn it, why did Brady do that again? If I don't know, the cycle of toxicity ends with us. Never spiral with your team. I say, now, I know Brady. He's a great RT. He's an incredible leader. I know how much he wants to mentor others. I think it'd be really important for him to understand the impact his behavior had on you. Why don't we go talk with him and encourage them to stop all the assumptions they're making and actually address it? If you can do that, another time, this actually happened recently, I had a staff meeting, and Ben, one of my best RTs and the one who loves to talk with me and share feedback, he slid me a paper, and there was 12 things. And he said, that's what everyone's mad about, and they want you to fix. I said, awesome. I slid it back to him. I said, in the end of our meeting, we're going to have an open forum. Can you say all of these things to me? And he looked at me like I was crazy. He said, I was trying to protect you. I don't want to embarrass you. That's why I gave it to you beforehand, so we wouldn't have to talk about it out loud and catch you off guard. I said, no. We need to model it's okay to say these things to me out loud. It's okay to disagree with me if you do it in a productive way in a staff meeting and work with me to understand the problem so we can come up with a solution. You're comfortable with me doing it. I want everyone else to be so they don't have to turn to you to talk to me. So we did it. We modeled this, and soon after they saw the way I responded, everyone started piping up and telling me all these things. It was one of our most productive meetings. But psychological safety doesn't happen over time. You have to show up consistently and create the safe space to let them know it's okay to say these things out loud. And slowly, if you do this consistently, small things where you don't allow the toxic behaviors to infect your department, you could get closer to that point. Now, this is what normally happens, right? We get really triggered, we're really angry, I get an automatic thought, and I have some very destructive response. So the challenge is, you're gonna get really angry, you're gonna have an automatic thought, and then can you stop? And then get curious. I actually have curiosity questions right behind me in my office, and just get curious and say, I wonder why that happened. Do I know what 100% certainty that he did this? And I literally go through and I breathe through this, even if I'm really angry. Because here's the fun part. Curiosity is a frontal lobe activity. It is quite literally impossible to be curious and angry at the same time. So this is a way to stop and pause and think differently. And so this happened a few days ago. Someone ran into my office, and they're like, oh my gosh, Carl, I was so mad at him. I had an intubation, and I called him. And you know, as Carl always does, he never picks up because he runs away. He's so lazy. He never wants to help out. So what happened, I was late. I had to set up for the intubation by myself. It was so embarrassing. It was delayed. Everyone was yelling at me. And we really have to do something about him because he doesn't really help us. And I said, again, cycle of negativity stops with you. Now I know Carl. He's a great RT. He's always helping out his team. I think it's really important to him to hear what happened today and how his actions affected you. Why don't we go talk to him? And so I encouraged them to do that. And I said, but you're not going to go tell Carl that he's lazy and he doesn't help out and you don't think he does anything. You are simply going to say, at 2 p.m. I had an intubation. I called you and you didn't answer. The intubation was delayed and it was really hard for me. And then I need you to stop talking. And I need you to let him talk. Get curious and ask him, can you tell me what happened? So I facilitated this. And of course, Carl comes in, has no idea. He is thinking he has had a great day. When it happens, he said, oh my God, I'm holding the delivery pager. I had a high-risk delivery at St. Joe's. I was running underneath the tunnel, which we all know we have no reception in. I had to deliver twins. I got them back to the NICU. I admitted them, and when I looked at my phone, I saw I had a missed call from you. But then I called the phone, and when I called, Dan picked up, and he said, oh, don't worry, I'm here. I'm helping Carl. We got it all covered. Just stay in your unit. In that moment, you saw this RT kind of calm down and said, oh, thank you. And that was a really great moment for me because I got to teach a very important lesson. Avoiding the conflict actually just creates more of it. Embracing it creates more connection. So this is my plea to you. Have the difficult conversation. Embrace conflict and use it to be curious and create more understanding and connections on your teams, because your culture is defined by the worst behavior you tolerate or you don't address up front.
4 minutes.
As proof to you that I really like feedback, I write down literally everything that anyone sends to me in email form and meetings, and I use it to drive our strategic plan because I like to let them know your feedback directly to me has become our plan. Thank you for making our department what it is. My team really knows I love feedback, so these are actual texts I received. One time I was giving a national webinar, one time I was presenting to our executive team, but they love giving me feedback. And I love that because feedback is a gift, and they will never let me look bad, or they assume that I always have the best intent. So as I end this, I just want to give you guys with something of when you go back to your institutions, how can you start positive energy on your teams to move in this direction? So in 2010, there were actually psychologists who looked into this. And what they said was all of us carry an energy. And in our organizations, you're either an energizer or a de-energizer. And de-energizers, I'm sure you've met some of them. They're the people who, when you walk into a meeting, they just suck the life out of everything. You have to decompress after a meeting, even if it was a good one. They just bad vibes all around. And energizers are the ones that lift you up, even in tough times. They're the ones you want to be around. They can create mobilization. They get everyone up and moving and excited. And what they said was, most people just say, how you react to me, that's your fault, not mine. I am just who I am. I can't change. And they sought out to set, is that true? Can we actually have a predictable influence in how others respond to us? And they found it was yes. They said that we all have a trait affective presence, or what they called our vibe, and it's our responsibility to address our vibe because we can actually change parts of it so that others respond to us differently. And what they found was there were 7 traits of people with infectious positive energy. And again, these are the people who can lift up and create mobilization on their teams. You want to hear them? They care about us. They connect with us, and they seek to understand who I am, both inside and outside of the hospital. They follow through. When they say they're going to do something, they do it. They don't come with endless problems. They're not a constant victim. They say, what can we do? What will we do? We are going to get through this together, and let's go. They give people their full attention. They are present. They are engaged. When you are with them, you know that they are focused on you and only you, and even if they are the busiest person in your organization. They are open-minded. They say, that's a really interesting perspective. I hadn't thought of that. Can you tell me more? They listen to others, especially if they have an opposing view. They validate others. They respond in a way that tell you, I believe you and your experiences. I may not understand it. I may not have the same beliefs, but I'm going to try my best to understand, because if it's important to you, it is important to me. So I want to end with this. I've talked with many leaders who are really tired and feeling and down on themselves because they want to be great leaders, and this is really hard. We're all balancing all the administrative things we do and connecting with our teams, and we put a lot of pressure on ourselves. But I want you to think, who's one of the best leaders you've ever had? Do you remember all the protocols they wrote, how good their budget was, what their productivity was? I'm going to guess not. You probably remember how they made you feel. So whether it's if you are a leader or with any of your team members, just remember, when you're leaving your legacy, they won't remember what you did. They will remember how you made them feel. If you focus on people first, the rest will follow. So the main takeaway is culture is not how we celebrate. It's how safe it feels to speak, how supported it feels to struggle, how protected it feels to do the right thing. And your culture is built by courage, accountability, and consistent leadership every single day. Remember, we're all in this together across the world. We have a community. If you need anything, please reach out to mentors, because this profession is only as strong as the leaders that I see in this room leading us forward. And with that, I want to thank you for joining.
Well, thank you, Ms. Lamorina, for a very great speech. We didn't want you to finish, but unfortunately we are time limited. Now with the next speaker, and talking about the topic, what I have learned after 50 years in respiratory care, with Professor Dean Hiz, and that's a cherry on top.
Well, thank you. I fully understand that I am the only thing, I believe, standing between you and the end of the conference. So I will try not to belabor this too much. So I've been asked to talk about what I have learned after 50 years of respiratory care, and to tell you that it actually has been more than 50 years now for me. I'll start with a story. So in 1972, I graduated from university with a degree in chemistry. I had no idea what I was going to do. So I was living in a city at the time, not too far from a hospital, and somebody said, you know, if you go down to the hospital, they would probably hire you to be an inhalation therapist. So I thought, why not? I need a job. I'll try this for a while. I'll see how it works out. So I went, I interviewed for a job. The director of the department said, can you start tomorrow morning? I said, sure, I need a job. I'll try this for a while. And now, more than 50 years later, I am still trying it. And it's been a really good trip for me, and I hope that all of you someday will be able to say the same. So these are my disclosures, exactly the same ones as I've had twice already today, no changes. So I want to focus on 4 things this afternoon with you. Now, I need to tell you I've learned more than 4 things over the last 50 years, but we don't have time to talk about all of them, so I chose these. Don't substitute one unproven therapy for another. Give you some examples of that. New is not necessarily better. Beware of physiologic endpoints, and sometimes less is more. And for some of these things, I think we've already seen some other examples earlier in the day. So you might ask, okay, in 1972, as a young respiratory therapist with very long hair that was red hair, if you can believe it, what did I do as a respiratory therapist? And this is mostly what I did. A whole lot of IPPB treatments using equipment that I suspect many of you in the room have never seen except in pictures. We did an awful lot of IPPB treatments. And as respiratory therapists, we thought that they were very helpful for our patients. But then, about the mid-1970s, we come to learn that IPPB may not be very effective. And I suspect that many of you have probably never done an IPPB treatment. And I'd say that's a good thing because IPPB is not a very effective therapy. So what did we do when IPPB went away? We started doing incentive spirometry. And we did a lot of incentive spirometry treatments. And this brings me to lesson number 1, which is avoid the temptation to substitute one unnecessary therapy with another equally unnecessary therapy. So avoid the mistake that we made 50 years ago when we took one unnecessary therapy, IPPB, and we substituted for it incentive spirometry, an equally unnecessary therapy. Sometimes, rather than don't just stand there, do something, we need to stop and think maybe it's better to don't just do something, stand there. And when Emily was talking about bronchiolitis earlier this afternoon, I thought about that. Sometimes it's better to don't just do something, stand there. So we don't have to throw every therapy that we have ever learned at every individual patient that presents themselves to us. So incentive spirometry turns out, I believe, to be an equally ineffective therapy as IPPB. And in fact, the AARC clinical practice guidelines published back more than 10 years ago, now almost 15 years ago, do not recommend the use of incentive spirometry for preoperative and postoperative patients. So point number 2, just because something is new doesn't necessarily mean that it is better. And the example that I will use here are ventilator modes. So in 1973, as a young, impressionable respiratory therapist, this paper is published first introducing intermittent mandatory ventilation. And as a young respiratory therapist, I couldn't wait to do this because in the paper, there was a figure that showed how I could collect the valves and the equipment that I needed in the respiratory department to adapt any ventilator circuit for IMV. And that's what we did. I can recall going through the ICU and converting everybody from assist control ventilation to IMV. We did it because we could. We did it because it was cool. We did it because we could demonstrate that we could adopt this new therapy that was published in the literature. And you might say, well, this study must have been a randomized controlled trial. It must have been a multi-center, multinational, many-center study, randomized controlled trial, showing that IMV was better than mechanical ventilation as we had practiced it up until now. And you know what? If you go and pull this paper, this is a case series of 6 patients that established the original use of IMV therapy. I published a paper, an editorial actually in Chest about 15 years ago about ventilator modes, And I thought I'd come up with a catchy, clever title here, Where Have We Come From and Where Are We Going? And if you pull that editorial and you read it, I talk about how we should be careful now in the 21st century that we don't make the same mistakes that we made in the 20th century by adopting new modes without really any sufficient evidence to support the use of that. Now, I need to point out that I believe, and I'm sure you all agree, that modern ventilators are engineering marvels. I don't want to go back to the ventilators that I used in the 1970s and the 1980s. The ventilators we have today are great for a lot of reasons, except for, I would submit to you, new modes. Because many of the new modes that come out on ventilators really haven't been subjected to careful analysis to determine that patient outcomes are improved with those new modes. So new is not always better, but certainly sometimes it is. So I don't want to go back to trying to manage patients on iron lungs and on the ventilators that we used back in the 1970s. New ventilators are engineering marvels, but not because, for a lot of reasons, but not because of the new modes that are available on many of those ventilators. So my next point is beware of physiologic endpoints. And I introduced this concept first thing this morning when I talked about evidence-based respiratory care. And I mentioned a little bit about physiologic endpoints. But let me give you an example here. So high-frequency oscillatory ventilation was available for many years to be applied to adults. And then along came the H1N1 pandemic in 2009, and high-frequency oscillatory ventilation became very popular because we could put patients, I say we, except I didn't, I really never adopted the use of HFOV in adults, but in many hospitals, patients with H1N1 were put on high-frequency oscillatory ventilation, and guess what? Their PO2s got a lot better, their FiO2s come down, their oxygen saturations got better, and everybody said, this is great. And in fact, during the H1N1 pandemic in 2009, there was such a large demand for high-frequency oscillatory ventilators that the company that made them ran out of machines. You just couldn't buy any more because there were such a demand for those machines. So I was actually one of the few at the time who said, I'm not convinced. Show me the evidence. And then what happened was that 2 large randomized controlled trials were published in the New England Journal of Medicine in 2013. One of them, the Oscillate trial, showed that mortality was worse with the oscillator than with conventional therapy for ARDS, and the other study, the Oscar study, showed it was no difference. So all of a sudden, we went from everybody wanted an oscillator for their medical ICU to nobody wanted an oscillator for their medical ICU. And now I think if you wanted one, you'd probably be able to buy it cheap, because as you know, high-frequency oscillatory ventilation has really fallen out of favor. So here's an example of a therapy that made the blood gases better, but the mortality worse, or at least the mortality not better. So beware of the seduction of the pulse oximeter. So just because you have a therapy like a new ventilator mode that makes the blood gases better doesn't necessarily mean that will translate into better patient outcomes. Because maybe the therapy to make the blood gases better also injures the lungs along the way and results in poorer outcome in the long term. So beware of the seduction of the pulse oximeter. Making the blood gases better isn't necessarily the best therapy for the patient. So sometimes less is more. Emily introduced this to us in her presentation. She had the guy holding up the card, less is more. And I thought, great, I'm going to talk about that too. So sometimes less is more. So what are some examples we can give here? Well, back in the mid-1970s, the ventilator that we used more commonly than any other one was the Puritan Bennett 7200, great ventilator at the time. And that ventilator could go up to a tidal volume of 2,200 milliliters at a pressure of 80 centimeters of water. And we thought that was great. I took my boards to become a registered respiratory therapist in 1976. At the time, that was an oral exam. So you actually went into 2 rooms, and there were examiners who asked you all kinds of questions. You had no idea what they were going to ask. And then they judged whether they would allow you to be an RRT or not. So in one of my exam rooms, in the equipment room, one of the examiners said, "What's the maximum tidal volume you can deliver on the Puritan Bennett 7200? And I said, with confidence, 2.2 liters, which was the right answer. But it wasn't the right question. The right question should have been, when would you ever use 2.2 liter tidal volumes on any patient in your ICU? But back in the 1970s and the 1980s and the 1990s, I regularly delivered tidal volumes, set the ventilator for tidal volumes of 1 liter, 1.2 liters, 1.5 liters sometimes. We used big tidal volumes. We used tidal volumes back in those days. I used to say this on rounds in our MICU. We used tidal volumes in one patient back in those days that was greater than the tidal volumes all added together today for our patients ventilated, intubated, and ventilated in the MICU. So you know how this story goes. So the AARC study is published, New England Journal of Medicine in 2000, probably the most important randomized controlled trial ever related to mechanical ventilation. Big study, over 800 patients, randomized to either 12 mLs per kilogram of predicted weight for tidal volume or 6 mLs per kilogram of predicted body weight. We all know there was a 25% reduction in mortality for the smaller tidal volumes, number needed to treat of only 12 patients. So if I aspirate my dinner tonight and I end up in your ICU, I want a tidal volume of 6 mLs per kilogram because that significantly increases my likelihood of surviving the course of ARDS. So you would think this kind of data, immediately, everybody would go to their ICU and turn down the tidal volume, right? Compelling data. But that's not what happened. Here is a study, observational study, published more than 15 years after the ARSNet study, looking at patterns of care for patients with ARDS in intensive care units in 50 countries around the world. And what did they find? 15 years after the ARSNet study, fewer than 2/3 of patients with ARDS received a tidal volume of less than or equal to 8 mLs per kilogram of predicted body weight. And the plateau pressure was measured in fewer than half of the patients, less than 40% of the patients. So if you believe that we should use a plateau pressure of less than 30 centimeters of water, as I talked about 2 days ago, I guess now, and others have talked about at this conference, how are you going to know if the plateau pressure is less than 30 if you don't even measure it? So this is 15 years after the ARSNet study, and often when I show this slide in lectures, I will say, shame on all of us. We have compelling data and we don't implement it into our practice. We also have other compelling data to show us that less is more. So less is more as far as tidal volume for ARDS. less is more as far as the use of non-invasive ventilation, ventilation with a face mask rather than with an endotracheal tube. And we talked about this in several lectures. I did a workshop on this yesterday. So non-invasive ventilation, another example of less is more. You can see for a variety of conditions in this paper published 10 years ago now, the number needed to treat, which I have in the red box, is only a few patients in order to save a single patient's life. So we only need to treat a few patients with COPD exacerbation using non-invasive ventilation in order for a patient's life to be saved. I actually was invited to write the editorial to go with this meta-analysis. Again, I thought I chose a clever title for this editorial. The evidence is in, non-invasive ventilation saves lives. I could have entitled this editorial, The Evidence is in, Less is More. And Emily gave some good examples earlier this afternoon about less being more. Another example of less being more is high-flow nasal cannula. We've heard a lot about the use of high-flow nasal cannula, including a very good talk by Brady Scott earlier today. So just as non-invasive ventilation can be very beneficial in patients with hypercapnic respiratory failure, high-flow nasal cannula can be very beneficial in patients with hypoxemic respiratory failure, and we actually have good clinical practice guidelines to support the use of NIV as well as high-flow nasal cannula. So what have I learned over the last 50 years? Well, I learned a lot of things. I tried to share a few of them with you here this afternoon. So don't substitute one unproven therapy for another. So when one therapy is shown not to be beneficial, don't just slide in something else that may be equally not beneficial. New is not necessarily better. So just because a ventilator comes out with a new mode doesn't mean that we should all buy that ventilator and incorporate that mode without sufficient evidence to show that it improves patient outcomes. Beware of physiologic endpoints. Beware of the seduction of the pulse oximeter. So just because we can make the oxygen saturation better doesn't necessarily mean that will be better for our patients. And sometimes less is more. Lower tidal volumes, non-invasive ventilation, high-flow nasal cannula. So what about the next 50 years? Well, certainly respiratory care practice will continue to evolve. No doubt about it. I'm not going to be around to see the next 50 years. Hassan's not going to have me back in 50 years to talk about what I've learned in the first 100 years of being a respiratory therapist. Pretty sure that's not going to happen. But respiratory care practice will continue to evolve. And I would encourage all of you to adapt with the evidence as soon as it becomes available. So when evidence becomes available that shows that what we're doing is not the right thing to do and there's a better way of doing that, we should adopt that. Change is inevitable. Certainly embrace that. And I am sure that patients appreciate that we do not apply what we did 50 years ago to our practice today. So with that, I will stop. I will thank you for having me here. It was great to spend a few days with all of you. And I believe this might be the 5th time that I've been to Saudi, something like that. And everyone is better than the previous one, and this has been better than the other. So with that, thank you very much.
Thank you very much, Professor Dean Hiss, for sharing your more than 50 years of life experience in our profession.
Keep it. Dean Hiss, you almost made me cry. Really. But we wish to... Yeah, very true. But thank you so much. Thank you so much. I have a few items to discuss before everybody goes. Thank you for all our speakers who finished today's excellent presentations. The first, I would like to remember in the beginning we said we will have Best Abstract Award, and that was done yesterday, the top 10 abstracts. But today we will have the Best Abstract Display Award. And for the past 3 days, many of our visitors went around, and I assigned certain people to go around and just to look, without the science, just to look at the right display. Because we made very specific guidelines on how to post and what's the most professional. So I have a list, actually, and many of them, in fact, many, if not all of them, are excellent, really. You should be very proud. Anybody who displayed an abstract should be very happy and should be very proud. However, and fair is fair, again, sent a few people to go around and take pictures of the, in their mind, the best abstract display. The looks, the structure, the fitting, and everything. And ironically, we have many of them pointing to one or two, actually three. And many of them are the same. Many of them voted for the same abstract. So I'm going to go with the top 3 votes. Number 3. Okay, this is the top 3. I have been to AARC and I have been to ERS. This is top quality. This is the people who got number 3. Let's have number 2. 3 of them. Top science, top structure. Not to mention the science itself, but the looks is so nice. So thank you for all the people who did that. Now to the top 1. Okay. We have actually 4. Again, they don't know about each other, each one from different institutions, but you can see the quality, obviously, everywhere. So thank you for all of those. We will provide you with certificate. Actually, the certificate, we have it for the best display for each one of those. Thank you very much. Now, remember in the beginning we said we have best spirometry blow. And yes, indeed, we have a few people, not a few, many, stopped by NDD. Thank you, NDD, for offering your spirometer and your disposable whistles. And we have 2 winners. Of course, we said top for female and top for male. Female, Aljuri Jarayan, is she here? Aljuri. Okay, stand. Here she is there. Very good. Thank you very much. And we have Jassim Al-Arbash. Where is Jassim? Here he is. Good. Excellent. Thank you very much. Thank you all for all who tried, but physics sometimes win. Now, this booth. One of our rules to all the booths is you must have an attractive booth, you must have it orderly, you must have giveaways, and it must be professional, because this is not for me. It reflects in the profession, it reflects in the conference, it reflects on our guests and everybody. So again, many, and this is based on certain votes, and also remember the sheets that we separated, people circulate. So we have a number of them, and Again, ironically, there are 4 who have the same number, same votes as the best. And 1 exceeded them by about 4 or 5. So can you put all the pictures? No, one by one, okay? Thimar Al Jazeera, Al Bayt Al Arabi, Vital Air, and POS. That's it. How many of those? 4? 4? 4, okay. So the top 4, we have those. So number 2, or basically the gut number 2 is POS. Next one. Next one. That's number 2 again. One more. Number 2. There are 3 number 2s. They got the votes. And of course, Vital Air got the best in looks and everything, professionalism. So with that, we close with this. Okay, remember in the beginning we gave the sheet for all the attendees to stamp, 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 stamp. We have so many, and some of them stamp half of it and hand it. So one of the rules, it has to be all filled and stamped. So Noura have them, and what I will do, I will just draw one. So you can just put the face down, and I will just pick one, all of them. I have no idea. I'm just gonna look in here, and I will pull one. One of the rules, this person should be in the audience. Kauthar Al-Matar. Al-Matar? Is she here? Kauthar. Kauthar. 2, 3, 2, 1. Kauthar is not here. Sorry. Zainab Riyad Al-Uraybi. Is Zainab here? Zainab, you are here? Please come. Yeah, she has. Super. All the companies are stamped here. And guess what? Her number is not even from Saudi. Zainab Riyad Al-Uraybi. And you are from where? She's from Bahrain, our neighbors. So thank you very much. Thank you very much. This is souvenir for you. And this stays in my pocket. Let me get I have 2 things here. You can select. There's an envelope and there is a wallet. Which one you want? Here you go. Thank you very much. The amount is $550. Did you register in any of the courses? The adult? You register for the adult? Just attendees. Anyway, she got what she paid 4 times or 5 times. So thank you very much. Thank you. Go back to my cheat sheet. Okay, so we're done with the grand prize. The CMEs, after we leave this, there are multiple sheets outside, or many sheets. You can just fill your name and fill the details so we can give you the CMEs, and it's 26 CMEs. Also, if you are also acquiring or needing CRCEs, this one you need to communicate with us via email. We will get all the details you need, your AARC number and all, and then we'll submit it all at once to the AARC. Okay. I would like to thank all who attended, all who made the effort to come from different places. We made more than 550 books and lanyard and bags. They are all gone the first day, unfortunate. So we printed more and we presented. So I'm assuming our attendees is more than 600 for sure, in and out. Also, interestingly, during the البث المباشر, live streaming, the only platform that we can tell how many are watching is the X. And the last one, just about 15 minutes ago, was about 580 watching in the same time. Not to mention YouTube, LinkedIn, and the Facebook. So that's very good attendance. So we are very happy and with the results. I would like also to thank all the people who submit abstracts. This is very important. The Al-Hirak is very important for us all. I would like to thank our faculty, all the people, all the faculty, the international who came from their home, despite the very long flight and the very long layover in certain city. So thank you very much for your time and effort. I would like also to thank our local faculty and all collaborators from different departments. We have almost every department in the kingdom, either clinical department, clinical services, or programs. So we are very delighted to have you all, and we thank you for every effort you have made to encourage and to distribute the word. Okay? And two institutions I would like to thank. Number one, Al-Mana. Al-Mana, without them, Al-Mana College has been very forthcoming and have been very helpful. This exact auditorium, we are so happy to be in this place. So nice, so elegant, and everything. The other one, and specifically from Al-Mana, there are three individuals I would like to thank. Or actually four. Salma Al-Qahtani from public relation, and also Fatima Al-Mas'ud, she is in charge of AV. And also I would like to once again thank Sukaina and Mustafa for their help. And I would like to thank Al Faisal University. They have been our first host. And they are, until now, they did our CMEs and they are doing the accounting for us. So we thank them, specifically Dr. Al-Qattan, Ms. Fatin Al-Khatib, and Mr. Adil Ghannam. Thank you. Okay. And I would finally, before we go, we cannot do any of that without our sponsor. So big, huge thank you to all the sponsors who participated this year and wishing for the next years. Before finally, I would like to thank my friend, colleague for 1,000 years. We have been together. He has been very supportive in ideas and expertise. We did this course together for the past 10 years, and finally we are seeing our baby can walk. So thank you, Dr. Sullivan, for your support. أخيراً وليس آخراً, حقيقة, excuse me, I'll have to say it in Arabic, it's more expressive. كل الشكر والتقدير لحكومتنا الرشيدة. Without, من دونهم ما وصلنا إلى ما وصلنا إليه من علم وتشجيع للعلم وتشجيع للإكسبرتيز وتشجيع للكواليتي هيلث كير. فنحمد الله كل الشكر لرب العالمين أولاً، ثم لحكومتنا الرشيدة على خدماتها. الجميع منا هو اللي سافر وراح كله على حساب الحكومة. الحمد لله، هذا من فضل رب العالمين. فالشكر حكومتنا الرشيدة، ملكنا الملك سلمان الله يحفظه، وإلى ولي العهد عراب رؤية 2030. كل الشكر للجميع. فشكرا لكم جميعا. في هذا نختتم هذا المؤتمر، وإن شاء الله لنا لقاء سنوات قادمة.